morning, everyone, and a very warm welcome from us and the whole of the airline team here at the North East Obstetric Anaesthesia Meeting 2022. We're delighted to have you join us here today. I'm Danny Morland. I'm a consultant anaesthetist working in the Royal Victoria Infirmary here in Newcastle, and alongside me here is Jen Hooper, who's a senior anaesthetic registrar also here in the North East.
Good morning. This event is hosted by A-Line Anaesthesia Learning in the North East and kindly sponsored by Peri-partum. We're hosting our meeting today from Holt's Yard, which is a repurposed industrial building, previously home to Tyneside Pottery. It's now a buzzing site for new business in the heart of Oosburn, but we're just 5 minutes from Newcastle city centre.
We do have a wonderful tech team here on site supporting us today, but they're also just NHS workers who happen to have a part-time enthusiasm for technology. So please bear with us if there are any technical glitches. We apologise in advance for any hiccups that may occur during the course of today. But we are delighted to have so many of you registered for this event today. This is our second North East Obstetric Anaesthesia meeting, and after the success of last year's half-day event, we've expanded our efforts and we're excited to bring you a full day's worth of presentations today. The aim of Neoam is to bring together ideas and share best practice amongst those with an enthusiasm for obstetric anaesthesia, both here in the North East and across the UK.
We've got a packed programme here for you today, including 4 invited speakers, Dr. Fiona Pearson and Dr. Katie Cranfield, who both live and work here in the North East. We're also lucky enough to be joined from further afield by Professor Nuala Lucas from down in London and Dr. Kailash Bhatia from the North West. We're really looking forward to these presentations. They'll be spread throughout the day, interspersed with some brilliant presentations submitted by trainees, specialty doctors and clinical fellows from across the country, covering a nice wide range of improvement projects and some case presentations. Just a couple of housekeeping bits before we get underway this morning. We have got a packed schedule for you today, but don't worry, there will be some pauses for tea, coffee breaks and lunch breaks throughout the day, so nobody's going to get too dehydrated. After each presentation this morning, there will be an opportunity for questions. So if you've got any questions at all, please submit them by the Q&A box, which you should be able to see at the bottom of your screen. Please try and keep those questions as clear and concise as you can, and make sure we know who they're addressed to. There is the chat function available. Feel free to use that to communicate with the other attendees, but bear in mind any of the questions on that won't actually reach us as hosts, so keep the Q&As on that bit for us, please.
It would be really wonderful to start off with getting an idea of where everyone is joining us from today, and it will also give us a chance to practice the poll function that we have. So you should see the poll available on your screen just now. So click away on that. Now, we will be using this poll function throughout the day to allow you to give a score for each of the submitted presentations. Now, these scores will help us determine the awards that are given out at the end of the meeting. So we'd be really grateful for your input on these polls when they appear throughout the day. Do we have the poll results yet?
Okay, so they're just coming up on our screen. That's great. Everybody had a chance, I hope, to work out where that function is on. Unsurprisingly, most of us from the North East, which is lovely to see.
37%, not bad.
We've got a really good spread throughout the country there. From down south, got Kent and London there, quite a number from North West and Humber, Midlands, South West, Wales. Nobody from Scotland yet. If there is anybody from Scotland that hasn't done their poll yet, please do make sure you represent yourselves. That's lovely. Great. Well, it's very nice to see you all here today, and I hope everybody has got the hang of that poll function. We will be using it for the presentations and would really appreciate your input there. Danny, I'll hand back to you.
So that's our housekeeping done, and we are now delighted to introduce you to our first invited speaker for the day. Dr. Fiona Pearson, trained here in the North East and is now a consultant anaesthetist at Sunderland Royal Hospital here in the North East, with a special interest in obstetrics and environmental sustainability. Fiona served a term as a trainee representative for the Obstetric Anaesthetic Association, and as part of that role, she was a member of the National Maternity Carbon Emissions Working Group and has published several articles relating to nitrous oxide and the environment. With this in mind, she'll be talking to us today about the carbon footprint of obstetric anaesthesia. Fiona? We can see you and we can see your slides, so over to you.
Brilliant. Morning, everyone. Thank you very much for inviting me to kick off the meeting, discussing the carbon footprint of obstetric anaesthesia. As already mentioned, I'm a consultant at Sunderland Hospital, And in my previous role as the OAA trainee rep, I was a member of the National Maternity Carbon Emissions Working Group. I'm by no means a climate change expert, but I've learned a great deal from others along the way, and I hope to share some of that with you today. So what I'm hoping to cover is to explain briefly what a carbon footprint is, why environmental sustainability is important, what the obstetric anaesthesia carbon hotspots are, and how we can look at improving environmental sustainability in obstetric anaesthesia. If you've got any questions from things that I say, please feel free to submit them on the chat and I will do my best to answer them at the end. So why is this important? Well, these are the warming stripes designed by climate scientist Ed Hawkins. And essentially it's a climate timeline. So it shows the continued heating of the planet. And as you can see, it's getting much, much hotter. Now, the climate emergency is a global health emergency because these rising global temperatures are resulting already in extremes of weather. Over time, sea levels will continue to rise, and this is going to impact on our water and food supplies. Between 2030 to 2050, we're expecting to see 250,000 additional deaths per year as a result of this global warming. So to tackle climate change, the NHS has set out its plan to deliver a net zero NHS by 2040. So that means reducing emissions that we control directly, which is referred to as the NHS carbon footprint, by over 6 megatons of carbon dioxide equivalents. Now, anaesthetic gases make up 2% of the NHS carbon footprint. So the net zero plan specifically describes transforming anaesthetic practice to reduce emissions from anaesthesia by 40%. So just to briefly explain what a carbon footprint is. Essentially, it's the total greenhouse gas emissions generated by something that we do. We use global warming potential to compare different greenhouse gases. Carbon dioxide is always used as the reference greenhouse gas, and the global warming potential is a measure of how much energy the emissions of 1 ton of a gas will absorb over a given period of time, relative to the emissions of 1 ton of carbon dioxide. You can calculate the carbon dioxide equivalents from the global warming potential, and it's essentially the mass of carbon dioxide emissions that would have the same global warming potential as an equivalent mass of a different greenhouse gas. So why are we looking at labour analgesia? The environmental impact of desflurane is commonly discussed, but it actually represents quite a small proportion of the CO2 emissions from anaesthesia. As this pie chart shows, in 2017, desflurane only attributed 17%. Compare that to 30% in maternity nitrous oxide emissions. So that actually equated to 157,000 tonnes of carbon dioxide equivalents. And if you looked at all the live births in that one particular year, that would mean for each live birth, it's 250 kilograms of carbon dioxide, which is like driving 1,500 kilometers in an average car. So where are we using nitrous oxide in maternity? We use it in obstetric anaesthesia for both general anaesthesia and as analgesic. And we use it for labour analgesia, usually 50-50 mixed with oxygen under the trade name Entonox. So to learn more about how it's used in maternity, we sent out an OAA approved survey to all the OAA members, asking questions about use of nitrous oxide and scavenging. And we received just over 400 responses. First of all, asking about use of nitrous oxide for obstetric general anaesthesia. It was used by 84% of respondents. 44% said that they would always use it. So that's nearly half of our obstetric anaesthetists would always use nitrous oxide for an obstetric GA. There was a variety of reasons given for this. The second gas effect, analgesic benefits, reducing risk of awareness, and also reducing your volatile concentration, which would have beneficial effects for the neonate and uterine tone. Now, we know that obstetric GA is a major risk factor for accidental awareness, and the overall incidence from the DREAMY study was 1 in 256. It does often incur induction of anaesthesia, and nitrous oxide can obviously shorten the gap between IV induction and onset of inhalational anaesthesia. And one of the recommendations of NAP5 was to consider the use of nitrous oxide for obstetric GA for that reason. But DREAMY didn't actually find any association between accidental awareness and use of nitrous oxide. I suppose a potential alternative could be the use of TIVA, And we did also ask about this in the OAA survey. But what people commented was that there was issues around particularly time to set it up, given often the urgency of an obstetric GA, and also concerns around the fact that the pharmacokinetic modelling hasn't really been done on pregnant women. So what about use of nitrous oxide for analgesia in obstetric theatres? So this would be where you've perhaps got a lady that's labouring and you're trying to incite a neuraxial block, or if you've got a lady having breakthrough pain mid-procedure. So 90% of respondents said that they would use nitrous oxide for analgesia, and pretty much all of them said that they would use it from the anaesthetic machine rather than from a separate Entonox cylinder. And the mean flow rate given for this is 6 litres per minute. So moving on to nitrous oxide for labour analgesia. How often is it used? Well, this CQC survey in 2019 found that it was the commonest labour analgesic used in England. Nearly 80% of women would use Entonox for labour. So what's the environmental impact of that? Nitrous oxide has a high global warming potential and a long atmospheric lifetime. As you know, minute volume increases during pregnancy, and in labour it rises further to more than double resting minute volume. So a 70 kilogram labouring woman would equal, that was using Entonox, for every minute that they were using it in labour, you would have more than 3 kilograms of carbon dioxide equivalents per minute it's used. Now that might not sound like very much, and if you think it's about a 17 kilometres driving distance, but remember that's per minute it's used in labour. And actually 3 kilograms of carbon dioxide equivalents is the same as a 3-hour low-flow sevoflurane anaesthetic. So how does the carbon footprint of Entonox compare to other label analgesics? You can calculate this by using established greenhouse gas emissions factors and life cycle analyses to look at the direct emissions relating to individual components of each form of analgesia. And if you look at the difference between Entonox, remifentanil PCA, epidurals, and intramuscular opioids. Unfortunately, there hasn't been any life cycle analysis on diamorphine. So morphine was used for the calculations because actually in a lot of parts of the world, they don't have diamorphine, and intramuscular morphine is commonplace. So what you find is that even taking into account all the plastic and waste associated with your PCAs and your epidurals, the carbon footprint of Entonox is still over 200 times greater than all the alternatives. And this is using Entonox intermittently for 1 minute per contraction if you were contracting 3 in 10. So you can imagine if a woman's using it continuously, this would be much higher. And that 237 kilograms of carbon dioxide equivalents is about the same as driving 1,400 kilometers. So what can we do about this? The Centre for Sustainable Healthcare described these 4 principles of sustainable clinical practice: prevention, looking at low carbon alternatives, trying to improve our service delivery, and empowering our patients. So disease prevention and health promotion for obstetric anaesthesia isn't that straightforward. I don't think many women would be impressed if we called pregnancy a disease state that was preventable. But good antenatal care may help to prevent pregnancy complications. If you think that an obstetric GA will undoubtedly have a higher carbon footprint than an obstetric procedure done under neuraxial block, perhaps working to avoid GAs when they're unnecessary could help to reduce the carbon footprint. I think reviewing patients anaesthetically, antenatally, could also reduce unnecessary general anaesthesia, particularly women that have had previous spine surgery. That doesn't necessarily preclude neuraxial blocks. And when we come to managing ladies in labour, it's important that we monitor and manage our labour epidurals so that we can resite any problematic ones early. And this might end up reducing Entonox use and also reducing unnecessary general anaesthesia. So moving on to low carbon alternatives. We know that epidurals and remifentanil PCAs provide superior analgesia at a fraction of the carbon footprint. However, they're also not available in all birth settings, and they may be contraindicated in some patients. So are there any alternatives that could be suitable for midwifery-led care? So some people may have heard of methoxyflurane. It's a volatile agent that's used for management of acute pain and procedures. It's commonly delivered via one of these Penthrox whistles, and each whistle contains 3 mils of methoxyflurane. Methoxyfluorine has a far better global warming potential of 4 compared to 265 for nitrous oxide. So one whistle is such a fraction of the amount of that of any of the other labour analgesics. But the problem with methoxyfluorine is that high doses cause nephrotoxicity. So because of that, they've set a maximum daily dose of 2 whistles. Now, in a labouring woman, a whistle would probably only last between 30 to 45 minutes. So as you can see, you're not going to get a very long duration of analgesia using Penthrox. However, it may be useful for shorter procedures, for example, repairing perineal repairs, or for providing bridging analgesia while you're trying to do something else. So there's actually an observational study of women who were having an epidural inserted, and they were given Penthrox whistles while they were having the epidural put in. And what the researchers found was that the methoxyfluorine reduced pain scores and restlessness during epidural insertion. So it's definitely a possibility, but more research needs to be done to assess safety. What about using the birthing pool? So you may have seen in that CQC survey I showed earlier, nearly 20% of birthing women that delivered in that particular year used the birthing pool at some point during their labour. So what's the carbon footprint of that? So to work that out, you need to know what the capacity of the birthing pool is, and you need to consider supplying the water, heating it, and then treating the wastewater. Now, the carbon footprint of that would very much vary depending on what sort of heating method you're using. But if you're using a domestic boiler, then the carbon footprint of that would be 4.5 kilograms of carbon dioxide equivalents, which is the same as 1.5 minutes of Entonox use. Now, in reality, the carbon footprint of using the birthing pool would be slightly higher, because obviously over time the water will cool and you'll need to top it up. But still, you can see it's far better than using Entonox for a prolonged period of time. What about low carbon alternatives for our neuraxial analgesia? So let's think about how we test blocks. Many clinicians would use ethyl chloride spray to assess cold sensation. Ethyl chloride spray is actually designed for topical local analgesia, not to assess cold sensation. It's a hazardous substance, it's expensive, so each can of ethyl chloride spray costs about £20, and it's obviously not licensed for assessing sensory level. Could there be alternative methods to test? Well, there's generally a lack of consensus on this, and OAA guidance is forthcoming. They say that we should check 2 modalities of block. So should we consider looking at light touch or pinprick sensation or a different cold stimulus? Because the biggest problem with ethyl chloride spray is that it actually contains fluorinated greenhouse gases with a very high global warming potential. So each can contains 195 kilograms of carbon dioxide equivalents. That's just the actual stuff in it. But then you need to consider about the packaging of it, transporting it to where it needs to be used, and also disposing of it. So as you can see, it soon adds up. So you may want to consider a different cold stimulus if you want to keep assessing cold. Some places would use a freezer and have little ice blocks in the freezer. But as we know, freezers aren't available in all clinical areas. So there is another alternative if you want to assess cold sensation, which are these cold metal sticks. These have the advantage of just being able to be stored in a fridge. They're reusable, so you just clean them like you would a blood pressure cuff between patients. They've already got MHRA approval, and each stick, it would be, once you've used 3 cans of ethyl chloride spray, the stick has already paid for itself. And these have been tried and tested already in Royal Bournemouth Hospital. So they used it in theatre recovery, where they were initially using 6 cans of ethyl chloride spray a week. And over the course of a year, that was more than 5,000 kilos of carbon dioxide equivalents. After they introduced the metal sticks, they pretty much saved all of that. And that was just for use in recovery. And not just the carbon saving, but that also resulted in a cost saving of nearly £5,000. And that was them just using it in recovery. Could you imagine what would happen if you rolled that out to other areas of the hospital, and in particular the delivery suite? What about lean service delivery? So let's think about capture and destruction of nitrous oxide. So there are devices that are capable of catalytically breaking down nitrous oxide into nitrogen and oxygen. What you have to do is obviously you have to administer the nitrous oxide and then have some way of capturing it. So you either need the patient to form a good seal with a mouthpiece or use a face mask and again create a good seal with that. There's different units capable of doing this. So this might be a mobile unit that stays in the room and that doesn't require any central scavenging, or a central destruction unit, which can manage much higher levels of nitrous oxide. So it would be able to deal with a whole delivery suite. But in order to do that, you have to have some sort of central scavenging system. Now, when we did that OAA survey, 80% of respondents said that they didn't have any scavenging in their delivery rooms. So that would be a major problem with it. Another problem is obviously, in order to do it, we need to train our patients in the technique. So like I said already, you need to have a really good seal. And Cliff Shelton and his colleagues down in Wythenshawe have been doing quite a lot of work on this. And they actually fortunately had a patient who was an anaesthetist that was labouring and agreed to use the system. And what they found is that the capture rate, even with sort of the ideal technique possible, was probably only about 50%. But even if you can capture 50% of the nitrous oxide, these units are capable of destroying about 99% of it. So if you can imagine, halving the amount of carbon footprint from Entonox use would be such a huge difference. And these have been very successful in Sweden, where 84% of carbon emissions from anaesthetic gases were from nitrous oxide use. They installed nitrous oxide destruction systems, and their carbon dioxide use fell by over 3,000 kilograms per year, which is amazing. And this is why these have been specifically mentioned in the NHS long-term plan. So if we installed nitrous oxide destruction in the UK maternity units, you could cut over 1/3 of the anaesthetic emissions. And that would save over 90 kilotons of carbon dioxide equivalents, which would be brilliant. But as I've said, there are problems with it with regards to training the patients to use them, and whether you're going to invest in small mobile units or you need to invest in scavenging for central units. I would really like to see scavenging in delivery rooms because we know that exposure of nitrous oxide to staff is also an issue. What I think needs to happen is that NHS England needs to provide funding for these units and support trusts in installing them. What about lean service delivery for other aspects of obstetric anaesthesia? The pandemic's very much changed the way that we deliver some aspects of our care. So in 2019, patient travel contributed over 1 megaton of carbon dioxide equivalents. I think we've now realised that a lot of appointments don't actually need to be done in person, and we could do some of them as telephone appointments. Another thing that would help would be combining both anaesthetic and obstetric high-risk clinics so that a patient can attend both with just one hospital visit. Anaesthetic gas scavenging is worth a particular mention in obstetric anaesthesia, where the majority of time our anaesthetic machines aren't in use. It's completely pointless having the scavenging using hospital power all of that time. It would be far better to have it switched off and then turn it on when it's actually needed. For those situations when we do need to give an anaesthetic, a general anaesthetic, it's really important to reduce our gas flow rates as early as possible. And there's a really good app available by the Association of Anaesthetists that uses calculations done by Tom Pearce. And this over on the right is what you see on the app. So you can basically dial up how much your oxygen and air is and what your sevoflurane concentration you're aiming for. And it will tell you not only the cost, but also the CO2 equivalents of that. We also need to think about waste in systems, and that's waste from both use of Entonox and also other analgesics. Administration of nitrous oxide. Think about how we're going to administer that. So if you're giving it in theatre for analgesia, I would very much urge you not to give it through the anaesthetic machine. It's a patient safety issue because you might potentially leave your vaporizer on and deliver a general anaesthetic to the patient. The other issue is that the nature of labour pain is that it's intermittent. So it makes no sense at all to have a continuous flow of nitrous oxide into your theatre when the patient's only experiencing pain about 3 in 10. And what about nitrous oxide waste? So work led by Alethea Chikera in NHS Lothian has demonstrated that huge volumes of nitrous oxide is being lost through delivery systems. At one hospital site alone, over 650,000 litres was being lost, equating to 300 tonnes of carbon dioxide equivalents. These can be due to leaks from pipework or manifolds and Schrader connections. And case studies of Entonox have shown similar volumes of waste. There's also the issue of Entonox remaining in cylinders when it's returned to BOC. So European legislation says that this has to be vented to the atmosphere prior to the cylinders being refilled. And as you can imagine, all that nitrous oxide, so even a 3% waste in a size G cylinder would be about 70 kilograms of carbon dioxide. That's like driving 400 kilometers in a car. So Medclaire, who are one of the companies that make catalytic destruction methods, are currently working with BOC to try and solve this problem. But one way we can help is by not having waste in our cylinders when it's returned to BOC. So how are you going to assess for nitrous oxide loss? So you need to do a bit of detective work. Check what's been done already in your hospital and get a team around you. So you need to involve your pharmacy department and your estates department. They will help you, and by interrogating the manifolds, you'll be able to work out what your actual usage is in the hospital, and then you need to quantify that against your clinical usage in each area. There's a really good audit form that Alethea and colleagues have done, which is available on the Association of Anaesthetists website. This helps you to be able to do this nitrous oxide project in your hospital. How do you know if waste is occurring? So if your audit reveals that you're not using any, but you're still going through some in the manifold, clearly you've got a problem somewhere. If your manifold turnover is far higher than your clinical usage, that's also telling you that you've got leaks somewhere in the system. What about looking at other aspects of labour analgesia? So although the carbon footprint of remifentanil, epidural and morphine are far lower than that of Entonox, we can obviously look at ways of improving sustainability in those aspects as well. So in order to do that, it's helpful to look at what made up their carbon footprint. And as you can see, for all the other options, the biggest issue is the single-use items, the disposables, and also waste. So let's stop and have a little look at what's in our neuraxial block packs. So if we look at this particular pack, does that dish need to be plastic? Probably not. It could easily be made from cardboard or something more eco-friendly. Do we need a gallipot anymore? No, because we no longer pour our chlorhexidine into that. We could easily just remove that from the packs. If a gown is in your pack, it's important that you're aware of that so that you don't then open up a second gown. So this is where it's really important that we actually work with suppliers of our packs in order to reformulate them and streamline them to avoid waste wherever possible. So how can we reduce the impact of other labour analgesics? So actually, when you look at all the carbon footprint of an epidural, the single greatest contributor to the carbon footprint is the disposable sterile gown. And we know that life cycle analysis has said that reusable sterile gowns have an improved carbon footprint than the single-use items. So we need to look at reusing our drapes and gowns. And there are hospitals that do have reusable items, and that's a far better alternative than single-use. It's also really important that where we do have single-use items, we use the appropriate waste stream. In 2019, the NHS generated over 600,000 tonnes of waste. Hospitals have their own waste stream, and each waste stream has its own carbon footprint, with recycling having the lowest and high temperature incineration having the highest. So what we put our waste into is another thing that matters. You need to think about whether we can use reusable waste bins, for example, the Smart Sharp bins. These go off, are emptied, washed and reused, so that saves the incineration of that massive plastic. Or there are environmentally friendly alternative waste bins, like bio bins, that are made from a more eco-friendly material. And moving on to patient empowerment. So I think the general public are becoming much more aware of environmental issues. New parents are opting for reusable wipes and nappies, but they're often completely unaware of their environmental impact of their birth choices. So I'm really proud to be working alongside Labour Pains to provide information for expectant women about the carbon footprint of different labour analgesic options. And this is kind of one of our prototype images for the leaflet, which will be alongside the different forms of analgesia representing what the carbon footprint of each is. And I hope that by giving women this information, they will be able to make an informed choice about their labour analgesia. So it's really important that we're not removing patient choice, but that we're empowering patients to make a choice that's right for them. So in summary, the carbon footprint of obstetric anaesthesia is far greater than that from desflurane. And the biggest contributors are nitrous oxide, ethyl chloride spray, and single-use items. Where we can make the biggest impact, well, nitrous oxide is the biggest contributor. So think about reducing waste. If you're giving it in theatre, give it via demand valve. And I find that's practically quite an easy thing to do. You just get a little Entonox cylinder. Often the woman comes from the delivery room with her own mouthpiece, and you can just deliver it through that. You need to start looking for manifold and pipework leaks. And I'd recommend that if the nitrous oxide project hasn't been undertaken in your hospital, that you look at doing so. Use nitrous oxide judiciously by educating patients and staff, and consider or offer alternatives. And then, as I've already mentioned, I think it's so important that we need to invest in scavenging and catalytic conversion. When it comes to other methods of labour analgesia, please reconsider using ethyl chloride spray to test the block. And remember to reduce, reuse, and recycle wherever possible. So it's a lot to think about. Where are you going to start? Obviously, education. So hopefully you've learned something today that you'll be able to take back and share with your trust. Small behaviour changes can actually make a big impact. If people see you doing small things, it will soon follow on. Engage your workforce so people have a wealth of ideas, and it's worthwhile actually seeking opinions from other people. And nominating a departmental lead can really help lead with that. And network with other trusts. So there's so much great work being done, both in the UK and overseas. And there's so much that we can all learn from each other. Thank you.
Excellent, Fiona. That was really good. We really appreciate that talk. That I've heard before in some bits again, but that was as a package, it's very educational. From my point of view, so just to reiterate, if you wouldn't mind, just your summary slide at the end, Fiona, like what is the biggest impact? To me, it came across there about that kind of nitrous destruction, technique, that working on labour ward, that seems to have had the biggest impact. What was your opinion about that?
Yeah, so we're not going to be able to get rid of Entonox. And the trouble is, NICE guidance is currently that it has to be available in all birth settings.
Yeah.
And yeah, patient choice is very important. So it's not going to go away, but we need to look at how we can use it in a way that's environmentally friendly. And to me, the easiest way of doing that is using these devices that we can then crack it into nitrous oxide and oxygen. Yeah. But as I say, the problem is the cost of these devices. And you're either going to have to get multiple mobile units, and also the size of them is a bit difficult to fit in delivery rooms because it is quite big and it just depends on the size of your delivery room. So you need to consider that. And you also need to consider about, the cost of that versus the central destruction unit. So if you're going to have a central unit, you need to have scavenging in delivery rooms. And we know that most UK units don't have that. So it's where if you are doing any sort of redevelopment of your delivery suite, you need to engage with the states and try and get them to put the scavenging in now so that we're future-proofing it. Because I think in the future, these will be mandated. It's just very much, we're currently riding the start of the wave. And obviously the RVI had its first, they were the first UK unit to have a nitrous oxide capture delivery back in September. And then they've been followed by Scotland in November. And there's now multiple UK units that are all trialling the Medclaire system, but they're all, as far as I know, trialling the mobile unit. Yeah. And I don't think any of them have got a central unit yet.
One thing we were just discussing was the idea of wanting to not take away patient choice, but also not make people feel sort of guilty about asking for certain analgesics. And sort of taking, yes, if patients don't know the effect of nitrous, would they be less likely to use it? Do you have any thoughts on, well, both the ethics, but also how we could approach that sort of patient and perhaps midwife education around the use of Entonox without making people sort of feel more guilty about their birth choices?
Yeah, it's very difficult. As you can imagine, I'm trying to write the information leaflet at the moment for labour pains, and it's very difficult to get the wording right because you're right, we don't want to guilt trip women at a time when they're already very, very vulnerable. And I think it's about saying to them, look, there are alternatives that you may find provide better pain relief. And if you want to use nitrous oxide, then ideally use it for the shortest amount of time when you need it. So when you're not having pains, take the mouthpiece out of your mouth and stop using it. don't let your partner have a try of it mid-labor. It's just about using it sensibly, isn't it?
Yeah.
Thank you.
We do have a couple of questions from the audience as well. The first one is actually, if you wouldn't mind, just repeat. So one of our attendees has asked, what is the name of the app that you mentioned that to calculate the CO2 emissions against the anaesthetic gas flows, etc.?
So it is, if you go on to, it's like Anesthesia LM, I think it is. I'll try and find the link and post it on the chat. But yeah, when you open the app, it looks like, you might not be able to see. Yeah, but it is a really good app, and you can just literally sit in your case and have a little look. Right, so I'm using this vaporizer, and it's quite good fun just to see what difference your flow rates can make.
Yeah, great.
But yeah, the fact that a minute of Entonox is like 3 hours of low flow sevoflurane, I think really hits at home.
Yeah,
that hits at home to anaesthetists. And what I find really works with midwives is when I tell them a minute and a half of Entonox is like the same as the birthing pool. And they're like, gosh, wow.
One of our other attendees has asked, does using low flows of oxygen to reduce anaesthetic gas consumption affect the CO2 footprint of using more of the absorbent, CO2 absorbent?
So it very much depends on what it is that you're using. So if you're using sevoflurane, then if you're going to use high flow of oxygen, you're going to be using more sevoflurane, so it would negate it out. If you're doing TIVA, then yes, there was a paper out maybe 18 months ago now, looking at fresh gas flow rates for TIVA, and they recommended a fresh gas flow rate of 6 litres per minute. So if you're doing TIVA, 6 litres per minute. If you're using any sort of vaporizer, then you want to go low flow.
Got it. Do we have any more questions come through?
Well, there you go. Somebody said anaesthetic impact calculator. Thank you.
Oh, great. Okay. So thanks for that, Fiona. I think we might move on to our next presentation now.
Okay. Thank you very much, Fiona. So our next speakers this morning are Dr. Radhakrishna, who's a specialty doctor in anaesthesia, and Dr. Sakkaragoudra, who is an associate specialist in anaesthesia. They're going to be talking to us this morning about GA conversion for caesarean section. Dr. Jaishri Radhakrishna is originally from India and worked in India for 3 years. Also spent 3 years working in Oman as an anaesthetist. She's been working in Darlington Memorial Hospital up here in the Northeast since 2019. And she is joined by Dr. Shashidar Sakkaragoudra, who is an anaesthetist who also worked in India for 5 years before moving to Darlington and has been working in Darlington since 2013. He has interests in both obstetric anaesthesia and also regional anaesthesia. Dr. Jaishri, I think you're starting us off today. We can see you, we can see your slides, so I'll hand over to you.
Hello, everyone. Good morning. As you all know, I am Jaishri. I think to join with our previous speaker, I have a review on GA conversions during cesarean section at Darlington Memorial Hospital. So I'm going to discuss it with a bit of introduction and issues with GA conversion and what was our conversion rate in 2018 and 2020, and comparing that with national standards and how we reduced it. And my colleague will join and discuss some action points and discussion about problems about GA conversions and how we dealt with it in our hospital. So in 2017 to 18, there were around 1 lakh emergency cesarean sections, which was carried out in England, out of which 21% was done in epidural anesthesia alone. So successful neuraxial anesthesia conversion is a measure of quality of care because it indicates that there was a working labor analgesia. And second thing is it also decreases the conversion to general anesthetic in obstetrics. So to raise the standards, guidelines was issued by RCOA, and they said that conversion rate for a Cat 1 section should be less than 15%, and to category 1 to 3 should be overall less than 5% respect. So that was the percentage given by them. So in this presentation, I will review what practices we do and how were our numbers and how we got it down. And especially in this pandemic era where we had difficulties with GA conversions and how we dealt with it. And we are looking forward to more suggestions to improve our outcome and quality of care from you all. So the issues was with GA conversion was it's a time constrained environment. There is an anxious patient, partner, and a family associated with it. It's always challenging again to give GA in a parturient. Surgeon loses the chance of trial of labor and may land up into an unnecessary cesarean section. Mother doesn't get to see the baby immediately. And also we have to take special care about presence and control of post-operative pain and side effects associated with the medications like nausea, vomiting, and pruritus. There's definitely some elements of awareness or recall and her capacity to care for her neonate. And of course, we have seen some depression and PTSD associated with this. So when it comes to theatre staff and the team, they are unprepared with PPEs for general anesthetics. So it's always challenge in a difficult airway situation in a remote theatre in an unsocial hour, especially communication with our PPE on. And there is extended theatre recovery in terms of GA recovery and also in terms of extubation. We need extra time to sterilize the theatre as well as replenish all the sources. And when it comes to partner, sometimes it's not explained about GA conversion and its impact. He is rushed out of the theatre, leading to stressful environment as such, and even he or the partner doesn't get to see the baby immediately. So data from DMH, in 2020, we had a GA for cesarean section of around 20, and our conversion rate from regional anesthetic was 6. So the total cesarean sections were 608, 400 were electives, and 208 was emergency cesarean section. And our conversion rate was low as 1.01%, as a GA rate was 3.3. So this says that 14 were straight GAs and 6 was conversion from regional anesthetics. So when I saw the problems, one was a spinal, which is converted to a GA. There were 4 epidural top-ups, which was converted, and a patient had both epidural and then a spinal and then a GA. In 2018, we did an audit to see our conversion rates, and it was 3.9% as compared to the standard national recommendations of 5%. So we thought about many options and how to reduce it, and we came up with a plan. And in 2020, our re-audit showed it was 1.01%. So the data is not very robust to get exact indication of all the cases, but the most common reason was inadequate time to achieve or inadequate block. So after 2018, so we came up a plan with periodically examining the labor epidural working. We did MDTs regularly, and if there is any indication of cesarean section and slow progression of labor, we did check the epidural block and density and bilateral, etc., all those things. And then in the theater, first thing we did was an integrity of the labor epidural. And then if it is good enough, and then we have a magical epidural block, box, which was made by our lead. Following that protocol, it's a standard one. So everybody follows it. And then we start using that protocol. So my colleague will take over. He will tell you what all the problems we had and about conversions and how we dealt with it and how we managed in this pandemic. Thank you.
Shashidar, you're just on mute at the moment. Can you just click on your microphone and we'll be able to hear you?
Oh, yeah.
There we go. We can hear you now. Thank you.
Thank you. Thank you. So good morning, everyone. So my name is Dr. Jaishri. I'm taking over from Jaishri, and I'm going to talk about a few action points which we took in our hospital to reduce the GA conversion rate, as well as to improve the experience of the patient who undergoes GA cesarean section. So we undertake regular education and training of the new trainees, as well as doctors and training coming fresh new to the hospital. And we regularly do our epidural audit review every 2-3 years and see and come out with results. And we take steps to prepare the environment and staff for GA sections, which are becoming less and less common. We conduct regular simulation-based drills for the trainees. And we conduct every once in or twice in a year ultrasound spine workshop, especially for the trainees who are covering the on-social hours to identify the space. And during this COVID time, we are conducting regular GA drills with mock drills, and we continue to review our steps for GA conversions every few years. So as Dr. Jaishri was explaining, when we explain pre-assessment, we had to be, though we explain about failure rate of spinal, we still be explicit about GA conversion. And we also, while explaining, we had to be very sure about patient understand what he can expect in theater, and especially emphasis on how we are going to check the block, what he can feel, the moving and tugging feeling, and also awareness of pressure sensation to avoid, unnecessarily sometimes the patient anxiety results in GA section. And we, based on the feedback, we have found that sometimes partners are not aware. So when we explain pre-assessment, if the partner is around, please explain to the patient as well as the partner that if there is going to be a GA section, cesarean section, that they will see the baby little later than if they had a spinal. This is a very emotional moment for them. So even a few minutes of separation will result in a lot of anxiety. So one of the important steps to avoid a GA conversion, unexpected GA conversion, is to establishing an efficacy of a labor epidural if the patient has an epidural. So when we go for assessment, many times the epidural is done by somebody else during the day or the night. So we may probably not know exact details. So we had to go through the details, epidural charts, how many boluses he needed, what are the pain score. It's good practice to speak to the midwives. You would have spent all day with her, and also speak to the patient. Once we decide that yes, epidural is efficacious and it's working well, if we decide to top it up, then sticking to the epidural protocol or department protocol for top up, and if you're giving spinal anesthesia for drug, whatever protocol, so sticking to it is a very good practice. It will result in better outcome as well as good for auditing. And slowly, most of the category 1 sections also are ending up with the regional anesthesia. So if there is a category 1 section and this regional anesthesia is planned, this ideally should be tried by experienced obstetric anesthetists for a better result. So especially and in the intraoperative period, we must wait for the recommended duration before testing the block. This happens often in a pressure situation where we have chopped up the epidural. Sometimes we try to test the block earlier than required, and resulting in false declaration of failed block. And also, it's very important that we communicate with patient about the steps which are taken to test the block. So patients are in stress, their mind is somewhere. So while testing the block, we must say what he can feel and establish the level of block. And it's a good practice. We all practice it to request the surgeon to test with the tooth forceps before starting surgery, which ensures that patient has surgical anesthesia. And in the event of all this, if there is a failure of regional anesthesia, either spinal epidural, it's important to clearly communicate with the patient about GA, as well as if there is a procedure, to clearly communicate with the patient, as well as surgical team, as well as the whole theatre team. It's a very noisy environment and everyone will be doing their own stuff. So it is very important to be very clear in communication, may rather be loud, to draw everybody's attention so that few minutes of there is more attention to the patient during induction of GA. So in this COVID time, it is useful for the scrub staff and surgical team to wear FFP3 just if there is a GA conversion. And in the event if the patient partner is already inside, if there is, this is big because basically this is based on the feedback we have found that partners are not explained very well. They're just taken out, okay, please. So we must explain, apart from patient, partner also, that there's been a failure of regional anesthesia, and we're going to give put to GA, and he will have to leave. And we have somebody, theatre staff, if the anesthetist doesn't have a time, even the theatre staff can explain this to the partner and make sure that he's comfortable, and he should expect that the baby will be given to him soon after. And it's a good practice to check the block once the patient is alert enough, post GA after extubation, and record the block. And every attempt should be made to fasten the time for the baby to be given back to the mother. And regarding post-op, we regularly, if whenever there is a feasible and whenever the skill set is available, we try and give a tab blocks for a post-op pain relief. If not, ALA infiltration by surgeon would be good enough. And apart from other pain relief methods. And it's good practice to have a debriefing session for every GS after GA section with the surgical team as well as midwifery team to find out what things were done and what things may be done. Every attempt should be made for an early post-op visit for a follow-up by anesthetic team. So the few steps which were taken at Darlington Memorial Hospital to improve the patient care, particularly maternity care during these COVID days, we regularly conduct interactive run through COVID-19 grade 1 LSCS drill. So here we assign roles, we do a fast bleep and do regular, it's like a real-time scenario because there are less and less of GA sections. So particularly trainees and all, they will experience a real-life scenario. And use the DAS obstetric airway guidelines with modification to COVID-19 patient, and it is put on the wall of the theater so that any anesthetist who's there on the site, he can have access to that. And whenever there is COVID patient in the ward, we could have a mini meeting as MDT to plan for us anesthetic management. And we should review our preparedness to deal with COVID-19 patients because we are in the third wave now. So whenever we get no patients, we get used to having no patients in COVID, and suddenly there is a COVID patient. So we do tend to, so we need to review our preparedness to deal with this COVID-19 patient. It's ultimately it's effective multidisciplinary teamwork, and we should communicate clearly, and especially with the PPE guidelines of the trust. So this is a picture of a drill being conducted in a hospital. As I said, every 6 months we conduct drill for trainees and everyone, and each one will get a role like team leader or anesthetist, ODP, so everyone knows what they're doing in a real life scenario. This is a COVID obstetric checklist for atrial intubation. It's a lot of information. It's just copied from the system and then I've just uploaded it. These are the articles which we have taken reference from. And thank you. And this is open for questions. If you have any questions or if you have any suggestions, please.
Thank you very much. Thank you, Shashidar and Jaishri, for a really interesting and useful talk on GA anaesthetics. I think that was a comprehensive talk through covering quite a number of the aspects. We've had a few questions through, a lot of them sort of pertain to the same issue. In terms of your epidural top-up box, people are quite keen to know what's in it and how has that changed from where you were back in 2018?
Earlier, there was a guideline for protocol, but people different, like depending on their experience. Some of them are wearing using 2% lidocaine with adrenaline, some were using levobupivacaine, some were mixing 10 mils of this, 10 mils of that. So finally we have made a box. The box has a 2% lidocaine, 20 mils. It has got adrenaline 1 in 1,000, which we are going to take 0.1 mil. It's got a 1 mil syringe so that we can do just 1 mil. And it's got a sodium bicarbonate solution to add 2 mils and discard it. And of course, fentanyl is it's not there, obviously, it's a controlled drug, but the recommendation is you can use fentanyl. So the box is every time the GA it's used, the ODP replaces with all this, and there is a new box ready. And it's all drawn and it's prepared and it is labeled as well.
Okay. Thank you. Okay, thank you very much, both of you. Could I ask everybody to have a look? The poll should be opening for this talk very shortly. If I could ask everybody to fill in the poll sort of straight after the talk, so if you could do that for us now, that'll be open for a short period after this talk, and obviously we'll look at everything at the end from that. Just a quick housekeeping with the questions that we got for the speakers. If you can try and use the Q&A box at the bottom rather than the chat, just to make sure they definitely get through to us in good time, that would be great. Right, thank you very much.
So our next speaker is Dr. Bunyad Naqvi, who will be presenting on left lateral tilt for caesarean section. Bunyad is currently working as a specialty anaesthetic and ICM doctor in the University Hospital of North Durham. He's been working in anaesthesia and ICM since 2015, having completed his ACCS anaesthesia training in the North East in 2018, and has been in North Durham as a specialty doctor since then. Bunyad, we can see you. I believe we can see your slides, so over to you.
Hello, good morning, everyone. My name is Bunyad Naqvi, and as I've been introduced, I'm a specialty doctor in Durham. So the project I'm presenting today is about the left lateral table tilt during the cesarean birth. This project is led by myself and very kindly supervised by our consultant anaesthetist, Dr. Firas Al-Jalani, who is our obstetric lead at the moment as well. So recently, NICE published, when I say recently, it was March 2021, the NICE published the amended guidelines about the cesarean birth, and in the anesthetic section, in the management of hypertension, along with the pharmacological management, the non-pharmacological techniques they mentioned about.
Bunyad, sorry to interrupt. Can you just put your slides on full screen, please? Thank you.
So in the non-pharmacological techniques, they talk about left lateral tilt, and it states that we should apply up to 15 degrees lateral tilt or appropriate uterine displacement once the woman is in supine position to sort of reduce maternal hypertension. As we all know that the maternal hypertension can lead to some adverse outcomes, both in mother and the fetus, like low ABGAR scores or fetal acidosis. So maternal hypertension during cesarean birth has been, in discussion for a while now, and there's been different modalities, pharmacological and non-pharmacological modalities that's been sort of discussed. So we're going to discuss left lateral tilt and the 15-degree tilt that NICE recommends that it should be up to 15 degrees. The reason we decided to sort of audit, it is basically an audit and a survey as well, because we just wanted to know what individual practices are across our hospital. So the reason we wanted to audit this guideline is that to see if 15-degree tilt is actually achievable. And if it is achievable, then is it safe to do so? So when I started talking about this project, the first question or the first thought that was shared with me by different people is that the NICE suggests it is up to 15 degrees and it doesn't state that it should be 15 degrees. So that was exactly my question again then, that even if the hypertension persists, would we be happy to sort of tilt the table all the way to 15 degrees, or we start considering other options like fluids and phenylephrine or ephedrine boluses, or manual displacement of gravid uterus. So that led to us to design a sort of a short survey and involve different people in our department to tell us about their current practices. So the method we used for this audit/survey was that participants were requested to show us their individual practices during the conduct of anesthesia during cesarean birth. So we used a spare anesthetic room with an operating table in it, and we asked everyone individually to come along and show us what their current practice is. So the picture in here in this slide shows the left lateral tilt. So that was a 15-degree tilt, and you can appreciate that how the tilt doesn't look comfortable, at least to us. So we have all the individual participants coming along to anesthetic room and showing us their individual practices. We use an inclinometer for this purpose. The inclinometer was brought from Amazon, and we did check its consistency and made sure that it is reliable. We did sort of compare it with few digital devices, like few apps on the phone, to sort of compare it and make sure that it's reliable and it is giving us same reading, and it doesn't give us variable readings at different times. And we also designed a short questionnaire and asked few questions from everyone about their individual practice across the during their conductive anesthesia for cesarean section. Regarding the participants, we had 35 participants in total, and we had 15 consultants involved in this. And then we had 12 trainees as well. The trainees were at a different level of their training. All of them were obs competent and were undertaking their duties in obstetric theatres. We also involved a few anesthetic nurses and ODPs, as we feel that they are an integral part of our team and they should be on board with it. And sometimes we ask them to sort of do a bit of a table tilt if we are tied up with something different. So in total, we had actually 34, not 35, 34 participants. And the results, this slide shows the results, and it is very interesting. If you can appreciate, all 34 participants had a variable sort of practice in tilting the table. The maximum tilt we observed was about 12 degrees, and the minimum tilt we observed was about 5 degrees. Only 4 participants had a tilt that was more than 10 degrees. Most of the participants had a tilt which was around 10 or less than 10 degrees. So if we go into the further slides, as I said, maximum tilt we had, it was 12 degrees, and the lowest tilt was 5 degrees. Mostly people were around 10 and less than 10. When asked, the questionnaire we provided them had a few questions on it. And one of the questions was that, would you be happy to tilt further if needed? And 33 participants interestingly said that that is the maximum they feel comfortable with, and they would not go beyond this. One of the participants did mention that if needed, they probably would go a bit more, but only marginally 1 to 2 degrees, but not more than that. And one of the interesting things that I observed was when asked people that what do they think about this tilt, the number they're given, like a random sort of a guess they've given, was much more than the actual number coming on the inclinometer. So regarding the other questions on this, all 34 participants said 15 degrees probably a bit too much, and they would not be happy to tilt the table up to 15 degrees in case of hypertension, as they do not feel comfortable, and as they think it might lead to patient falling off the table and causing an adverse outcome. As I mentioned previously, 33 participants were not happy to sort of increase any further tilt to what currently they are doing, and they said yes to other sort of modalities like fluids, phenylephrine, and maybe ephedrine boluses if needed for in case the hypertension persists. And all 34 participants answered that they do not discuss normally the table tilt with the obstetric team. One of the interesting things in this audit was we had actually one of our colleagues who was about 28 to 30 weeks pregnant at that time. She wanted to be anonymous, so I haven't named her here. She very kindly agreed to help us, and she took part in this audit as well. And she thought she felt extremely unsafe, and she had to hold on to the sides of the table to prevent them from falling. So that was an interesting finding. So concluding this audit, we thought left lateral tilt, 15 degrees of left lateral tilt during the cesarean section is probably not achievable. And most of us, do not feel comfortable and with a 15-degree tilt. And we start, considering other options like phenylephrine, fluids, and ephedrine way earlier than 15 degrees. And we think that 15 degrees potentially not safe and can lead to some unwanted incidents if additional safety measures are not in place. So we think, taking the recommendations from here on, we think that the left lateral tilt, 10-degree left lateral tilt is possibly acceptable, and further training is required with the people who are using about 5 to 6 degree tilt, and maybe a bit of a training to increase the confidence to tilt a bit more table might be helpful. And if more than anything beyond 10 degrees, we should start considering manual displacement of uterus by the obstetric team, and if there is cardiovascular instability, and or if the more than 10 degrees tilt is required, we should also start thinking about straps, sidebar mounts, or other precautionary measures to sort of help preventing the fall. Interestingly, I was going through the literature if there is anything previously recommended about this, and there was one of the study that was published in Journal of Anesthesia in 2012, and they mentioned an interesting fact that after their audit, after their project, they sort of trained their colleagues about the table tilt, and they re-audited it after 12 months, and still people were very reluctant to sort of tilt the table to more than what they previously used to do. So there is a bit of a hesitancy in tilting the table. And there was another study published in, actually there was a consensus published in AGBI in 2017 regarding the management of hypertension. And it also states that manual displacement of uterus is probably more sort of advantageous and more reliable than in reducing the hypotension than left lateral tilt. But again, sustaining that manual displacement by obstetric team during the procedure probably is not sustainable. So at the moment, we are relying on left lateral tilt. So we recommended that 10 degree of left lateral tilt is probably enough to sort of avoid aortocaval compression.
Great, thanks for that.
Thank you.
Yeah, thank you. So the interesting talk. This is a perennial subject of discussion, I think, in my obstetric theatres. Some very sensible recommendations. I think what you said about the use of manual uterine displacement in the case of severe cardiovascular instability sounds very sensible and supported by the literature. We did have a question there that somebody had asked, which was, would increasing the tilt to 15 degrees always correct the hypotension? I think the answer is no. It is going to be a multimodal.
Yeah, it is multimodal. There was another study I was going through, and they sort of studied various sort of angle of lateral tilt, and they said one sort of it's not like one size fits everyone. It's kind of a made to measure thing, and they said the relief of aortocaval compression is somewhere between 7.5 to 15 degrees. So it's multimodal. It's variable from patient to patient. You know, as I said, we can rely on other modalities like pharmacological management of hypertension as well. We can use phenylephrine, and we can use fluid bolus. And the tilt, as I said, the relief point of aortocaval compression is between 7.5 to 15 degrees, and that's possibly where nice guidelines is that we can tilt table up to 15 degrees.
And interesting, somebody also made a point that there is you can do on your iPhone there is an inclinometer feature on the iPhone.
Yeah, there is. That's where we compared. There are a few inclinometers on the iPhone. So the one we bought from Amazon, we compared them to a few inclinometer on the iPhones, and we made sure that we get consistent reading and we don't get variable readings at the same point. So we sort of made sure that the readings we're getting are reliable.
Great, thanks for that. So I believe the polls will now be open for the audience to score the presentation. There we go. And then we'll have a chat.
Excellent. And that poll will just be running for a few moments there if you can complete that. So our next talk this morning, we've got Dr. Stephen Manning joining us. He's got an interesting case report for us on maternal cardiac arrest. So Dr. Manning is a Newcastle graduate. He entered medicine slightly later after a short spell as a professional rugby player. He started his anaesthetic training up in the east of Scotland, before a couple of spells in New Zealand, And whilst in New Zealand, he's represented the country in both triathlon and duathlon, but is now back with us in the Northern Deanery as an ST5. So Steve, we can see you there and your slides, so I'll hand over to you. Thanks.
Perfect, thank you for the introduction. It always makes you feel slightly, reading out your credentials and things like that, make you feel slightly strange, but yeah. So I'm here today to present a, well, to be honest, one of the I don't know, most interesting cases I've ever been involved in, and definitely something that maybe worked towards my whole career, but you know, something you never really wish to or think you'll ever be part of. But we're going to talk today about the cardiopulmonary arrest following an induction of labour. It's a case report, thankfully, of a successful outcome, which I think is what makes it particularly interesting. We're going to touch on a few topics, probably each of which you could talk about for an hour, but peri-partum caesarean section, pulmonary embolism in pregnancy, thrombolysis, and major hemorrhage, each of which are kind of pretty epic subjects in themselves, but all encompassed within this case report. So so cardiac arrest in pregnancy, well, it's extremely rare, really, isn't it? You know, like I said, you hope never to be involved in it, but hope if you are involved in it, you can do your best. But when it does occur, the kind of speed of response and the attention to specific pregnancy-related factors are all kind of really vital to the outcome. So the aim of this case report is to analyse and highlight the factors that led to such a successful outcome, both maternal and neonatal. The discussion is going to focus on some issues around the performance of peri-partum dissection and peri-partum caesarean section, that kind of decision making, intraoperative thrombolysis with an open abdomen. We're going to explore not just the clinical care and the decision making, but also communication and performance under pressure, all of which are vital in this. So just to kind of brush over a bit of background in around those subjects. So cardiac arrest in pregnancy, like I said, an extremely rare event, 1 in 30,000 pregnancies. And the speed of resuscitation response, obviously, kind of like we said, critical to the outcome. And the management of the collapsed pregnant patient differs in kind of several critical areas compared to traditional adult resuscitation. These include the need to prevent aortic cable compression, which our previous talk was looking at, early securing of the airway with tracheal intubation, the rapid performance of the caesarean section, and consideration of non-cardiac related pregnancy factors. So the timing of delivery is based on theoretical considerations such as oxygen consumption, neurological injury, and very few case reports, unfortunately. But the maternal benefit of peri-partum caesarean section is the relief of the aortic cable compression, with improved venous return and potentially more effective chest compressions and improved respiratory function. And pulmonary embolism has an estimated incidence of about 1 in 10,000 in pregnancy, with a mortality of 3.5%, which is relatively significant, I would think. These two interventions are rarely performed concurrently, and peri-partum caesarean section and systemic thrombolysis don't really occur very much, and there's very few case reports on this, so that's why it makes it significant to present this today. So moving on to the case presentation. So we've got a prima gravida lady, post-dates routine induction of labour, nothing really unusual in her initial presentation, apart from the fact it was an IVF pregnancy, but it had otherwise been pretty uncomplicated. She'd been given 1 prostaglandin E2 vaginal tablet. Always calm on the labour ward. Yes, that's right. I said always calm on the labour ward. Never, maybe never a good sign. But so we got this was about 4 o'clock in the morning as well. So this is happening overnight, just to give it some context. That when, interestingly enough, I was stood by the kind of nurses' station when the emergency bell went off. So as most anaesthetists do, didn't necessarily it's more of a kind of amble, really, isn't it? Or kind of fast-paced walk. No one ever wants to be the first person on the scene, but you don't necessarily want to be the last. But what I was confronted with was a pregnant patient lying on her left-hand side, kind of gurgling a little bit, but no real signs of respiratory effort. We had a good jaw thrust, to which there was no response. You know, common things are common. You know, my wife says I'm lucky or unlucky enough to have witnessed a few eclamptic seizures, and in my mind, that was what was going through mine. Oh, it's a post-ictal eclamptic seizure. We should, you know, jaw thrust, oxygen. Except there was something different about this. She was very lifeless. The jaw thrust didn't provoke much response. And this, the cogs are whirring in your mind and things are starting to kind of tick over. So yeah, no pulse could be felt. We started some in situ CPR. Interestingly enough, at that moment, asked for some oxygen. And I think, you know, people's minds work at different stages as things are kind of going on. What, relating to the first talk as well, so as opposed to oxygen, what I was offered was some Entonox. Thought this was a little bit out of kilter. Probably wouldn't have been this good in this situation. But this started things working in my mind. We're up in an induction room. There's no instantly available oxygen. There's no wall oxygen. There's no piped oxygen. We've got a collapsed lady. We're starting CPR. So I made the decision at that point that we were in the wrong place. This all happened, you know, probably wasn't enough time to comprehend or really think through these decisions. But what I said was get on the bed, start CPR, we're going to theatre. So we rapidly mobilised to theatre. In theatre, we moved across very rapidly from the bed, continuing CPR. And then by the time I had face masks, ventilated, inserted the ET tube, I looked up to see the junior obstetric surgeon, scalpel in hand, performing the peri-partum cesarean section. So that was all very, very quick. So we moved from 4:15 was the time of the cardiac arrest emergency alarm, and 4:18 was the time of delivery of the baby. So that's like 3 minutes from initiation, and that included the time to move to theatre, which I guess people can ask questions about later, because I know that's relatively controversial. I think, so from that point of view, we've got the neonate out is going to cross to the neonatal teams arriving. More and more people are arriving in the room. We've got the scrub staff now arriving to help with the cesarean section. You've got neonatal team arriving to help with the neonatal resuscitation. Interestingly enough, as the kind of time went on and we're attaching the defibrillator paddles, the baby actually came out as you would expect a emergency cesarean section. He was kind of pink and mottled, but instantly you could hear, within a couple of minutes, you could hear his cry, which is very kind of reassuring, you know, that was kind of happening and going on. But more people were arriving all the time. Lots of things were kind of going on. Defibrillator pads are going on. People are inserting cannulas. That kind of regular management of arrest is kind of continuing. So into our hand, we gave a milligram of adrenaline through a cannula one of the emergency team had placed. And following a further cycle of CPR, we started to get a faint pulse. We had another, thankfully in the position that we were, we had lots of people arriving and lots of people with skills arriving that could do things. So we had an arterial line placed and we could start to see some movement on the arterial line. You could actually see how good the CPR was as well on the arterial line, really generating high pressures. But then it changed a little bit and you could see more of her own pulse coming in. I could feel it. I was still kind of handbagging her through the ET tube and I could feel some respiratory effort just kind of starting up, and it kind of built and built till it was kind of more regular breaths. The surgical team are continuing with their cesarean section. And then after about kind of 2 minutes, that effort started to fade down again. The pulse started to fade, the respiratory effort started to fade. So started titrating some more adrenaline. And then again, it started to come back. Respiratory effort started to come back. The pulse on the arterial line started to come back. More and more people were, like I said, arriving. So we've got more got consultant staff starting to arrive in terms of the consultant obstetric anaesthetist. We've got consultant intensive care consultant starting to arrive. We've got a decision-making process about what's going on. And all the time these people are communicating with each other and focusing each other. It was an incredible kind of task focused and the kind of power of a shared vision. Everyone shared the vision and they knew what needed to happen. We needed to get to theatre, this neonatal to come out, we needed to continue on the resuscitation. And the communication between people, you know, was ultimately just fantastic. I think one thing that really struck home was the closed loop nature of it, you know, that this kind of ongoing thing that people were communicating back to each other and recycling back to each other was absolutely fantastic. But the next stage of the management was differential diagnosis, discussion through what could be happening, what could have caused this. And it quickly came to the forefront of people's mind that PE was likely to be the most, you know, but no way to really confirm that. Thankfully, we were able to track down an emergency medicine doctor with some echo skills who came up and did a cardiac echo, which showed some right-sided heart dilatation, which again added to the evidence, but not conclusive by any stretch of the imagination. And to embark on the task of thrombolysis with an open abdomen is, well, yeah, definitely not something to take lightly or to rush into. So I think it was definitely a considered opinion involving kind of, well, probably ultimately 5 consultants, obstetric, anaesthetic, and intensive care, and other staff to thrombolyze. So in preparation for the thrombolysis, the obstetric team closed as much of the abdomen as they could in terms of inserting Bakary balloons, B-link sutures. But with the thrombolysis, obviously, it kind of led us into a major hemorrhage protocol, with the Belmont delivering kind of multiple units. So in total, during the course of the major hemorrhage, we had 20 units of red cells, 16 FFP, 5 pools of platelets, 6 packs of cryoprecipitate, and the regularly communicated blood loss to our team kind of in the end of the procedure totaled up to 12 litres. So yeah, but ultimately, after the thrombolysis, after all the blood products, after the combined working of all the team, things started to come together. The blood loss slowed, the patient stabilized, the rotems were all in order, the coagulation had been, you know, interestingly, we're trying to destroy the coagulation or kind of destroy the coagulation pathway with the thrombolysis, but then trying to restore it. It's a really interesting kind of dynamic that you're trying to take away this kind of clotting to break up the PE, but at the same time, you then want to try and restore it a little bit so you haven't got this ongoing blood loss. But following the procedure and the successful closing of the abdomen and the stabilization of the patient, on the way to the intensive care unit, they went via radiology. The CTPA confirmed the segmental pulmonary embolism, which was evident, and no abnormality was detected on the CT head. Everybody kind of left in the morning following the kind of hysterectomy and the procedure that she'd.
Hi, Steve. Sorry to interrupt. You've got about a minute left for the talk. Okay,
but well, that's good because the sun will always rise at the end of every shift, and everyone will go home. So yeah, so we all left that morning, rather shell-shocked with the events of the evening, but knowing that ultimately everyone had done their best. We'd all trusted our instinct, trusted our internal guidance systems, worked on the kind of shared vision, and put her in the best position that we could possibly have. So returning for the following night shift, it was amazing to hear that over the following 8 hours, the sedation had been weaned. She'd woken up and been extubated. And 6 months later, the patient's only issues are a minor impairment of her short-term memory. And the male neonate is growing and developing unperturbed by the events of his birth. So, yeah, I mean, there's further discussions, but ultimately this is the only case report of on-table thrombolysis with a non-in-theatre cardiac arrest with such successful outcomes. There are a couple of other case reports, but with significant neurological impairment to the mother. So I guess the key bits in this are this really successful outcome.
Okay.
So,
thank you very much, Steve. That was a really, really interesting case report. As you say, something everybody trains for but hopes to never come into. There's certainly been quite a bit of discussion amongst us in the room about the sort of rarity of such a fantastic outcome. So I think all the team are absolutely to be commended for that. And most of the comments we've had through, I think, are a selection of hand claps and thumbs up and such like. I'd say certainly an all-round, gosh, congratulations. That's certainly a fantastic outcome. Conscious a little of the time, we do just have one other question. Somebody's wondering, who was it that actually interpreted the results of the ROTEM in theatre there?
It was the consultant obstetric anaesthetist. She interpreted the...
right, done by the
kind of, regularly going out in the RBI. There's a ROTEM relatively close to the theatre, and they were regularly going out to over the course. I think there was 3 ROTEMs that we ran at various points during the case, and they went out and interpreted the ROTEM and then came back in. I think ultimately there were 3 consultant anaesthetists involved in the case. I think my last slide was just about the blue cheese model, which is alternatively the Swiss cheese model, where all these factors line up to lead to a successful outcome. The staff in theatre, the people available on that shift, everything lined up for this lady that led to a successful outcome. And I think any one of those things falling down and it mightn't have been such a successful outcome, but just all the holes lined up for her on that day. And
no, so certainly a very, very interesting talk, and I think probably one that we'll all sit and reflect on a little bit longer afterwards. Could I get everybody to do the polls again? They should be appearing on your screen. And again, if you can sort of complete those just now, they'll be with you for a short time. Thank you very much, Steve.
Thank you. So our next speakers are Dr. Claire Agius and Dr. Billy Qureshi, and they're going to be speaking to us about the introduction of an electronic follow-up system into obstetric anaesthesia. Claire Agius qualified as a doctor of medicine and surgery in 2010. As an undergraduate, she published several papers about stem cell research and its clinical applications, and since completing a foundation program, she's been an anaesthetic specialty trainee here in the Northern Deanery and is currently an ST6 in anaesthesia. Claire's QI work includes helping facilitate the safe use of remifentanil PCAs for labour analgesia in Northumbria Healthcare NHS Trust, and working on an education programme aimed at increasing the confidence of the use of such PCAs, as well as helping in the evolution of a clinical guideline in this regard. She also has a varied audit portfolio, which include leading audits about antibiotic use and sepsis, both in ITU with prior to emergency laparotomy, auditing the assessment of chronic illness as a baseline for advanced care planning on admission to hospital, and outside of work enjoys being a mother, swimming, skiing, and playing a clarinet. Billy Qureshi studied medicine in Newcastle and has trained mostly in the Northeast, with only a brief spell in Mersey, which was far too wet to stay in, apparently. He started his consultant post at the RVI in 2017, with predominantly interest in regional anaesthesia, but also managed to keep his hand in with some paediatric anaesthesia, which he still thoroughly enjoys. Billy has a non-clinical interest in patient-reported outcomes, digital health and informatics, and has established an online software company to serve NHS institutions with innovative solutions for integrating PROMS data into routine practice. Away from work, he used to be a fitness fanatic, but that was swiftly buried after the birth of his twin boys, who are now 16 months old, and both strive to ensure he doesn't get any time himself for fitness these days. Claire, I believe you are going to be starting us off. We can see you and we can see your slides, so over to you. Thank you.
Thank you very much, Danny. So I'm going to be speaking about a reaudit of the rate of follow-up of obstetric patients having an anaesthetic procedure following the implementation of an online system. So this is my plan. I'm just going to go over some backgrounds, the aims of the reaudit, the methodology used, and the results. We'll have a bit of a discussion at the end, and then we'll talk about pros and cons of an online database system as opposed to a paper-based log, and we'll end with some recommendations and questions. So as you all know, most obstetric anesthesia cases happen uneventfully, but there are occasional complications which may be severe and are potentially treatable. As you can see on the right-hand side, there's the Royal College Audit Recipe Book, and the standard against which we are auditing and re-auditing is, as you can see in the red box, is that all women receiving an obstetric anesthetic intervention should be followed up. That's 100% of women. So to give you a bit of an idea of the background, so before February of 2020, all procedures were recorded on a paper logbook that has been in existence for about, I'm told, about 20 years, and that's the logbook on the left-hand side. And essentially, when a clinician performs a procedure on a patient, they put in the time and date, patient detail, the procedure and the reason for it, the name of the clinician, and potentially any notes like whether it's been difficult or anything that they think is relevant. So follow-up was done online. So you had to meet the patient face-to-face. Some of them might have been discharged. Some of them wouldn't be there by the bedside when you go and see them. It was quite time consuming, and there were concerns that a significant number of patients weren't being followed up. So between February and March of 2020, a colleague of mine did a re-audit aiming to determine the rate of follow-up of obstetric patients who are having an anesthetic procedure. And the results of this audit were that 57% of these patients were being followed up. So therefore, a recommendation of this audit was that an online database system is created, and the purpose of this was to record all anesthetic procedures, and in order to achieve better follow-up, to use an automated text messaging system so that the patient gets an SMS and they can reply, and that eliminates the variables of having a busy shift, the patient having been discharged, and so on and so forth. So in February 21, there was a changeover, and people were told at induction to use the PROMS database, which is the database that Billy created in order to achieve these aims. And then this is where my re-audit comes in, which is that in February and March of 21, I collected data aiming to determine the rate of follow-up of obstetric patients having an anesthetic procedure following the introduction of this online electronic system. So just to tell you a little bit very briefly about the system, when you log into the system, this is where you put in your the details of what you have done. So on the left side, you can see that you get asked what procedure you've done, and the questions that the database asks the patient is conditional upon what kind of anesthetic procedure the patient has had. When you submit the data, then you can see the following page, which is the database with all the information. And as you can see at the top, you can also search the database using a number of queries, which I'll get on to later on in terms of the data that the database gives us. Just as an example, if the patient has had an epidural inserted for labor analgesia, these are the questions that the patient gets asked. Whether they were informed about the anesthetic, any new headaches or neurology, would they have the same anesthetic again? And there's also space at the end, as you can see in the blue box at the bottom, for them to leave any free text comments. And there's advice that, of course, if they are concerned about their condition, they should call 999 as a safety netting measure. So The aims of my re-audit was to compare the total number of cases present in the online database as opposed to the total number present in the paper logbook, just to make sure that we're not missing out on any patients. We were viewing the paper logbook as the gold standard, seeing as it had been used for a significant period of time. Secondarily, the aim was to check the proportion of patients being followed up in order to ascertain whether or not the implementation of the PROMS database has had any impact on the rate of follow-up. So the methodology that was used was identical to the methodology that was used in the original audit. So data was collected retrospectively. All entries were recorded. It was the same number of days as the initial audit, and it happened between February and March of the following year. There were no exclusion criteria, and the total number of cases on the online database were compared to the total number in the online logbook, and the percentage follow-up was worked out. So to go on to the results, so the total, as regards whether all cases were present in the online database, the vast majority of them were, so 94% were present in the online database, which means that 6% were not. And when it comes to the rate of follow-up of patients, if we use as the denominator the total number of cases that were present on the online database, then optimistically the rate of follow-up was 58%. If we use as the denominator the total number of cases present in the paper logbook, then pessimistically the rate of follow-up was 55%. So, largely speaking, the majority of cases were logged into both systems, with 6% being absent on the online database. The reason for this might have been potentially it being a busy shift, possible problems with logging in onto the online database, lack of promotion among trainees potentially, and also unclear expectations. So for example, having had a chat with some of my colleagues who are working on Delivery Suite at the time, there was this perception that the questions that the database asks are in English. So people were not inputting patients that couldn't speak English onto the online database. This was addressed in a presentation I gave at an audit meeting. So essentially the database has over 100 languages that people can choose to receive the questions and to answer back. So all cases should really be on the online database. There was no significant increase in the rate of follow-up between February and March of 21. However, there has been a new cohort of patients in the last changeover in August 21, and there'll be another one in February next week. Essentially, there is greater confidence using the online system as time goes by, and furthermore, there are new features that are constantly being added to the database. For example, the ability to disable SMSs when inputting a new case, so that way you don't have to have the patient getting two SMSs, one for an epidural insertion and one for an epidural top-up, and that also avoids the creation of a record that doesn't appear to have been followed up. And furthermore, there's the creation of an action list, which I'll talk about later. So the database gives us a lot of information continuously, and as you can see, the rate of follow-up since February and March has increased and has been as high as 71% for the month of May. So reflecting, I think, greater confidence among people using the online database. So to sum up, the database has not only enhanced follow-up numbers, but it has also enhanced the quality of the follow-up, and it has allowed us to focus our attention on the patients with potential complications and allowed us to close the loop. And the reason for this is this action list that I mentioned earlier. So if a patient answers yes, for example, to developing a new headache or some neurology, and the database automatically creates an action list, and that patient will remain there in the action list to act as a visible reminder until the clinician checks out what the patient has written, calls them and follows them up, arranges follow-up with them. So to discuss the pros and cons of the online versus the paper-based database system, clearly the online is very familiar. It's been used for a long time. It's quicker in that you don't need to log in, and the database can at times be quite slow. It doesn't need any maintenance, and it works very well as a backup in case of malfunction of the online database system. In terms of the online system, all SMSs are logged in, and the system automatically sends a reminder SMS after a couple of days if the patient hasn't answered the initial one. SMSs are sent automatically, so this eliminates the potential of the shift being busy and patients not being followed up, or for example, if the patient has been discharged quickly. It's clearly more secure. You need a login to enter, and it allows for a legal record of due diligence. There's more than 100 languages to choose from to complete follow-up, and it's easier to retrieve and analyze data with those fields that I showed at the beginning. It provides us with continuous, up-to-date, real-time data analysis, which can be used to drive change if we see any trends that are happening. And it allows for individual feedback of patient satisfaction, both in terms of metrics and in terms of free text. And this is available for both consultants and for all clinicians, essentially. So it's a case of benchmarking and quality assurance. It allows access from home to clinician who can therefore check on any tasks that they might have handed over and any patients that they really wanted followed up.
So just 1 minute, Belle. Thank you.
Okay, thank you. And new features are constantly being added on in response to feedback. And it's clearly more time efficient because you do not need to have a face-to-face conversation with everyone. This is just a snapshot of some of the graphs that the database comes up with, showing the level of patient contrast, headaches, and neurology for a selected time period. And this just shows us trend in the prevalence of headaches and neurology. So in terms of recommendations, I think we should improve inputting of data onto the online database system. So there was I gave a presentation in October, just to reiterate that all cases should be included. A demonstration is given on a first attendance to delivery suite, and reminder emails. I think it would be great to have a reminder at every handover, and a poster in the anesthetic offices helped with regard to increasing data inputting onto the online database system. And finally, I think we should consider the duplication of data that happens onto the paper logbook as well as the online database. And with regard to improving patient response rate, I think we should emphasize the importance of responding to SMSs amongst non-medical staff, for example, using a stickers, and also when we go and check that the epidural is working and when the patient is pain-free, I think we should use that as an opportunity to for them to respond to the SMS.
Okay, great. Thanks a lot, Claire. Sorry to have to wind you up there, but we'll just
no worries. Sorry about taking so long, and thank you very much for your time. We're happy to have any questions, and Billy, who created this database, is here.
Hi, Billy. Hello. Thanks for joining us. So Claire, that was really interesting narrative of the implementation of the digital database that in the unit that I work in. I can back you on that. One of the first questions was, what is the cost of implementing this online database? Maybe Billy can give some insight.
Yes, so obviously the website is partially a private enterprise and it's partially a QI project within NUF. So we run several different systems for different clinical applications within NUF. And for that work, I don't actually build a trust. I just get a quarter of a PA allowance to allow me to run these systems, which is not, obviously it does take more time than that, but this is good quality assurance, quality improvement work, and I'm happy to support it with my own time. So I don't build the trust for using it, but I do build the trust.
Yeah, so we're getting it on the cheap, really, aren't we? There was another comment that from more than one person that the database initiative was really well done, and congratulating you. The last question I think we're going to say was, is the online database for all patients or just those who were discharged before follow-up? And if it was for all patients, do you still do the follow-up? Do you still do physical follow-ups, Claire?
We do. I mean, as you know, Danny, we still do face-to-face follow-ups, particularly for GA patients. So what was the beginning of the question?
Is it for all patients who have interventions and or just those who will fail to have been physically followed up?
It's for all patients.
Yeah, I can support it. So it's for any patient who's had an anaesthetic intervention will be put in the database, but it gives a safety net because we found that 40% of patients were going home before we got a chance to see them. So it gives that safety net for people who go home before that.
Yeah, if I could just add, part of the design process that we had, Danny, was where you said that GA patients, you want to have a physical follow-up. So the system doesn't automatically message those GA patients, but those follow-ups that are done face-to-face can still be entered using the system to provide the log and the record of the follow-up and add the data to the analytics. Yeah,
we found it incredibly useful. So thank you for that. I think we'll open the poll now for that presentation. So thank you, Claire and Billy.
Thank you very much.
Thank you.
Okay, well, I hope you'll all agree that's been a really brilliant start to our day here. Thank you so much to all the speakers that we've seen so far. Please can everybody remember to complete the scoring polls for all the submitted presentations that we've had so far. We really do value getting that feedback. We're going to have a break now, just until 11:10. I think we're running a couple of minutes late, but hopefully it's still enough time for a decent break. Go and have a cup of tea and coffee, stretch your legs, and we'll see you again at 11:10 for Dr. Katie Cranfield's talk. Thank you.
Thank you.
everyone, and welcome back. We hope you're feeling refreshed and ready for this next section of the programme today. I hope everyone's had a chance for a good break. We're just chatting in the break there. We've had over 200 attendees, which we're absolutely thrilled about. So we thought we'd kick off this next session with another poll, just to get a bit of an idea of the level of experience we've got in terms of what grades everybody is working at in anaesthesia. So there should be that poll just coming up on your screen just now. We'll have that running on, and I'll perhaps come back to that after the next talk for this morning. So I'm really pleased to be introducing our next invited speaker, Dr. Katie Cranfield. We're delighted to have her talking to us today about the lesser spotted deteriorating obstetric patient. There we go, I managed to get that out. Katie is an adopted Geordie. She's completed most of her training in the Northeast in both intensive care and anaesthesia. She's a consultant at the Royal Victoria Infirmary in Newcastle, where she works in both intensive care and obstetric medicine. Katie has a particular interest in obstetric critical care and was involved in setting up the maternal medicine network within the Northeast. As a quick aside, last year we had some of the North of England maternal medicine seminars running, and I know if anybody was able to join those, they'll agree it was a really interesting set of talks, good chance for lots of specialties to get together and have a discussion around various topics in obstetrics. We're keen to get those up and running again, so keep an eye out. And in the meantime, if anybody, particularly trainees, are keen to get involved in sort of some of the admin side, please do get in touch with us, speak up, and we can see if we can get things moving. Katie is currently undertaking RCP obstetric medicine credentialing at St Thomas's Hospital in London. She's an active member of the UK Obstetric Surveillance System, or UCOS, steering committee. Outside of work, she loves to bake. I'm sure there's a few of us can vouch for the quality of that. Swim and spend time exploring the beautiful Northeast with her family. Katie, we can see you there now. We've got your slides up, so I'll hand over to you. Thank you.
Thank you very much. So hopefully you can see these slides moving. So I'm going to have a little chat about unwell obstetric patients, just how common are they in the UK, why we sometimes find it difficult to spot them, and just a few hints and tips to go through that. Now, I'm sure it doesn't take a rocket scientist to see that the person on the left, it really is not very sick, and the person on the right very much is, but there is this area in the middle that we sometimes find it difficult to pick out the women who are either at risk of deteriorating or who are deteriorating. And I thought it might be worth having a little think further about that and a bit more about why. This is something that actually came from NHS England. It's a vignette about a patient that we'd all like to think doesn't happen in our hospitals, but actually I think it's more common than we think. So it talks about a young African woman. It's her first pregnancy. She's booked as low risk. English wasn't her first language, and she had a normal vaginal delivery, 1 litre PPH, and went home the next day before her blood results were back. Probably not that uncommon. The next day she returned to postnatal ward via ED, was a little bit breathless, had a bit of palpitations and some dizziness, and someone looked at her blood results and saw that she was a bit anemic, so gave her a blood transfusion. And though she remained a little bit tachycardic and a little bit breathless, she went home the next morning. And at no point during that stay was she seen by a consultant or by an obstetric physician. And her husband stayed with her throughout the night, and no interpreter was used at any point. He rang the maternity assessment unit again that evening, saying that she was still feeling a bit breathless and had a bit of pain in her ribs, and was told by the midwife and SHO to keep her at home, propped up in a chair. And she very sadly collapsed and died overnight and came into ED with no signs of life. And it was only on post-mortem that her severe rheumatic mitral valve disease was diagnosed. So whilst we have a relatively low maternal mortality rate in the UK compared with some other countries, it's still 8.8 per 100,000 live births. And our ITU admission rate, well, isn't that high, at about 0.2%, so 2.24 per 1,000 women, but actually severe morbidity, so things that would have a significant impact on women's health, things like a large PE or sepsis, have probably a much higher prevalence of around 7 or 8 per 1,000 women. In general, critical care admissions for obstetric patients tend to be rather short, 1 or 2 days. And you've got much higher risk of admission if you're over the age of 35, of Black ethnic origin, have had 3 or more previous births, have preeclampsia, diabetes, or a placental disorder. And the reason why women are admitted to critical care in the UK is usually due to obstetric hemorrhage or pneumonia are the two most common reasons. So just having a little look at this, which is from this year's Embrace report that came out in December, it's quite striking. The main reasons, so more than half of women who die during pregnancy and the postpartum period in the UK die from something completely non-obstetric. And more than half of women who die actually have pre-existing medical problems as well. When we look at the causes for why women die, the solid bars are indirect causes of death, so that's not something directly caused by the pregnancy, and the hashed bars are direct causes of death. Cardiac disease, epilepsy, which over the past few years has had a massive increase in causes of maternal death. Sepsis, with the hatched bar being sort of direct causes of obstetric causes of sepsis, and thromboembolism remain pretty high causes of maternal death. And I just thought we'd touch a little bit on those a bit later on in the talk. I think what is also quite striking to see, and the picture on the left with the circles isn't actually from this year's Embrace report, but I think shows it really, really nicely, is the number of other either inequalities or biases that this group of women who very sadly died had. They almost all had other physical or mental health problems. They were often multimorbid, overweight, smoking. They may live in deprived areas, and they often had quite a short gap between pregnancies. Many were born outside the UK. And as you can see here, whilst there has been some slight improvements in rates of inequality of maternal deaths, depending upon ethnicity, there's still a big way to go. You're still more than 3 times more likely to die in the UK if you're of Black ethnic origin than if you're Caucasian during your pregnancy. I think similarly, it's important to note the disparity in social deprivation. So the most deprived, group 5, significantly more likely to die than other groups. I think recently we've been seeing this increase in maternal mortality rates in the least deprived, and I think that probably is the case, and I think it probably reflects a group of women who are having babies much later on in life, and potentially IVF pregnancies when they've got other comorbidities. But we'll see what happens with that over the next few years. So why do we find it difficult to identify women who are sick? I think there's a few things to think about here. In terms of patients, sometimes there's a language barrier that means that we might not always identify the symptoms that they're having. These are a group of patients that often have multiple different comorbidities, so teasing out the story, even if we are able to communicate properly, can be quite tricky. These group of women have an ability to compensate. You're designed to compensate for blood loss whilst you're pregnant. So this group of women will compensate until they're really very sick. Sometimes patients have other responsibilities at home, so they might be caring for other children, they might need to work, other reasons why they either may not want to seek help or may wish to be back at home. Physiology of pregnancy can sometimes be quite tricky to differentiate from physiology of being unwell, and we'll talk more about that in a moment. Women often have fears about the impact of medications or treatments on their babies, so might not wish to take certain medications or undergo specific investigations. And I think it's really important that we play a real role in making sure that we consent and have these discussions with women properly. And sometimes women might worry about not being believed or the response that they're going to get from staff when they disclose symptoms that they may be having. How about when you're at work on delivery suite? Well, there are a lot of reasons why you might not be picking up these patients. You see lots and lots of very well women on delivery suites, and what we want and think of when a woman has just had a baby is that she's well and glowing, and we're biased and have expectations, whether or not we're conscious of those biases, as to what we think we're going to find. We might well be in the middle of a 12, 24-hour shift or on call and be tired. The workload might be slightly unmanageable. So someone comes and tells you that the patient who's in room 4 isn't feeling that well, but they're fine, really. And you just want to believe them because you've got 1,000,001 other things to do. Your own personal health or mental state might well affect your ability to pick things up. And there's a perceived need for things to be okay, whether that's as a junior trainee, you feel like you need to be seen to be coping and not bothering your senior, or whether it's that you feel like things are going fine and they need to continue that way. Sometimes people genuinely feel like they've got a lack of support or a lack of experience to manage these things. They have their own fears about their ability to manage things. And I think something that's really common in all areas of this hospital is what we call fetal fixation. So people are worried about doing anything, worried about doing a scan or prescribing a medication because they don't know about the impact of that on baby. So it's easier for them to do nothing. And that tends to be where things go wrong. In terms of a systems design side of things, there's numerous reasons why it's hard to pick these women up. The way that we now work, we're not always working with the same team. So you don't know when a specific obstetrician comes and tells you that they're worried, whether that's really out of character for them and actually something that you take really quite seriously. There's a far more handovers, so things get missed in handovers, staff rotate around, and certainly at the moment there's lots of bed pressures and pressure for people to be okay to get them out and discharge them. There might be differences in individual skill mix within the team, and probably, almost as an impact of practicing defensively, a lack of making a positive diagnosis. We're very good at wanting to exclude a PE or exclude a cardiac cause for someone's breathlessness or chest pain, but have we actually found out what's wrong with them? Well, does that really matter? I mean, surely we're all providing good enough care, and yes, it might be a bit tricky to pick things up. Well, actually, it probably does. When you look through the case reports of the women who died in the last triennium, only 17% of those women who died got what we would classify as good care. And quite horrifyingly, 37% of them, improvements to care which could have been made might well have impacted whether or not that woman actually died, which is a pretty horrifying figure. I think we're very good at learning about physiology, but do we ever really get taught what's normal and what's not normal in pregnancy? Until you know what's normal, how can you pick up what's normal and what's not normal? And this certainly isn't something I was taught about at medical school. We didn't really know an enormous amount about it until a few years ago when the 4P study was published, which looked at normal physiological data in pregnancy within the UK. And actually our previously thought teachings are probably a little bit wrong. Heart rate increases a little bit during pregnancy, about 9-10 beats, and blood pressure increases slightly by about 10 millimeters of mercury. Your respiratory rate and temperature should remain completely unchanged during pregnancy, and tachypnea is very much a red flag of pregnancy, and we'll talk about those a bit more later. SATs tend to generally slightly gradually decline throughout pregnancy, but at any point SATs of less than 94% are very much abnormal. There are some slight alterations to normal blood values that we'll talk about a bit later. And there are some specific ECG changes. Ectopics are more common, left axis deviation, slight ST depression and T wave inversion due to the change in position of the heart, and small Q waves are all normal in pregnancy. Certainly late in pregnancy, you get chest x-ray changes, you get increase in pulmonary vasculature, there's far more blood going around, the diaphragm rises, and the heart looks far more horizontal on the chest x-ray, which can sometimes make it appear larger. In terms of echo finding, the heart is working much harder, it's pumping a lot more blood around the body, so you do get LVH. You can get a slight degree of diastolic dysfunction, and for anyone who does point of care echoes, I'd probably say about 25% of women do end up with a very small pericardial effusion, but it is very small, and it's thought to be due to chronic volume overload. The LV often looks quite hyperdynamic, and functional MR, TR and PR can all be absolutely normal, but you should not have aortic regurgitation in a normal pregnancy. I just wanted to again highlight the importance of using a maternal early warning score chart. So these are the same observations plotted on a Muse chart and a Muse 2 chart. The Muse scores highest risk and the Muse 2 scores nothing at all. And there is a national Muse chart on the way. It should be out later this year. It's in pilot testing. So I thought we'd talk about a few of those leading causes of death. And the reason I picked sepsis to start with is because it's the one that I think is sometimes most difficult to differentiate from physiology of pregnancy. In terms of infections that pregnant women get, worldwide, the most common one that they genuinely are predisposed to is malaria. Not so much within the UK, where it's pneumonia and then direct causes. So following section, endometritis or necrotizing fasciitis. Always think about your septic abortions and chorioamnionitis. And then mastitis and pyelonephritis are also quite common. In terms of organisms, most often you're looking at group A strep or E. coli. So why is it difficult to pick up in pregnancy? Well, the physiological response to pregnancy can also reduce your ability to respond to infection. And the physiological changes that you get with pregnancy very much mimic sepsis. So diagnosis can be difficult. This, I thought, was a really great image from a paper that I found, which basically highlights the differences in pregnancy and sepsis. So in pregnancy, your systemic vascular resistance drops, your heart rate increases, your blood pressure can drop a little bit. Same with sepsis, you obviously get a reduction in vascular resistance, tachycardia, drop in blood pressure. Respiratory wise, your pulmonary vasculature becomes leakier. You've got a much higher renal blood flow and renal glomerular filtration rate, and you've obviously got far more procoagulant factors occurring in both conditions. So the overall effect, if you have a pregnant woman who's septic, is that she's going to have absolutely massive hemodynamic collapse at a late point in time, which leads to shock and organ dysfunction. From a respiratory point of view, you're more likely to decompensate rapidly as well, causing hypoxia. Much higher risk of getting pulmonary edema, ARDS, and they're much less able to compensate for a nasty metabolic acidosis because they've already got a respiratory alkalosis that's physiologically normal with pregnancy. They're at a higher risk of acute kidney injury, and from a coagulation point of view, microvascular thrombi often form, which can cause dysregulation of the microcirculation. So you're far more likely to get impaired tissue perfusion and shock. Whilst it's not the most common cause of death within the UK, there's still a pretty significant number of women who die due to sepsis. Within the last 3 years, there were 13 causes of direct sepsis, and that is the area that very much has not dropped. So it's the area that I think it's just worth focusing on. I think the increase is due to this sort of concerning area of mid-trimester chorioamnionitis, and that's very much from, I think, us having an ability to manage women with extremely premature rupture of membranes for longer periods of time, and making sure that we're careful about explaining those risks of continuing the pregnancy and the risks of sepsis to those women. So just a few points on sepsis. It's the one thing that I would say absolutely don't just rely on news, because these women will compensate on until really quite late. So look at the blood results, look at the inflammatory markers. Have a really low threshold for thinking about direct causes of sepsis and potentially source isolation. So does this woman need to go back to theatre? Ask women directly about invasive procedures. Have they had have they had amniocentesis? Ask about ruptured membranes, and wherever possible, if the woman's primary language is not English, think about using an interpreter. So I just wanted to touch on the red flags of pregnancy because I think they're fairly relevant for the other conditions that I wanted to talk about. This is from the Royal College of Physicians Acute Care Toolkit, which I would really recommend downloading. It's a couple of pages and it summarises things really nicely. And these are signs or symptoms, some physical and some psychiatric, that should really prompt you to be worried about a woman and to try and come up with a positive diagnosis as to what is wrong with that lady rather than just trying to exclude diagnoses. Cardiac disease remains the largest cause of maternal death within the UK, and more than 75% of women who die within the UK were not known to have cardiac disease when they originally presented and became pregnant. The relevant red flags here are tachypnea, chest pain that is persistent and severe, tachycardia, orthopnea and palpitations, and you should absolutely investigate these women and try and find out a cause. You're 3 to 4 times more likely to have an MI in pregnancy in the postpartum period. And whilst it's not your typical clot rupture, it's usually a coronary artery dissection due to the changes in connective tissue that occur with pregnancy. You should still think about sending that woman for an angiogram or PCI and treat them exactly the same way that you would do if they were not pregnant. DC cardioversion is safe throughout pregnancy. It seems strange saying that, but that's really sadly, women in the UK died because they did not get cardioverted for dysrhythmia because there were concerns about it being safe in pregnancy. And the other thing to think about when you're thinking about cardiac disease is aortopathies. Because of those changes in the connective tissues, women are at high risk of aortic dissection. So if you have a woman with unexplained chest pain, you absolutely can and should send them for a CT scan if that's on your radar and it's something you're thinking about. Epilepsy, I think, is definitely worth mentioning given the recent increases in sudden unexplained deaths in epilepsy. And I think that's probably due to the fact that we no longer really use sodium valproate in pregnancy. So sodium valproate we know is harmful for baby, but it was a very good anti-epileptic in pregnancy. And we quite often change women onto lamotrigine now. And what we do know is that levels almost always drop during pregnancy. And people are very worried about impacts on baby and giving too much medication. So when women come and talk about the fact that they think they're having slightly more seizures or nocturnal seizures, which is very much a red flag in this area, people take a level, but then it takes a while for the level to come back. So I guess my message here would be, don't wait to increase the dose. You're unlikely to make these women toxic. You can always drop the level down if you need to. For women who are at particular risk of seizures, labour is quite a risky time. Women are often tired, dehydrated. They may not have remembered to take their medications at the appropriate times. So they really are, that's the risky period to worry about. And for some particularly high risk women, we might give a few days of clonazepam to try and cover their labour, because actually having a seizure might well have implications for a woman if she drives. Just some general points: you can absolutely put a woman in the MRI scanner while she's pregnant. Try and avoid gadolinium contrast, but you can MRI scan her. You can put her in the CT scanner and give CT angios. Benzos and Keppra, so levetiracetam, are perfectly safe in pregnancy, but try and avoid valproate. And we should try and take opportunities to give women safety advice if they are epileptic, but hopefully they should be seen in the joint clinic. Venous thromboembolism, whilst we're making some progress with this, it still remains a leading cause of maternal death. Tachypnea, again, is absolutely not normal. Women often will describe feeling breathless whilst they're pregnant, but physiological shortness of breath at pregnancy should get better on exertion. So if you're worried about this woman, pop a SATS probe on them and walk them up and down some stairs, and you will find that if it is physiological breathlessness of pregnancy, it should get better, and the SATS should get better on exercise. Don't use D-dimers in pregnancy, they're almost always raised. And any maternal collapse, please think about point of care ultrasound if anyone's able to do so, if you've got someone who can do so at the time. There were women who were thrombolized without having a point of care ultrasound, who'd had a massive intra-abdominal bleed, and women who didn't get an echo, a point of care echo, who may well have benefited from thrombolysis had somebody seen a big RV dysfunction. You can absolutely thrombolize a woman who's pregnant or postpartum, and similarly with embolectomy for a high-risk PE. Just also remember that just because a woman is on VTE prophylaxis, it does reduce her risk of getting a VTE, but it doesn't prevent it. If women are wanting to breastfeed, they can breastfeed on low molecular weight heparin and warfarin, but not the newer oral agents. And you should try and delay starting warfarin until at least 5 days postpartum. If you've got women on heparin, you don't need to do anti-10A monitoring unless they're particularly large or small, or they've got other complications like renal impairment. And if your woman does have a DVT or PE in pregnancy, you should continue that low molecular weight heparin for at least 3 months, but also until they're more than 6 weeks postpartum. So if they had it when they're only 7 weeks pregnant, they'll be on low molecular weight heparin all the way through until they're 6 weeks postpartum. One of the final things I just wanted to touch on was acute kidney injury. I think because we are so used to looking after adult patients and seeing creatinine significantly higher than this, it just doesn't flag on our radar. But at no point in pregnancy is a normal creatinine any higher than 77 micromoles per litre. So if you have a woman on delivery suite with a creatinine of 95, she has a pretty significant acute kidney injury. There are a few pregnancy-specific causes of acute kidney injury to think about. Early on, hyperemesis, septic miscarriage. In your middle to late pregnancy, your microangiopathic hemolytic anemias, preeclampsia, and acute fatty liver. And then I think probably the ones that we see and probably miss most commonly are the postpartum ones. The women I worry about are the women who've had a couple of litres bleed. They've maybe had some non-steroidals because they've gone to theatre. They've maybe had some tranexamic acid, which can cause a sort of cortical necrosis of your kidneys. I'm not saying don't give these medications, but just be aware that those are the women that are at high risk for getting an acute kidney injury. I know we're all COVIDed out, but just to touch on a couple of things, if you are seeing women who are pregnant, take any opportunity to ask them about vaccination. So if you're seeing them in an anaesthetic clinic, if you're seeing them in main theatres and they're young women who may be thinking about pregnancy, ask them about COVID vaccinations. The rate of women who are hospitalised with COVID and admitted to ITU is 16% of women who come into hospital with COVID are admitted to critical care, and about 1% of women admitted to hospital still die from COVID. Quite horrifyingly, 70% of women who died from COVID up till December had not had steroids prior to being seen by critical care. In terms of things to think about clinically, just have a think about the location of caring for these women within your hospital and where the most appropriate place for them to be looked after is in the escalation pathway. We're quite often seeing that women with severe COVID during pregnancy get this preeclampsia-like syndrome where they become hypertensive with proteinuria, but actually their uterine artery Dopplers, and if you use soluble FLIT or PLGF, their ratios remain reassuringly low. And the relevance of that is you might be feeling like you need to deliver the baby because the woman's developing hypertension and proteinuria. That isn't necessarily the case. Absolutely refer these women to ICU. They can be recruited to trials, and you should consider tocilizumab or Ronapreve or steroids for these women. The only other things that I just wanted to highlight are the risks of preterm birth, pregnancy loss and stillbirth, which I think women are not, or certainly women I'm seeing in clinics, are not necessarily aware of, and that sometimes makes the difference between them choosing to have a vaccine and not. I've just popped this on. This gets regularly updated on the RCOG website. It's a sort of infographic to help with treatment, but the things that are also coming, COVID medicines delivery units are providing medications for people with COVID in the community who are unwell, to try and reduce their risk of becoming more severely unwell. Sotrovimab is safe in pregnancy. Molnupiravir, which is an antiretroviral, is not. And remember that your women who've had tocilizumab may not present the same way with sepsis for the next few months, so just be aware of that. Finally, just to very briefly touch on maternal medicine networks. So NHS England is setting up 17 of these around the country. They'll run on a hub-spoke model with a maternal medicine centre and supported by obstetric anaesthetists, obstetric physicians, obstetricians with an interest in maternal medicine and specialised midwives. Some women will be discussed with the Maternal Medicine Centre for opinion. Other people will have their care transferred to the Maternal Medicine Centre. And it should be a sort of fluid motion where women can shift from one to the other. It's varying how they're working around the country, but just have an awareness of it in your area and how your areas is going to work. And I thought the final thing to finish on is the fact that if we could do one thing that would improve our ability to manage this group of unwell women, is that we should treat women who may become pregnant, are pregnant, or have recently been pregnant the same as a non-pregnant person, unless you can find a very good reason not to. So just to summarise, really important to listen to and believe what patients are telling you, and use translators as and when you need to do so. Be aware of your own cognitive bias and decision fatigue, and try and make a positive diagnosis if a woman is unwell. Treat obstetric patients the same as non-pregnant patients, and always remember that there is always someone at the end of the phone in a different centre or even in the same centre as you are. I'm very happy to take any questions, but I will shut up now.
Thank you very much, Katie. That was a really excellent and thorough talk, I think, covering huge numbers of areas affecting the obstetric patients. I think particularly like the sort of looking at all our own biases and things as well, and those very comprehensive slides covering all the different areas. We've just got a couple of questions there. You've mentioned on one of the earlier slides about the maternal early warning score systems coming in. Do you know what sort of timeline we're looking for that? Is there something likely to be?
There is a pilot of there's a pilot about to be started of it in different centres around the country, some electronic and some paper-based, just to alongside those units current early warning score charts, just I suppose to verify it and see how it works in practice. And then I think the team are hoping that it will be later on this year.
Okay, right, thank you. And you'd mentioned on one of the slides there, this sort of pre-eclamptic-like syndrome associated with COVID. If you'd already got a patient that's likely to have had a point of care COVID test when they've arrived, would you advocate sort of any further testing if you were suspicious with these sort of pre-eclamptic-like symptoms not fitting? Would you repeat lateral flows, anything like that, or is there not really a...
So I think in terms of if they were hypertensive, would you then search for COVID? So possibly, in that I suppose anyone who is symptomatic, you would want to be thinking about doing COVID tests on. But I think the more helpful thing would be to do something like a soluble FLIT or a placental growth factor if you've got a hypertensive proteinuric woman, to try and exclude a diagnosis of preeclampsia, which is what that would hopefully help you to do. But then obviously be aware that you still need to find what is causing that woman to be hypertensive.
Okay. Thank you very much indeed for your presentation. That was excellent. Thank you. Just before we move on to the next talk, we'll have a quick look at those poll results that we had through before this talk, just looking at who's here joining us today. We've got a really nice spread actually of trainees and consultants across the region, up on your screen as well there. So 39% consultants. We've got some very senior associate specialists and clinical fellows, and quite a number of trainees of different grades. Nobody who's very junior with us today, but quite a nice spread there. So thank you very much for getting back to us on that one. It's just nice to see who's joining us today. Right, I'll hand over to Danny to introduce our next speaker for you.
Yes, so I'd like to welcome our next speaker. This is Dr. Nathan Griffiths, who will be giving us a talk on maternal transfer. Nathan completed his ACCS anaesthetics in the North East and is currently enjoying working for Nectar, the transport agency, despite his apparent motion sickness, with the occasional trip somewhere exotic such as Birmingham. When not at work, he looks after his 2 young boys and tries to maintain some kind of vestige of social life. Nathan, we can see you there, we can see your slides, so over to you.
Great, thank you very much. So talk today on the transfer of the obstetric patient. So transfers themselves can cause anxiety for staff, less equipment available, unfamiliar environments, and often sick patients. And you couple that with obstetrics, which can also be an anxiety-inducing experience, and it cannot be the most pleasant thing to do. But we're going to discuss some sort of principles today. They're known as the ACCEPT principles that are sort of taught on some transfer courses. Can just be handy to have a framework for how you can think about approaching these transfers, with some additional considerations thrown in for the obstetric patient. It's going to hang it all loosely off a case we did in August. So this was a lady at QE in Gateshead to come to the RVI, relatively short journey. She's a 31-year-old lady with a raised BMI, 27 weeks pregnant, with gestational diabetes, otherwise well. And she was admitted on the 23rd of August with shortness of breath, fever and cough, initially treated for a chest infection. Unfortunately came back as COVID positive, and she also had a CTPA which showed COVID pneumonitis and PEs. So not ideal combination. She had increasing oxygen requirements on the ward at the QE and was admitted to their ITU for CPAP and further close monitoring. She had sort of standard sort of COVID treatment with some dexamethasone and TOC as well. And then a decision was made to transfer to the RVI in case of need for premature delivery. So we did the transfer on day 4 of her illness. So a bit about the transfer. So through Nectar, we had an MDT phone conference. So that involves the ITU consultant at Gateshead, the transfer consultant, myself, the nurse, and the driver as well, and the ITU consultant at the RVI. Unfortunately, we couldn't get obstetrics in on the conference at the time. They were pretty wrapped up. And it's the MDT that make a decision on the level of care for transfer. So for this case, it was myself and one of our specialist nurse practitioners to transfer this patient. Go through our sort of usual kit checklist, taking both an adult and some neonatal kit as well in case of delivery en route. And we had a discussion about clinical deterioration in the peri-arrest section. Obviously, these are rare, and Steve obviously has unfortunately been involved in this before. A cesarean section in the peri-arrest would be horrendous, more so in the back of an ambulance, but it's something that needs to be raised, I think, for all these obstetric transfers, to know that it is potentially on the cards. And to just have that in mind as the worst case scenario, we could be doing one of these. And the discussion about the care of the baby, if that was to occur. So in the back of an ambulance, you're talking perhaps just yourself and the nurse. So it's very limited staffing. And the priority of the care is the mother, even after a peri-arrest section. However, obviously that will make people can be very uncomfortable, but you can hopefully do what you can for the baby, but then the attention's on the mother, which isn't a pleasant situation, but that would be how it lies. So talking through some of those principles, so go and do your own assessment of the patient before transfer, which is essentially your A2E assessment. So this lady, airway was her own, she's on tennis CPAP, big FiO2 of 85%, which gives us sats of 95%. And just on sliding her onto our transfer trolley, her sats went down to 82. So not particularly well, lady. A slightly raised respiratory rate of 22. Blood pressure was unsupported, GCS was okay, urine output was okay, and she's still febrile, and she was receiving ongoing care for COVID-19 and her pulmonary embolisms. There was an obstetric review at Gateshead shortly before we left, and they weren't concerned about the baby at this stage. So we want to see, so we've got control, so it's handy to allocate sort of roles and areas of control before the transfer. So I was there's obviously overlap, but overall in charge of the clinical lead, and the nurse, their extra experience was over charge of the logistical lead, such as calling between different hospitals, setting up the call conference before we went, checking, we got all the paperwork with us, that sort of thing. In terms of communication, we had a verbal and a written handover from the staff at Gateshead, and then our verbal and written handover then onto the RVI. And then an evaluation at this point that we're definitely going ahead with the transfer. You don't need to deliver the baby before we go, and how speedy the transfer needs to be. So this was an urgent transfer, but not a time critical transfer. It's important here as well, just to check that there is still, check that there's still a fetal heartbeat with a CTG or a Doppler, because you wouldn't want to put a lady through an unnecessary transfer, especially one that could take several hours. If unfortunately there's already been a loss of the baby, and maybe care could be continued where she is. And then P, preparation and packaging. So you sort of transfer bag, A to E equipment. We always take a video laryngoscope for obstetric patients, and most of our patients now anyway, in case of airway trouble, and have a consideration for some drugs that you're going to take as well. Obviously, they'll be case specific. And there are checklists for equipment. NEC to have some, and the North of England Critical Care Network Conference, they have some checklists online as well, so you can see, get an idea of what kit you're going to need. Again, thinking both of the mother and the baby. And then transport itself, so final review, final checks. Check your left lateral tilt, or they're in that sort of position anyway. And then a call to the receiving centre and double check your destination. Maternal patients, especially with medical problems, could be going to lots of places. So some hospitals you have to go through A&E as sort of standard. And then they could be cared for by an obstetrician primarily. They could be going to a labour ward, a medical ward, HDU, ITU. You don't want to have a patient on loads of oxygen, already potentially upset and distressed, walking all the way around the hospital to try and get to where you're meant to go. So just double check that before you set off. This was the lady's, just everyone likes a couple of pictures, I do anyway. So that was the lady's chest x-ray. Not particularly nice COVID picture. And that was a CTPA. So you can see that sort of horrible COVID pneumonitis there. So in terms of her clinical case, so after transfer, she became increasingly intolerant of CPAP. So this was 2 days after transfer, and hypoxic. She was intubated and ventilated, then proned with right side elevation for aortic caval compression, because she's on the front. An OBS review at this stage showed reduced variability, very concerned about the baby. So she had a category 1 section at 27+5. Really unfortunately, there wasn't a bed for the baby at the RVI, so the baby then had to get transferred to Sunderland. And you can see how unwell this lady was, with saturations of 70% by the end of section, which then improved once she was proned again. I'm not going to go through all their critical care stay, but like a lot of these COVID patients, this lady was unfortunately in hospital for 54 days. So it was a prolonged stay at the RVI, then back at Gateshead, and then eventually home, which obviously is not a nice start to your life with a new child. So just going back to those principles. So assessment, control, communication, evaluation, preparation and packaging, and transport. It's just any sort of structure. It's a stressful thing. So just a structure to try and help you, plan your transfer and hopefully not miss anything. So your assessment, that's essentially like an S-bar, which I'm sure you're all familiar with. Recommendations can be your own recommendations before doing the transfer. So checking you've got a rescue line, for example. Listening to your MDT. So sometimes the driver will have recommendations on the route and the use of lights, etc. And the nurse practitioner will have recommendations set off within the transfer team. Then external to that, you can have recommendations from critical care and obstetrics on management of the patient's conditions. So it's really important to listen to everyone in this case, because people can think of things that you may not think of. So control, like I said, so identify early who's going to be responsible for what part and elements of the transfer, and allocate tasks to try and avoid unnecessary duplication and stress. And communication. So it's really important to have MDT involvement. There's a communication between the local team, the transfer team, and the receiving team. But also for the obstetric patient, you have a really broad MDT. So obstetrics, anaesthetics, critical care, and neonates, and maybe medical staff as well. And all these people have got different experience and knowledge. So it's really important to sort of listen and get them on board, because again, people can have input and ideas that you wouldn't necessarily have thought of yourself. If possible, nice to double check there's a bed, well, obviously a bed for the mother and the baby as well, if possible, if you think delivery is imminent. An evaluation at this point, so establish your urgency of transfer, and is it still appropriate? Has there been a consideration of delivering the baby first and weighing up those risks to the baby and the mother, and what level of care is available where you are? And who's going to go with the patient? Obviously, for the transfer service, you'd have yourself and a nurse practitioner, but if it's, say, time critical or the transfer service is busy and you're doing this yourself, often with these really unwell patients, especially critical care patients, a critical care nurse is probably the most appropriate person to come with you. You know, their experience and help with sort of critically ill patients, transfusions, lines, all this stuff's invaluable. Could argue maybe for some obstetric emergencies, you may wish to take a midwife, but my experience, that extra critical care experience from a nursing perspective is probably going to help you out the most. Again, it depends what staff and space you've got. And then a decision on your speed and mode of transfer. So generally, this sort of blue light transfer wheels on two wheels going around corners, etc., generally isn't appropriate for almost any transfer. It massively increases the risk both to the transfer team and other road users, and hasn't been shown to have significant effect. So we'd use for these sort of urgent ones blue lights, but within the speed limits and just to get through traffic. So safe and steady transfer. Air transfer is a consideration for some. Obviously not gateshead to RVI. For anyone who's in the northeast, that would definitely not be really needed. But for longer distances, but even I think studies over in Canada, even 3-4 hour transfers, the difference saved by using air transfer is minimal. By the time you have all the faff either ends, so generally road transfer would be the way to go. So some specific obstetric considerations for your preparation and packaging. So fetal monitoring, so you won't be expected to monitor the fetus during a transfer. So a CTG or a Doppler before you head off, and ideally as soon as possible at the other end, but not during the middle, because one, you need someone who can interpret your CTG if that's what you're doing. And trying to get reliable monitoring in the back of an ambulance can be difficult at the best of times, just for your standard monitoring sometimes, so never mind extra stuff. Take a muse chart with you, both to, in that stressful environment, remind yourself of the different limits and what you'd expect your observations to be, and also part of your documentation. Extra pillows and a wedge to try and maintain that left lateral tilt position. And an emergency C-section kit. Again, people need to know that this is a potential thing. It's on the card. What's going to be your plan? So that's essentially just a size 10 scalpel and 2 cord clamps. You need to raise this as a team so that nursing staff or whoever's with you are empowered, because this can be really uncomfortable, horrible situation if you've got an arrest in the back of an ambulance. And, you know, people, I've never done one, thankfully, but people I'd imagine would freeze. It'd be very stressful. So people need to be empowered to say, here's the scalpel, we need to crack on. Obviously, a decision made on your transfer, if you're a minute away from A&E and the woman's just arrested, by the time you've pulled over to a safe space to make your interventions, you could potentially just floor it to the A&E department. But, you know, longer transfers, you know, these sections need to be done within 5 minutes. So just have those discussions before you go about where you are on your journey. When would you proceed with the section? And double check your neonatal kit. Again, the priority is the mother, but if you had done one of the sections of delivery, baby would be down between the mother's legs to try and keep warm. You got plastic bag hats, transwarm it. That's just like one of those big cracky chemical reaction things. Like people have little ones at the side of a sports pitch to keep your hands warm. It's a big one of them. You can put a baby on it. Towels, and then just some basic airway support stuff, face mask and arm boot bag. And transport. So final review. Before, in case anything's changed, definitely continue with the transfer, your checklist. NECTA have some, and the North England Critical Care Network have some checklists online. Don't forget your tilt for the obstetric patient, inform the receiving unit, double check where you're going, and hopefully have a very boring trip is what you want your transfers to be. Like a lot of cases, you just want it to be straightforward and pretty dull. Fingers crossed. So a couple of things that's coming up, as Katie's discussed, there's going to be some the Maternal Medicine Network rollout. So there's probably going to be an increase in maternal transfers. There's been an increase in transfers over the decades as other cares become centralised and specialised. So this is likely to happen for maternal transfers as well. And there's some North East guidelines and development in the acute care pathway for obstetric patients. and that'll have a specific transfer section as well, so keep an eye out for that. So summary, the principles of transfer remain the same, with just some little changes, whether that's the mother, the baby, or another patient. Get advice early, have an MDT discussion early. And if you're doing this and the transfer service isn't doing it, they can help even if they're not doing the transfer. So depending on their staffing, they can help with setting up conference calls. Instead of having to call everyone back, just do it all in one go, save time and repetition, and can help with sourcing beds and things sometimes as well. Plan for the worst and hope for the best. Some references. Shameless plug, quickly get it in there for those with an interest in transfer, or hopefully major interest in transfer. There's going to be a Northern transfer meeting on the 5th of May. It'll be advertised on A-Line soon, here first, sneak preview. And it would be free to non-medics as well. So if you've got critical care practitioners, nurses in your area who'd be interested, let them know. Special thanks to Dr. Cranfield, who's come into Nectar and given us some obstetrics teaching and helping develop the nurse practitioners there. And thanks everyone for your time.
Great, thanks for that, mate. That was a very comprehensive rundown on the issues involved in transferring the obstetric patient. I have to say the thought of a post-mortem, peri-mortem section in the back of an ambulance and then subsequent transfer in has given me a cold sweat, and I don't think I can sleep tonight. We did have one good question from one of the audience members. How do you provide non-invasive CPAP in the back of an ambulance, and is that considered to be an aerosol generating procedure, certainly in terms of thinking about the ambulance crew and the transfer through the hospital corridors?
Okay, so yeah, that's a good question. So the driver section has a glass panel that can shut off, so the driver doesn't need to wear FFP3 for transfer. In the back, we did full FFP3 for this case, and all the ambulances then we called it fog light decontaminated afterwards. Our transfer ventilator is Hamilton, which has a non-invasive ventilator function. If it's non-transfer service, probably it's going to be tricky, and probably with your NDT discussion, you'd maybe have to discuss whether you could whiz them on non-CPAP or whether you need to change for another ventilatory option.
Great. Okay, thanks for that, mate. We appreciate it. We'll open the poll for that presentation now. Thank you.
Thank you very much.
Thank you. So our next speaker, we have Dr. Sarah Todd, who's an anaesthetic registrar. She's currently working at the RVI in Newcastle. She has a major interest in obstetric anaesthesia and is going to be talking to us today about postnatal analgesia. Sarah, I can see you on the screen and your slide should be up shortly, so I'll hand over to you.
Hi, thank you very much. So this is a little QI project that I've done at the RVI with these obstetric anaesthetist colleagues, following some discussions that we had about some concerns we were having about women and their analgesia following their cesarean. And this was done at the RVI back in 2019, unfortunately, in the pre-COVID era of our lives. So we decided to do this project because predominantly it started with concern about women who are having GA sections. So we're getting a large amount of phone calls about these women in less than 12 hours after their surgery, asking for us to have a think about their pain relief from the midwives. And at the time we were prescribing them all PCAs with the intention of having that on roughly for 24 hours. And the midwives were calling us within sometimes even 5-6 hours saying, can we have the PCA down? Can we have something else? And we thought this might have been driven from the midwives. So we wanted to find out a bit more about that. And just generally, when we were doing the post-op checks and going around and seeing women, some of them were still saying that they were quite sore. So what could we do to improve this? Was there anything that we could do to improve the midwife championship of them being the kind of owners of analgesia on the ward? And just generally, we know that people who have poorly treated pain following any operation can develop chronic pain. One study showed that 5.9% of women following a cesarean section can go on to get chronic pain. So we are certainly key people involved in trying to prevent that from happening. So what I did was I went and spoke to women in the first 24 or 48 hours after their cesarean section And then I rang them at home, which is an interesting experience, about 2 weeks later to find out how they've been getting on. Initially, I spoke to women who'd had a GA section, and then their results were so interesting that I then spoke to some women who'd had cesareans using a central neuroaxial blockade, so either a spinal or an epidural top-up. I did give a questionnaire to the midwives, to 20 midwives, which I'll go into if I have enough time. And what we were doing was, at this point, when you're in theatre with a woman, there's an electronic prescription bundle, and that just automatically generates, if you set it going, ibuprofen and paracetamol regularly, PRN dihydrocodeine for all women, obviously starting once PCA come down for GA section women. And then we were in charge of prescribing to take out medication for the dihydrocodeine, and women were getting 10 tablets of that to go home with. So we spoke to about 40 women, so 20 in hospital for both roughly GA section and central neuroaxial blockade, and then giving them a ring following. We just lost a couple of women because we just couldn't contact them. Just having a look at who we were talking to. So for the GA sections, just out of curiosity, I was just wondering what reasons they'd had their section. And obviously the majority of them was Cat 1 sections, but there was a few who had a few other kind of more complex medical issues. And of those women, 76% of them were having a TAP block or a QL2 block of some description as well, just to try and help with their pain relief. Of the central neuroaxial blockade cesareans, about half of them were electives, and most of them were spinals, just kind of coincidentally, and there was only just one epidural top-up, and all of them received an opioid of some description in their spinal or epidural top-up. So I went and spoke to the women, and my first question was, are you currently satisfied with your pain relief? And initially, most women were pretty happy. 86% of the GA section women were happy, and 87% of the spinals. However, that does mean that right from the start, there were 14 and 13% of women who weren't happy at this moment. I then asked, would you like more pain relief at this moment in time? So 24, 48 hours after your section. And now the numbers start getting a bit higher, and actually 19% of the GA section women would like more pain relief at this point. And this is considering that they've literally just been attached to a PCA, and this has just come down and they're now starting something else. But they would like some more pain relief. And 35% of the spinal women would like some more pain relief. So I was quite surprised by that. And when I said, have you been receiving your regular paracetamol and ibuprofen at this point? A surprisingly large amount of women said, no, I haven't. And this was completely agreed on their drug charts. So only 40% of women, GA women, were receiving regular paracetamol or ibuprofen, 52% of the spinal women. So there was definitely some clear room for improvement there. Overall, most women did receive paracetamol at some point. They just might not have been receiving it regularly as it was prescribed. Less people were receiving ibuprofen, usually just because there might have been some contraindication to it. And most received it at some point during their admission. But again, many missing doses at various different points. Most spinal women had had a dihydrocodeine at this point, less of the GA section women, but that's because 91% of them had had a PCA, which was now being stopped, and they were just getting started on something else. So when specifically with the GA women, we were kind of going into what was happening with the PCAs. So 70% of the women had their PCAs off within 12 hours, and all of them were gone within 24 hours. And when I was looking at the charts for the PCAs, they were barely using them. And I thought it was definitely the midwives who were saying, let's get rid of this PCA and get you started on something else. And maybe the women were wanting it. But actually it was the total opposite situation. 50% of the women asked for their PCA to be taken away. They were wanting a shower. They were trying to nurse a newborn baby while attached to a really annoying pump. It was making them feel sickly. A lot of them, their baby was on special care and they wanted to go visit their baby. And just generally, it was a massive nuisance for them. 25% of the time, the nursing staff suggested taking the PCA PCA away, but only once the woman had said, I'm really not enjoying this. And the midwife had completely reasonably said, well, let's just stop it and try something else. And all but one were happy with this decision. So it just became clear to me that actually these aren't really working, in my opinion anyway. So out of hospital, I gave the women a ring, and in between them trying to look after a crying baby and do 100 other things, the first question I asked was, were you satisfied with your pain relief at home? And actually 74% of GA women were, but unfortunately that means a quarter of them weren't. And with the spinal women, 90% of them were happy with their pain relief once they got home from hospital. Average pain scores were in the 6s for their worst pain once they got home from hospital. So fairly similar. Did they get their dihydrocodeine to go home with? And I couldn't quite work out why not all of the GA women had dihydrocodeine to go home with, because they really, really should. And that definitely would reflect why some of them were struggling so much. I think one of them had such a bad experience that she just left in anger. And I wonder whether a couple of them didn't get them, maybe because we didn't put them on the TTO, potentially just because their sections were so busy and so stressful, and it was just a little job that got missed and unfortunately wasn't picked up with the midwives. I'm not sure. But that certainly would have helped make some of these women a bit more comfortable at home. And then this I thought was a bit frustrating for the women, that 28% of women had to go to their GP to get more pain relief who'd had GA sections. And so they've had an emergency C-section, they've now got a newborn baby, and now they have to go to their GP, which it just sounded really frustrating for them. And when I asked, would you have liked more to go home with, 58% of them said that they would, and 35%, so a third of the spinal women, said that they would have liked more to go home with. So it just made me wonder about those 10 dihydrocodeines that we were giving, and do we need to give more? When I asked, did you feel like your pain relief was taken seriously in hospital, 79% of the GA women thought that it was, 90% of the spinal. So I think a bit of room for improvement there. I asked the spinal women a few extra questions because of what I'd learned from the GA section women, and 95% of them were taking paracetamol and ibuprofen regularly at home as instructed. Only 10% of them had a problem with the dihydrocodeine, and that was usually something quite minor, like feeling a bit groggy or a bit of constipation. And then interestingly, only 10% of women actually used up all of the 10 tablets. So though a third of them were asking for more, only 10% of them were using them up. But when I asked them why that was, it seemed that there was a lot of them who were rationing their dihydrocodeines. They were quite anxious about taking too many too early, because they were worried about running out when they maybe were more desperate. And actually maybe with some better education, explaining that those days at the beginning are the days to take the dihydrocodeine if you're sore, and your pains should be getting better. So don't save it for day 7, because you probably won't need it at day 7. Maybe that could help improve some of the opinions on why they need more, or they just need more. I'm still undecided. And would you be happy to take your own paracetamol and ibuprofen on the ward? So if you were post-cesarean and you got a box of both of these drugs with very clear instructions on of when to take them, and actually not only did the women like this idea, they thought actually it would totally change their experience. They would only have to ask for dihydrocodeine on the ward, and they really liked that. I just asked if they had any general comments, and there were lots and lots of lovely things said, but unfortunately 5 women had been needing fairly regular dihydrocodeine and Oromorph on the ward, and then it was just goodbye, thanks for coming, here's your 10 tablets, please go home. And I totally can see that, you know, we're expecting women to get up and moving really, really quickly and get them home, but there's no tailoring. Some of the women had quite complex pain issues before. I remember there was the spina bifida lady had really awful back pain. Someone had really bad Crohn's. Someone had a wound infection. So there's other things. It's not one format fits all. I definitely think there's room for improvement for tailoring our post-op pain relief plans. That does come with the caveat that pharmacy would need to get involved, and the midwives aren't used to as much getting pharmacy to get extra pain relief available for women. So that would need some sorting on their behalf, but it's done on every other ward quite reasonably, so it definitely can be done on a postnatal ward. 5 women reported that they'd asked for pain relief and they'd be told, here's one, why don't you see how you get on with that, and then you could take the other one later. And by the time it got around to later, it was almost always, you know, lunchtime or something, and that was totally what was reflected on the drug charts. And really upsettingly, 30% of women said that they felt like a nuisance or pathetic, or like they were being inconvenient for asking for pain relief, which just shouldn't be the case at all, and we should definitely be trying to get rid of that view of things. And 3 women felt like they were actively discouraged from taking dihydrocodeine. This is the midwives' responses. First of all, we asked them what pain relief we're routinely prescribing, and on the whole, it was correct. But unfortunately, a few women did think that we gave out codeine postnatally, which is obviously not true. 80% of midwives thought that women were receiving adequate analgesia post-section, and 80% of them did know that there was a difference between the pain relief for a spinal versus a GA. But when we asked them, which is all of this, which I'm not expecting you to read, what that difference was, there was more of an understanding that we prescribed different things, but not understanding really about why, about intrathecal opioids or epidural opioids, and how that might make someone who'd had a GA section more sore. And this is the midwife feedback. On the whole, they thought things were pretty fine, but surprisingly, they actually wanted more opioids available, which I wasn't expecting, based on how few paracetamol and ibuprofen they were giving out. But actually, they were quite keen to have more Oromorph available for them, and they must have found that women who have had it have had good pain relief from it, and maybe felt less groggy and less constipated than they have with dihydrocodeine. What areas for improvement are there? What conclusions could I get from this? I mean, I think that what would be amazing is giving women their own.
Hi, Sarah. Sorry to interrupt there. Just a 1-minute warning there.
Okay, thank you. So I think women should be getting their own paracetamol and ibuprofen as standard, but obviously this comes with a load of red tape, which means that it's just not completely easy and straightforward to achieve. I think in the recovery room, they should get a little pharmacy packet with those medicines in, with a description with the clear instructions and a little description of what to expect and what dihydrocodeine is and how many they'll get to go home with. And that for the majority of women, they don't use up all those tablets. This was just an interesting study from America. 0.35% of opioid naive women became chronic abusers post-cesarean section. And this was from an American study where women were getting a bucket of oxycodone. So the stigma around opioid use post-cesarean isn't needed. And we should be tailoring and maybe using more Oromorph, and certainly adapting discharge medication for women and their individual needs. I think we should potentially stop using, or I have stopped using PCAs for GA sections, and I'm prescribing more dihydrocodeine and Oromorph, and I'm just generally just talking to the women more and trying to help manage their expectations of their pain relief. And we're trying to improve communication and education with the midwives, which I know some of the senior midwives have been trying to support us with, just to try and improve their championship of analgesia on the ward. Those references.
Great, thank you very much, Sarah. That was a really interesting and informative talk. Thank you. We've got a couple of questions. Unfortunately, I don't think we'll have time to go through them all, but just to start with there. You mentioned that a number of times there was patients that are prescribed medication on the wards but aren't actually getting them. Yeah. Was there a reason that you found as to why this is, what the barriers might be to them getting that?
Yeah, it was actually happening a lot. So as you can see, about 50% of the time. So those 5 women described, without any prompting from me, this very kind of clear view on the ward of, oh, well, why don't you try one, see how you get on, and if you're still sore, we'll give you the other. And we're literally just talking about paracetamol and ibuprofen, and obviously there's no reason why they can't just have all the tablets that they're prescribed. So that was, I think, one of the main barriers. It was very much maybe you'd get one paracetamol and then maybe your ibuprofen at lunchtime, so paracetamol at breakfast. So I think that is just education, and it's something that if it's prescribed regularly, you just need to give out. You'd expect that on a normal post surgical ward, and I'm not quite sure what the midwives were rationale was behind that kind of attitude towards it.
Okay, thank you. And just to clarify, were all your patients that were having a GA section getting a tap block or similar with at least sort of 60 mils of local anaesthetic being given?
So 76% of them had a documented tap or QL2 block. Of the other 25%, there was nothing that was documented on the anaesthetic charts. I don't know whether one was done and documented somewhere else, but I suspect they were mainly quite junior people overnight who weren't able to do them.
Okay, and just finally, what would be your maximum 24-hour dose of dihydrocodone for these patients?
I've been doing 4 times a day, so 120, 160, sorry.
Great, thank you very much.
Okay.
Our next speaker is Dr.
Sorry, the poll. I do apologise, Sarah. The poll will just be coming up. Yes, if everybody could vote now, that would be very helpful. Thank you.
So I'd like to introduce our next speaker, who's Dr. Jordan Alfonso, who's going to be giving us a presentation entitled "Who Has Time for the Checklist in an Emergency?" That's a great title, Jordan. We appreciate the fun. Jordan completed his anaesthetic core training here in the Northeast before moving to the Northwest, and he currently works as a CT3 equivalent clinical fellow at the Royal Bolton Hospital. Jordan, we can see you, we'll see your slides, so over to you. Thank you. Oh, can you make full screen, please?
Perfect. There we go. Hi, so my presentation is just going to be on a project that I did, again, like Sarah, pre-COVID back in 2019, and then eventually managed to get it re-audited, and it had a successful result, so I think it's worth presenting. So this is about the use of the WHO checklist specifically in the obstetric theatre. So a little bit of a background. I'm sure we all know the WHO checklist. It's fairly ubiquitous in our practice, and we do it dozens of times a day, every day of our clinical lives as anaesthetists. So yeah, just a little bit of a background. Obviously, over nearly 15 years old now, since the original WHO checklist was put into place, and yeah, so that's the rough kind of schematic checklist that was originally created by the World Health Organization at the beginning. We obviously, everybody uses a different kind of adapted version for their own particular hospitals and departments. So, but those are the brief questions that we all have as a core of the checklist. So, question we all should ask with anything that we do: does it actually work? And there's a large study done shortly after its inception in 2009 that it was an international study that showed yes, it did significantly improve patient morbidity and mortality in the perioperative period. And so it is worth doing in terms of reducing kind of clinical error in the perioperative period. So what about specifically in obstetric theatre? So a study a few years later that showed, just looked at the very simple question, what category is this C-section? And they asked anaesthetists and the surgeons, and surprisingly, quite a disparity at the beginning in whether they thought it was a Cat 1 or a Cat 2 section. Then after the checklist was introduced, that disparity obviously kind of reduced, as we're all more on the same page. So the question that we had when I was working as a C2 in Sunderland Hospital, which, as you know, is a DGH, has about 4,500 births a year. Do we do the WHO checklist in our maternity theatre? So the initial audit we did was back in November to the beginning of December 2019. What we did, we created this little questionnaire that you can see there, very tiny slip of paper that we just put in the theatre register, and got all of our ODPs on board who were very, very, very helpful. And at the beginning of every case that we did in the maternity theatre, got them to fill in fill in the form saying, was there a brief? Did we do the checklist? And if not, why not? So we got 32 patients in general for that first audit. So the first question we asked was the case mix. Fairly standard spread of cases that one might do in a maternity theatre. Did we do a team brief? For the most part, we did. In 4 cases, we didn't, and we'll talk more about that in a little bit. And was the WHO checklist completed, which was the main question that we were asking. So we found that by and large we did. So in 91% of the cases, so 29 of the cases, we did do the checklist, and that there was a 50-50 split between whether we did it before or after the anesthetic was done, so before or after the spinal. So yeah, of those 3 cases that the WHO checklist wasn't done, 2 of those were a Cat 1 section, and 1 of those was a emergency PPH. And you can understand as why that might happen. If it's a true Cat 1 section, time is very precious, and it's all a bit of a hectic environment, so don't always have time to do the checklist. So yeah, we didn't do too badly the first time around, but there's always room for improvement. So what did we do about it? So we sat down with our anaesthetic department at Sunderland and Mr. Hinshaw and the Sunderland obstetric team. We sat down and thought we can make a abbreviated checklist that we can do in a hurry. So taking just the salient points, just the key questions that we need to ask before we undertake a Cat 1 section. It's something that's already done in other hospitals, so we took a bit of inspiration from those. I think there's a couple in London, there was the Liverpool Women's Hospital, and I think we used the RVIs as well. And we thought that the best way to kind of employ this new checklist was to turn it into a big whiteboard that everybody can see in the theatre, mount it on the wall of the obstetric theatre where everybody can see it, and then have one of the theatre staff just fill it in as we're doing the checklist at the beginning of the case. So after some deliberation and after kind of crossing all of the red tape that you would encounter when trying to do any kind of intervention in the NHS, we managed to come up with this checklist here and managed to turn it into a whiteboard. So you can see there's just the very, very brief questions that we need to ask. So any allergies, difficult airway, things like risk of major hemorrhage, FSE been removed, and obviously put the patient's name so we're all kind of on the same page as what's happening. So very, very simple intervention. So as said before, any medical intervention that we do, we should always ask, does it work? So we eventually managed to re-audit it after COVID kind of calmed down a little bit in the back end of 2021. Did the similar methodology in terms of collecting data. So created a similar checklist, similar questionnaire, sorry, to before, except this time added the extra question of, did we do the checklist on the whiteboard or on the paper if it was a Cat 1 section? And results of that, we did. So we put an intervention into place, and now 100% of times we were in the emergency theatre, we were in theatre with an obstetric case, we did the checklist. So of this time, there were actually 3 times as many Cat 1 sections as there were in the initial audit, but we did the checklist for all of them, and 5 of those were employing the new whiteboard. So I think that deserves a bit of a pat on the back, and that's yeah, fairly reassuring. So yeah, it just goes to show how a simple change to the ergonomics of the theatre can result in improved patient safety, even in a very hectic situation. So hopefully the guys at Sunderland will be able to re-audit that in the future and just make sure that we're continuing to do that. So happy to take any questions. Thank you very much.
Great, thanks for that, Jordan. That was a really nice, kind of simple quality improvement project there. I don't believe we've had any questions from the audience. There's a comment that was a great idea for a WHO checklist for Category 1 sections. Are there So what hurdles did you face in getting the abbreviated checklist implemented in Sunderland when you did it, Jordan?
So I think just in terms of getting anything, particularly anything physical, implemented in the hospital, there's always, you have to, lots of red tape to encounter, and having to deal with the states and having to deal with I don't know, getting, especially doing things during COVID was exceptionally difficult. But I think the obstetric team in particular have been really good at encouraging this to happen. So yeah, kudos to them.
And what do you think the benefits are for patient safety?
I think it's certainly something that I've only been doing obstetric anesthesia for like a couple of years now, and I've encountered lots of instances, even just recently, where patient safety has been affected because there hasn't been good communication between theatre team or the obstetrics and the anaesthetists, and it has in recent experience resulted in adverse patient outcomes. So I think just having everybody knowing what they're doing from the beginning is invaluable.
Yeah, I agree. You beat my drum here. Anything that encourages team communication in those kind of high pressure environments has got to be welcomed. So thanks a lot for that. We will open the poll for your presentation there.
Thank you.
Okay. Thank you very much, Jordan. So that presentation concludes our morning session. Thank you very much for joining us. We'll have a break now for lunch, but we'll see you back here again at 1:25. We look forward to welcoming you for our afternoon sessions. Thank you.
Thank you. Enjoy lunch.
welcome back. We hope you've all enjoyed your lunch and are feeling refreshed and ready for our afternoon session. We're going to be starting off this afternoon with another of our keynote talks. We are delighted to start the afternoon with our third invited speaker of the day, Professor Nuala Lucas. Nuala, I know you didn't want too full an introduction here, but I think there's quite a bit of information that's important for our team to know about. Nuala is a consultant anaesthetist at Northwick Park Hospital in northwest London. She served as Honorary Secretary for the OAA and as Chair of their Education Subcommittee. Nuala is the anaesthetic co-lead for the UK Confidential Maternal Death Inquiries. She is Senior Editor of the International Journal of Obstetric Anaesthesia and was the sole anaesthetic member of the Guideline Development Group for the NICE guidelines for caesarean section, intrapartum care and twins. More recently, she was awarded an MBE in the 2020 Queen's Birthday Honours for services to anaesthesia during the COVID-19 pandemic. And in 2021, she was the recipient of the Association of Anaesthetists Featherstone Professorship. Her research interests include complications of obstetric anaesthesia. Thank you very much for joining us here today, Nuala, and we can see you and your slides will be with us imminently, so I'll hand over to you. Thank you.
Thanks, Jen, and thanks, Danny, and thanks, everyone. It is great to be here with you. It would all be nice to meet in person, but hopefully that's not too far away now. So it's quite an unusual experience being given a freestyle with a talk. Normally you get a topic, postpartum hemorrhage, etc., and you've got a reasonably clear narrative in your head. But when you're not given a specific topic, it does give you time to reflect about what really matters to you in your job and the things that you like to think about. So obstetric anaesthesia. It takes up about 50% of my clinical time, but it's 100% of the experiences, anecdote cases that I remember and carry with me throughout my career. Some of the happy times and also some of the very sad times. I think that the last 18 months, well, it's 2 years now, isn't it, really? You haven't really given us much time to think about anything else. So preparing this talk has given me an opportunity to reflect about obstetric anaesthesia. And how I thought I would discuss one of my favourite topics is to do it as a progress report. So over the next little while, I'm going to consider what's gone well with obstetric anaesthesia. I'm going to consider some areas for room for improvement, things we could have done better. And something I think we need to do in the post-COVID era, not just for obstetrics, but all areas of anaesthetic practice, is what do we need to do to make sure that we're fit for purpose going forward? So first of all, let's consider what's gone well. So I'm sure this is familiar to most of you. This shows it's from the last Embrace report, and it shows all the causes of maternal death in the UK. Now, it is reassuring that anaesthesia is right at the bottom of this list, but I think we also need to highlight that anaesthesia is the only iatrogenic cause of death on this list. All the other causes are disease, pathophysiological processes. And I think whenever you see anaesthesia at the end of a list of mortality, it really does remind us and behoves us to scrutinise and seek ways to make sure that anaesthesia is removed from this list altogether. But overall, the reduction in maternal mortality in the UK since the start of the Maternal Confidential Death Inquiries, to which anaesthesia has contributed significantly, has been a major success story for our specialty. Now, this figure shows direct anaesthetic mortality from the start of the Maternal Confidential Death Inquiry almost to the current day. And you can see the very rapid decline. Now, rather than discuss the possible reasons for this very dramatic decline, I thought I'd pull off a couple of comments from quotes from early Maternal Confidential Inquiry reports. So the first one, in 5, possibly 6 cases, anaesthesia was administered by the single-handed obstetrician. The second one, spinal anaesthesia for caesarean section initially appeared satisfactory, but respiratory difficulties occurred before the operation was completed. By this time, the anaesthetist was busy elsewhere and not immediately available. And can you imagine those scenarios arising today? And I think just these 2 quotes, and if we think about how we deliver our service now, just demonstrates just how far our specialty has come. Now, we don't actually know the number of anaesthetics that are given to pregnant and postpartum women in the UK, and I'm going to come back to this point a bit later on. But we can work out how many anaesthetics are given for caesarean section from the overall number of maternities and the number of caesarean sections. And if we look at the figures for direct anaesthetic mortality just related to caesarean section, so that includes regional and general anaesthesia, we can estimate that anaesthesia for caesarean section is 240 times safer than it was 50 years ago. And I think this is a really important figure just to highlight and reflect upon, just to actually numerically demonstrate just how far we've come. And of course, a lot of this reduction has been due to making sure that there have been no deaths from failed intubation in obstetrics. And it's been almost 20 years now since we've had a death from failed intubation in obstetrics. And of course, the big contributors here are improved training and supervision. And of course, I think the impact of well evidence-based guidelines. And I think everyone's very familiar with the OAA and Difficult Airway Society guidelines. So overall, I think we have got much to feel proud of in obstetric anaesthesia over the last 50 or 60 years. But I do think there are some things that we could have done better. And I'm going to look at three areas. I'm going to look at the management of spinal hypotension. I'm going to look at pain during caesarean section under neuraxial block. And lastly, I'm going to look at high neuraxial block. So first of all, spinal hypotension. Well, we know that in the absence of prophylaxis or treatment, spinal hypotension can occur in around 90% of patients. Now, this top paper here from Dr. Labatino was one of the first papers to describe the use of phenylephrine for the use of management of spinal hypotension for caesarean section. And then in 2006, I'm not sure if all of you would have been qualified in 2006, but if you're not familiar with this paper, it's really well worth taking a look at. It's one of Bunyad Naqvi's definitive papers, really investigating phenylephrine and ephedrine to maintain blood pressure in this scenario. But it wasn't for a further 12 years that we had the international consensus statement on the use of phenylephrine in this scenario. So why did it take so long? Well, really, why did it take from 1966 to 2018 before we adopted what we really now know is the gold standard in this area? Well, I think some of it relates to an evolution in our understanding of the mechanism of spinal hypotension, and there has been clearly a clear learning pathway. I think for many years, we believed it was primarily a problem of the venous system, venodilation. I think in the 50s, there came to be a greater understanding of the contribution of supine hypotensive syndrome. And then latterly, the combination of supine hypotensive syndrome and venodilation. But it was only really in the 2000s when we started to use cardiac output monitoring techniques in obstetric anaesthesia that we came to understand that it's actually much more significantly a problem of the arterial system, arterial dilatation, rather than simply venodilation. So I think this evolution of our knowledge was one contributory factor. But I think the much more significant factor was this issue about inappropriately translating evidence from an animal model to human practice. Now, most of the studies, animal studies looking at vasopressors are conducted in a sheep model, and that's because it's possible to cannulate the sheep and the in utero lamb. But the big problem here is that sheep have what's called an epitheliochorial placenta, in contrast to the human hemochorial placenta. Human hemochorial placenta is a much more invasive placenta. And we know that epitheliochorial placentas are much more sensitive to alpha agonists. Therefore, when you gave agents such as phenylephrine, you've got a pretty significant reduction in placental blood flow, which of course is generally perceived to be bad for the in utero lamb. But it was this inappropriate extrapolation of evidence from the sheep model, I think, that was one of the major issues and delayed the adoption of phenylephrine into current practice. Now, what about pain during caesarean section? I think we're all well aware that this is, can be a problem. It's not just that pain during caesarean section, but if we don't manage it properly, we know it can cause problems for our women after delivery. Now, this figure shows the caesarean section rate from the 1980 up to 2020. So back in the 1980s, the caesarean section rate in the UK was less than 10%. And the majority of these women would have received general anaesthesia. The regional rate at this stage was only around 20%. And of course, those ratios are pretty much flipped these days. The caesarean section rate now is over 30%. And of course, we know that most women, about 91, 92%, receive regional anaesthesia. And ever since the regional anaesthesia has dominated as the anaesthetic technique, pain during caesarean section has been a persistent problem. So this comes from David Bogott. He's an obstetric anaesthetist in Nottingham, for those of you who don't know him, and he's got a huge medico-legal database. And this figure shows the proportion of cases attributed to different causes in obstetric anaesthesia over 3 time periods, 1994 to 2000, 2001 to 2007, and 2008 to 2014. Now, if you look at backache, you can see that there's been a fairly good reassuring decrease in the number of medico-legal cases due to backache. But if you look at pain during caesarean section, pain during caesarean section has persisted as a cause of litigation across these 3 time points. I know that Tim Cook is updating his analysis of the NHS Litigation Authority database, and I think it will be really interesting to see what that looks like when it hopefully published within the next few months. Now, why has pain during caesarean section remained a problem for obstetric anaesthesia and, of course, our patients? Well, I think a big factor has been our failure to recognise that pain during caesarean section under epidural spinal is not just an acute problem, pain at the time. But if we don't manage it properly, it can be associated with very significant psychological sequelae for our patients. And I think not just obstetric anaesthetists, but probably the anaesthesia as a specialty, and perhaps across medicine, I think we have been slow to recognise that we've always concentrated the impact of psychological harm. We generally tend to concentrate on, when we talk about safety, we talk about physical safety. But I think it's important to recognise that psychological safety and psychological outcomes are as important. And if anyone's interested in this topic, I'd urge you to take a look at this excellent paper published last year. This quote at the top comes from that paper. Emotional and psychological trauma are safety errors, whether or not a patient leaves the hospital physically intact. And the paper made a couple of other points that I just really pick up because I think they're really useful. Patients, we talk about safety and we talk about physical outcomes, but patients really conceptualize the meaning of safety very differently from that of clinicians, doctors, nurses, midwives, and for patients, physical and emotional safety are inextricably linked. Other people have made this point as well, particularly Susanna Stanford. Psychological trauma can result not just from the adverse outcome, but also a result of how the incident was managed. And just emphasising about going back and recognising when things haven't gone well and apologising to patients and being honest with patients. And lastly, only patients will know about their experience of psychological and emotional safety. And it's important that when we're trying to look at patient outcomes, we look at these outcomes as well. Now, the last thing I just really want to touch upon is high neuraxial block. So this is the cardiac arrest in pregnancy study. So this was a UCOS study, the UK Obstetric Surveillance System, and it was published 3 years ago now, and it looked at all causes of cardiac arrest in the UK, in pregnant women in the UK. And what this group found was that the number 1 cause of cardiac arrest in pregnancy was anaesthetic causes, either high neuraxial block or local anaesthetic toxicity. Now, I would say that all the women who suffered a cardiac arrest related to anaesthetic cause were successfully resuscitated, but this is a pretty worrying finding for obstetric anaesthetists. And somebody has suggested, Steve Yentis has suggested that high neuraxial block is it the failed intubation of the 21st century. And I do wonder whether you're concentrating so much on the risks and outcomes associated with general anaesthesia in obstetrics. Have we slightly taken our eye off the ball, leading to these problems with regional anaesthetics? I would just offer one small point of reassurance. We just finished the high neuraxial block study and we're analysing the data. So I hope that we'll be publishing on that later this year, and that this will form the basis for some guidelines in the area. But I think we might have slightly taken our eye off the ball overall. Now, moving on, how can we ensure our subspecialty is fit for purpose in the 21st century? And before I consider what we might do, I just want to consider a couple of points about what might be problems with obstetric anaesthesia. I do sometimes wonder whether we're a bit of a Cinderella subspecialty. I don't know what it's like in your hospitals, but in my hospital, whenever we're getting a new piece of kit or discussing some exciting innovation, obstetrics is right at the bottom of that list. You know, when video laryngoscopes are coming along, we're ordering some. Somebody says, oh, what about video label? Should we get one for there? You know, ordering the high flow device. I think the order had pretty much gone in and somebody said, oh, hang on a minute, what about label? Should we get one for there? So I think we're sometimes a bit of a Cinderella subspecialty, and I think we're certainly less glamorous than things like cardiac or perioperative medicine. But I also think that sometimes we're too cautious in translating gains in anaesthesia to gains in obstetric anaesthesia. I think the caution comes from the fact that we have two patients, we have the mother and the baby. But I sometimes wonder if we're a bit overly cautious in translating gains in our specialty as a whole. And the other element, I think, is that we have to recognise, not just in obstetrics, but in anaesthesia as a specialty, and possibly even across the board in medicine, certainly in high income settings, medical care is generally good and safe these days. There are going to be no major innovations coming along in anaesthesia or surgery. But the way that we're going to improve outcomes for our patients is to, I think, to use this concept of marginal gains. And this is small yet significant improvements that can lead to monumental results. And anyone who does a lot of cycling will know that it's a concept that's used by the British cycling team, just making small adjustments, small tweaks, which can lead to significant improvements overall. And I think this represents how we're going to improve not just obstetric anaesthetic care, but anaesthetic care across the board, this concept of marginal gains. And I think the marginal gains will come from 4 areas, and I'm going to discuss each of these in turn. So first of all, research. Now, I want you to consider, is there a problem with research in obstetric anaesthesia? I mean, we see papers being published, we see things moving forward in a very slow way, but I think there is a bit of a problem with obstetric anaesthesia research. So this top figure comes from Jan Hansel's excellent updated systematic review about video laryngoscopy. And they looked at obstetric patients and all other patients as well. And the bottom figure is a review on the same subject, but just in obstetric patients. Now, video laryngoscopes have been around for about 15, possibly even 20 years now. And if we look at the number of patients, the obstetric patients that were included in these studies, 4 RCTs, 9 observational studies, only 35 case reports or series, amounting to only 528 patients in total. So we're simply not doing some of this important research in obstetric patients. Now, these 3 papers, all published within the last 18 months, looking at airway complications in obstetric patients. The first comes from France. It's a multi-center study looking at the incidence of hypoxemia at induction during OBS-GA. Second paper from South Africa, similar study, slightly smaller study, but similar findings, relatively high rate of hypoxemia in obstetric patients during induction. And the third paper is the DREAMY paper. It's the baseline characteristics of a study looking at the incidence awareness in obstetric patients. Now, you can see there on the right-hand side, the relatively high rate of airway complications, and we know that in obstetric patients. But if we look at video laryngoscopy use in these patients, it was very low. I mean, the South African study used in 3.3% of patients, but in the UK, only 2% of patients was video laryngoscopy used as a first-line device. Now, I don't have much equipoise when it comes to video laryngoscopy. I personally think we should be using it as our first-line device on the labour ward. We know these patients are more complicated, and I think we have enough evidence from the general population to translate this into the obstetric population. So what I'm suggesting to you is that even when we have evidence that we could use to improve care for our obstetric patients, we're not using it. So I think there's 2 problems with research in obstetric anaesthesia. Now, what I think is a solution to the first problem, at least, is these are my solutions. First of all, I think we need to be inclusive and be creative. So this is a really nice editorial from Marion Knight. And what Marion did was they looked at all the COVID trials that were going on at that particular time point, just about a year ago now. And unsurprisingly, almost 1,000 COVID trials going on. But only less than 2%, 1.7% specifically included obstetric patients. And Marion's take-home message was, we need to really actively seek ways to include obstetric patients in research. And I think a really fantastic example of this, not in obstetric anaesthesia, but was the recovery trial, which of course was looking at various treatment strategies for COVID. And to include obstetric patients, they altered the steroid that was used. And I think whenever anaesthetic projects are going on, we need to consider, can we include obstetric patients? The airway guys want to do an airway project. Can we include obstetric patients? A big area that I think we need to look at is, should we be using TIVA in obstetric patients? I mean, obviously there are going to be inherent difficulties, but I think we need to actively seek ways to include patients in research. The other way I think we can improve our research on this area is to find new ways to research. Now, this is a slightly nerdy topic, and I apologize for that. Now, remember earlier on in the talk, I said we don't actually know how many anaesthetics are given to pregnant women or immediately postpartum women. And that's because in the UK, there is extremely limited recording of routine activity. And that's why every time there's a national audit project, we have to do an activity survey to provide denominator data, because we don't actually know accurately how many anaesthetics are given. Lots of people turn to HES data, which uses OPCS and ICD coding, which really isn't suited to record anaesthetic data accurately. There are a couple of NHS digital data sets, but again, they're not really ideal for us to record anaesthetic activity accurately. Now, I'm telling you that if we recorded anaesthetic activity better as a routine, we could improve our knowledge and help to research in this area. But is there any evidence for me to make this statement, or am I just clutching at straws? Well, let me show you a paper which I think demonstrates this point nicely. So this comes from Rachel Kearns in Scotland, and what she and her colleagues did there was they looked at a huge database where they have slightly better recording, and they looked at the association of epidural analgesia in women in labour and neonatal and childhood outcomes. Now, if anyone's picked up a paper over the last year, you might have seen the huge amount of press that an American paper got that was published just about 18 months ago. This American paper suggested an association between an epidural in labour and the development of autism in children, which is obviously hugely worrying for our patients and for us. So what Rachel and her group did was they looked to see if there was an association with adverse neonatal and childhood outcomes. It was a population study looking at over 400,000 mother and offspring pairs with neonatal and early childhood outcomes. Now, first of all, neonatal outcomes. So what they found was that in women who'd received an epidural, there was a reduced risk of a low APGAR score at 5 minutes, but a slightly higher risk of the baby requiring resuscitation or NICU admission. But when they did an analysis with mediation by mode of delivery, they found that actually the risk of reduced APGAR score remained, but also there was a reduced risk of resuscitation and NICU admission, so incredibly reassuring. What about early childhood outcomes? Well, in women who'd had epidural analgesia, there was a reduced risk of having developmental concerns at 2 years, and specifically fewer concerns regarding communication and fine motor skills. So I think this paper demonstrates that broad and comprehensive routine data collection in anaesthesia can be used for research. And I think this is a priority, not just for obstetric anaesthesia, but for anaesthesia across the board. What else can we do? Well, I think we need to be seeking to reduce variation in practice. This figure comes from some work using the National Obstetric Anaesthetic Database published back in 2019. It shows the GA rate for caesarean section across the UK. Now you can see that most units are clustered around just under the 10%, 8-9%, but there are some units reporting a GA rate of as high as 20% and some units with a rate of around 1%. Now, I think this is pretty significant variation. We don't really understand why this is. Similarly, the accidental dural puncture rate, most units clustered around the 2% mark, but a few outliers, and some units as high as 6%. We know, and I know the Northeast have been pretty good at this, the Northeast have been early adopters of propofol, and I think your GA technique is probably leading the way across the country. But there is still some variation with people using thiopentone as their induction agent. Even after all the evidence from NAP5 and the DREAM study, people still hanging on to using thiopentone. And of course, crucially, we know that there is variation in outcomes for our women depending on their ethnicity. We know that Black and Asian women have a higher risk of dying during pregnancy. This figure on the right, it looks at labour neuraxial outcomes according to maternal immigration status in France. And what they found was that depending on the where the women had come from originally, before they'd arrived in France, there was a lower, if they'd come from low and middle income countries, there was a lower uptake of techniques such as epidural analgesia. It's not just about ensuring that everyone has equal access, it's about making sure that people feel enabled to take up these techniques. We're currently investigating in this in the UK, and I think this is a real priority as well. We need to make sure that all our women have equal access and feel enabled to reach out and get any care that they need during labour. So understanding variation. So variation per se doesn't matter. All our patients are different and there'll always be a degree of clinical autonomy in caring for them. But what matters is unwarranted variation. We don't totally understand why it happens, but it may relate to professional uncertainty, different behavioural styles between clinicians, and simply a lack of evidence. But the way to minimise it, I think, is to measure it and standardise care as much as possible on best practice. And I think that for organisations, including the OAA, which I obviously work with, I think one of our major tasks for the next few years is to try and develop evidence-based practice in areas that aren't covered by other guidance, such as NICE or the RCOG, and an obvious one would be general anaesthesia. Now, coming up to finishing, I just want to mention two other topics: quality of care, focusing on quality indicators and outcomes. Quality metrics in obstetric anaesthesia, why do we need them? Well, I think they support clinicians to improve care through comparative benchmarking, and it can really help to inform policy making at regional and national levels. And it provides information to our patients, and we want our patients to have good, accurate information. It's difficult to measure quality, and I think this is a big area that the whole specialty needs to look at in the post-COVID era. Do we look at structure, do we look at process, or do we look at outcomes? And each of these have their relative merits or disadvantages. The access process run by the Royal College does provide an initial starting point, an initial strategy to look at quality in obstetric anaesthesia. But for those units that haven't decided to go down the AXA route, I'm hoping that the OAA is starting to use their quality indicators. This was the indicators that they developed through a project undertaken just before the COVID arrived. And I think this is a good starting point, but I think looking at quality is going to be a huge aspect of care over the next couple of years. Now, the last thing I want to mention is collaboration. Obstetrics has everything. We have patients with cardiac disease, we have patients who get sick, we have patients with elevated BMIs, difficult airways. And we all talk about multidisciplinary working, but I think sometimes we go wrong because the multidisciplinary working isn't truly authentic. You know, we're invited at the last minute to an MDT meeting, or a patient rocks up on labour ward. They've had input from the cardiologists, they've had input from the OA team, and the poor anaesthetist on the day has never heard any of this. And I think if we are going to really develop as a subspecialty, we need to go beyond the simple delivery of labour analgesia and anaesthesia for caesarean section. We need to actively seek ways to make sure we're part of the peri-obstetric team, in the same way as anaesthesia is now becoming perioperative medicine, and that's a whole other discussion. I think we need to ensure that we're really part of that peri-obstetric team, working in an authentic way to develop care plans for our women. And the final element of collaboration I just want to mention is collaboration beyond our borders. I mentioned the cardiac arrest in pregnancy study earlier on, and this figure on the left-hand side is from the South African Maternal Confidential Death Inquiry. Now, they also highlighted a problem with deaths and poor outcomes from high neuraxial block. Now, again, the two figures at the bottom, the two studies I mentioned earlier, one from France and one from South Africa, both with a relatively similar rates of hypoxemia at induction of general anaesthesia. So despite the disparities in the income setting as the UK, France and South Africa, I think we have much more in common as obstetric anaesthetists than we would assume from the outset. And I think we really need to seek ways to actively collaborate with our colleagues in different resource settings and to include them and to work with them. I think we have much to learn from their experience. I think it's not just one-way traffic. We have much to learn from them as well. So just to conclude, how can we ensure obstetric anaesthesia is fit for purpose in the 21st century? I think for research, we need to actively seek ways to include pregnant women. And I think we need to improve routine data collection, not just in obstetric anaesthesia, but in anaesthesia full stop. I think we need to look to reduce unwarranted variation in practice and standardise where there is evidence. We need to focus on delivering high quality care to our patients, developing and using quality metrics. And lastly, we need to collaborate locally, nationally, and internationally. Thank you.
Much for your talk, Nuala. That was a very interesting talk and insight into where we're at with obstetric anaesthesia at the moment. Thank you. We've got a couple of questions to go through. You mentioned there about pain under regional anaesthesia and pain at caesarean section. How is obstetric anaesthesia addressing those issues, and particularly the psychological harm that can be caused by this?
So I think that we're doing better across the board. I mean, if I think about my own unit, we now have a much better pathway to follow up and offer psychological support to women when this has happened. And I think we're getting, if I look back on my own practice, I think when that happened a few years ago, if you had a patient who experienced pain, we'd go and see them afterwards. We'd say to them, "You're all right now, aren't you?" And we'd leave it at that. But I think we're being much more honest in acknowledging and saying, "I'm sorry that wasn't as we had hoped and planned for you. Did you find that traumatic?" And finding ways to offer them support. And as I said, in my own unit, we now have a much clearer pathway for referral, for counselling and support, not just related to obstetric anaesthetic difficulties, but we know that women can have traumatic times during childbirth in other settings as well. And I know that various units offer some kind of counselling. The other aspect to it is that I hope that guidance on this subject will be published within the next few months. It's currently being revised at the moment, and I hope this will provide more of a standardised approach for colleagues to help care for patients who have experienced this complication.
Thank you. And obviously you talked a fair bit about research within obstetric anaesthesia. How do you think we should be approaching that, and particularly any sort of ethical or ethic committee hurdles that may be thrown up?
Yeah, so I didn't mention that, but this is a particular bugbear with me. And I've tried to talk about people in the research world who are much more important than me. But when we were putting the DREAMY study through ethics, it took almost a year to get it through the ethics committee. And I have to sort of shout out to Peter Odor, whose persistence just got it through in the end. But I chatted to a guy called Michael Avidan, who's an anaesthetist in America, and he was at medical school with my husband. That's how I know him. And he's done a huge amount of work in this area. And he said in the US, that study would have got through ethics in a month. We've all had to put relatively simple projects through ethics, and you approach these ethics committees, and there's also a sense of you're guilty until proven innocent about it. And I don't have the answers how we break down these barriers, but I personally feel I feel slightly anxious this is going on YouTube, but I personally feel that something's slightly gone wrong, that doing fairly basic projects has become so incredibly complex and difficult in the UK, and I don't know what the answer to that is. And there's as I said, there's much more important people out there than me that might have some sort of answers, but the whole process is incredibly difficult, which is why we all seek to do observational research, quality improvement projects, surveys, etc., because there's slightly less barriers to those projects. So yeah, no, I don't have easy answers, and I wish it was a bit easier. But I think just one final point, I do think the training networks, people working together, sharing the load of the monster of trying to get through things through ethics, I think that is one potential solution. And I think, when trainees are in jobs for 6 months, it's difficult to get things done, but by sharing it, it gives more people an opportunity to get involved. So sorry, it's slightly convoluted, long-winded answer, but yeah, it frustrates me that it's so difficult.
Okay. Thank you very, very much for joining us today. Really appreciate having you here, and lots of thanks from the chat feed there as well.
Thanks, Taylor. Thank you. That was great. So our next speaker is Dr. Ahmed El-Faioumy, who will be presenting on peri-partum hyponatremia. Ahmed is a senior clinical fellow in the anaesthetics department in King's College NHS Trust at the Princess Royal University Hospital. He had 3 years of training in one of the biggest tertiary hospitals in Cairo, Egypt. That's the Ain Shams University Hospitals, and then was promoted as an assistant lecturer in the same university hospital. He subsequently joined the NHS in 2019. Ahmed, we can see you. We can see your slides, so over to you.
Hello. Thanks a lot for the introduction, and thanks for having me today. So today I'll be talking about a very important subject that we usually encounter in our labor wards, which is a peri-partum hyponatremia. And in addition, I'm going to talk about an audit that we ran in our hospital to assess the efficiency of our current hyponatremia guidelines. So to start on, as we all know that peri-partum hyponatremia is quite not an uncommon complication, and it usually is unlikely goes under-recognized. It has the potential to cause severe harm and deleterious effects from both on the mother and the infant, evidenced by the literature on the effects of hyponatremia on the central nervous system, and even by case reports. In the obstetric setting, the dilutional hyponatremia is more common in the labor, compared, of course, to non-dilutional hyponatremia, caused by either excessive hypotonic fluids intake during labor or by the physiological changes that happens during the pregnancy. So as we know that the normal blood sodium levels in the pregnancy is in the range of 130 to 140 millimole per liter, of course, compared to the non-pregnant population, which is in a range between 135 to 145. This, of course, can be explained by the physiological changes of pregnancy, where there's a state of hypervolemia and retention of total body fluids. So to continue on with the pathophysiology, why are the pregnant ladies more common and more vulnerable to hyponatremia? We can find that oxytocin plays a very crucial and important role in dilutional hyponatremia, either endogenous high levels during labor or exogenous if given for induction or augmentation of labor. And of course, this is more expressed during the 3rd trimester, where the fluid excretion is less compared to the non-pregnant population. Finally, the labor stimulates pain and stress, which leads to excessive release of ADH from the posterior pituitary, which leads to further water retention and reduction in plasma osmolality. So by understanding the pathophysiology, there are some risk factors that we must be vigilant about, and this should mandate a regular sodium follow-up monitoring. So these risk factors include either positive fluid balance over 1.5 liters, prolonged labor, and of course, Synto or oxytocin infusions, patients who are on insulin and dextrose infusions for any cause, and patients taking medications such as antidepressants, antipsychotics, diuretics, and so. And of course, finally, pre-eclamptic ladies. So moving forward to the manifestations. Manifestations usually depend on the blood sodium levels and the rate of drop rather than the absolute values. So it's very important to have a baseline sodium level for us to know. The lucky thing that usually most of the cases goes asymptomatic, but if the patient is symptomatic, there's a wide range of neurological symptoms caused by the disruption of the CNS due to changes in the plasma osmolarity leading to cerebral edema. These neurological symptoms include headache, nausea, dizziness, up to disorientation, coma, and up to seizures. And usually these symptoms start to appear when the sodium levels fall below 125 125 millimole per liter, although at this level sometimes, usually the patient might not be asymptomatic. So moving forward, I'm going to take you brief through our guideline that has been implemented in November 2020. The purpose of this guideline was to reduce the risk of hyponatremia by increasing the awareness amongst the medical staff and emphasizing on the accurate fluid balance monitoring and earlier detection of any signs and symptoms of hyponatremia. So briefly, these are the key points that we use for the prevention and management of hyponatremia during induction and labor, of course. It emphasized that all women should be encouraged to drink isotonic fluids to avoid dehydration in labor, as there was no evidence that supported fluid restriction in the labor, even if the patient is going to have an anesthetic. In addition, of course, it has been found that healthy women or who had a neutral fluid balance are at low risk of hyponatremia. In addition, the guidelines emphasized on the strict fluid chart monitoring. The guidelines recommended that intake output should be recorded 4 hourly, and that women should be encouraged to avoid 2 to 4 hourly in labor. Regarding IV fluids, it was clear that IV fluids shouldn't be prescribed unless there are clear indication, not only to correct the CTG changes or any other cause, and the prescribed reason should be documented on the fluid balance chart. Moving forward, this is a flow chart for our midwives to go through. It focused on the timely interval when to monitor the sodium. It's either 12 hourly if the patient had this normal sodium levels 130 or above, or 4 hourly in cases of patients with sodium levels between 125 to 129, and below 125, it should be repeated 2 hourly. In addition, the guidelines focus on when to inform the obstetric team, when to inform the anesthetic team, or the medical team, and of course the ICU team as well. Of course, in the case of the sodium levels below 125. So we ran this audit to assess the efficiency of our hyponatremia guidelines and to assess the implementation of these guidelines, and of course to make sure that all staff are aware of these guidelines. So we gathered information that we collected data over 1 year from May 2020 till May 2021, which is divided into 2 groups. One group were 6 months before the implementation of guidelines, while the second group were included data that had 6 months after the implementation of the guidelines. Of course, all women who have delivered in our maternity hospital and had a maternal cord blood gas sample were included in this audit. Putting into consideration that our blood gas machine was daily calibrated and validated, and considering that the maternal sodium usually approximates and is correlated to the maternal cord blood sample. So moving on to our audit results, as you can see on the table, unfortunately that the number of the hyponatremic ladies or had a sodium below 130 compared to the first group and the second group, there was no much difference. As shown, it was about 28.5% in the first 6 months, compared to the second 6 months after the implementation of the guidelines, it was 26.9%, which wasn't expected to see this results. We were expecting more decline in the number of hyponatremic ladies, of course. So moving forward, when we further analyzed the data, we found that in the first group, about 23.5% or 174 samples had a sodium level between 125 to 130, compared to the other group after the guidelines, it was about 23.6, which is 23.6%, which is, there's no much difference. But the good thing is the patients who had a sodium level below 125 were reduced from 5% before the guidelines to 3.3% after the guidelines. So in summary, we found that the number of hyponatremic ladies were almost the same. That's why we had a discussion and we did some recommendations that we wanted to monitor as well. We wanted to increase the awareness by highlighting the incidence of hyponatremia in our labor ward to all our colleagues. We wanted to spotlight the need to review blood gases for sodium levels by placing posters in our labor ward, and of course, emphasizing that the high-risk patients that we discussed earlier in the presentation. And the other thing, we wanted to emphasize on the importance of accurate fluid balance. This should be discussed with all women going into labor. In addition, we wanted to add that some fluid losses should be monitored because they were really underestimated, for example, like vomiting. And another point that was a really arguable point between us anesthetists is, should we prescribe IV fluids for every laboring lady with an epidural, or should she just rely on her neutral fluid balance or oral intake? So we discussed this and we found that it's better to, the lady with an epidural doesn't need to have a background IV fluids. Otherwise, we should give fluid boluses unless for any solid indication of hypovolemia or dehydration. And finally, in our guidelines, we wanted to add the precise management of any severe or symptomatic hyponatremic lady if the sodium is below 125 millimole per liter, or symptomatic patients. Symptoms such as a drop in GCS, seizures, or confusion. Of course, this has to be after liaising with between the obstetric team, anesthetic team, intensive care as well. We suggested that based on the guidelines that we should give 150 to 200 mL of 2.7% of sodium chloride via a wide bore cannula or a central venous line. In addition, we should consider administration of 20 milligrams of furosemide, of course, in the situation of asymptomatic hyponatremia or severe, below 125. So the question that came through my mind is, should we treat numbers or should we treat symptoms? That's always the question, because of course we couldn't track the number of patients who were really symptomatic with the severe hyponatremia because of a retrospective audit. But the numbers of symptomatic patients were really low. And the other question that we always needed to address, should all the women with an epidural receive a background IV fluids or not? And of course, we're going to re-audit this after 6 months. Thank you. These are the references. Thank you.
Thank you for that, Ahmed.
Thank you.
Yeah, we've heard quite a bit about hyponatremia in the past few years. It's interesting to hear another institution's experience of it. We did have a question from the audience today, which was a question about who's getting routine UNEs in your department. Is this women at high risk of hyponatremia, women on fluid balance, or just or routinely?
No, routinely women in labor. Not usually always high risk, because we didn't depend on the UNEs in this audit. We depended on the blood gas analysis. Usually, most of the women going into labor and delivery, they have a maternal cord blood gas sample. So from which we got the archived samples, and then we made our results. We analyzed the data over the 1 year.
Okay.
Hopefully I answered your question.
Yeah, that's great. Thank you very much. Yeah, we don't have any further questions, so I think we'll just open the polling your presentation. Thank you, Ahmed.
Thank you.
Thanks very much, Ahmed. So our next speaker this afternoon is Dr. Deborah Moore, who's going to present on cerebral venous thrombosis. Deborah is a CT3 anaesthetist who's currently working at Royal Lancaster Infirmary, She's small but mighty, often seen in the gym lifting something heavy. She's originally from the west coast of Scotland, near to Glasgow, but is frequently mistaken as having an Irish accent since she's moved to England. So Deborah, I can see you and we can see your slides, so I'll hand over to you now.
Great, thanks for that introduction. I'll be presenting a case on a left cortical vein and a sagittal sinus thrombosis that we experienced at Royal Lancaster Infirmary in the Northwest. So let's talk a wee bit about the patient. So she was a 31-year-old para-2, passed with a history of mild asthma. She also had COVID in July, which she had mild symptoms for. It didn't require any hospital admission. She had an elective cesarean section for introducing growth restriction. However, there were 3 sections on the elective list, which they couldn't get to the third one, and therefore she was the third one, and she ended up being a Cat 3 in the afternoon. She was classed as a difficult spinal due to bony obstruction, but there was success at L3-4 with 2.5 mils of 0.5% heavy marking and 0.3 milligrams of diamorphine. Block was T4, there was no immediate side effects, and it was an uneventful operation. So what happened in the following days? She was discharged home 2 days post-up, but developed a frontooccipital headache, which was worse on sitting and standing, so it's postural in nature, the day after discharge. The headache was bad enough to warrant an epidural blood patch, which was attempted 4 days after spinal by a consultant anaesthetist. Unfortunately, a further dural puncture occurred with worsening of the headache. She didn't want another epidural blood patch, and she opted for conservative management with analgesia, caffeine, fluids, and rest, bed rest that is. She gradually got better and she was discharged home 6 days later, headache free. However, the day after that discharge, she developed right-sided paresthesia involving her right arm, right back, leg and face, with a 0.5 power in her right hand lasting 10 minutes. She had 5 episodes of this associated with a different frontal headache, so different from the previous headache. She was assessed in hospital by an anaesthetist who found no abnormal neurology on examination, and an MRI venogram was ordered over the weekend. Of note, this was an outpatient MRI venogram. The report came back as a left cortical vein thrombosis and a possible superior sagittal sinus thrombosis. This is not her CT scan, however, it was very similar to the scan. And where the arrow is, you can see something which is called an empty delta sign, which indicates a superior sagittal sinus filling defect. Treatment-wise, she was started on warfarin as per neuro advice with subcut enoxaparin bridging, and she was discharged home a few days later. She's currently doing well at home. She has occasional tingling in her right arm, and her INR is within target range, and she'll be on warfarin for 6 months. So PDPH, post-dural puncture headache, what is it? So it's described as a dull throbbing pain with a frontooccipital distribution. Typically, the headache is aggravated by sitting or standing and is reduced by lying down. The diagnosis should actually be questioned in the absence of a postural component of the headache, and there should at least be a partial relief if the patient assumes a supine position. According to the International Classification of Headache Disorders, the headache should develop within 5 days after a dural puncture and disappear spontaneously within 1 week, or up to 48 hours after an epidural blood patch. The headache may also be associated with neck stiffness, tinnitus, photophobia, and nausea. Less frequent and more rare complications include reversible encephalopathy, pneumocephalus, and subdural hematoma. Therefore, when neurological signs or changes in headache characteristics, such as a non-postural headache occur, serious etiologies should be excluded, such as a subdural hematoma, cerebral thrombosis, or reversible encephalopathy. So what are the possible causes? So one hypothesis is reduced CSF pressure. So due to the loss of the CSF in the epidural space through the dural puncture site, the decreased CSF pressure creates a loss of the cushioning effect normally provided by the intracranial fluid. The resulting traction placed on intracranial pain-sensitive structures elicits pain. Another hypothesis is the distension of the cerebral blood vessels. So with a sudden drop in CSF pressure, there's vasodilation of the intracranial vessels to maintain a constant intracranial volume, resulting in a pathophysiology similar to a vascular headache. The beneficial effects of vasoconstrictor drugs such as caffeine and theophylline in PDPH support this mechanism as well. Of note, symptoms may fluctuate as thrombosis and fibrinolysis occurs simultaneously, leading to changes in surrounding blood flow and intracranial pressure. The Royal College quotes PDPH from epidural as 1 in 100, which is 1%, and for spinal 1 in 500, so 0.2%. The case numbers are variable. It can depend on the user, the patient, and the spinal needed used. Just a few examples. In 1987, Sprott conducted a study that included over 7,000 spinals and lumbar punctures in a non-obstetric population, and their rate was 0.02%. Other studies have quoted 7.3. Another one quoted 8.2. And a specific obstetric study looking into 55 patients quoted no headache with a 24-gauge Sprott. And another obstetric study in 103 patients, they had a rate of 0.96% with a 24-gauge Sprott. So let's look a bit into venous sinus thrombosis. It's uncommon. In fact, it's pretty rare. The rate is 0.22 to 1.32 per 100,000 per year. However, the mortality is 10 to 30%, so it does have a reasonably high mortality and morbidity rate as well. This accounts for between 0.5 and 1% of all strokes. In pregnancy, this increases to 11.6 per 100,000 per year. More common in young, mean age 33, and females, 60 to 75% of cases. So it really shows that this does happen more frequently in the pregnant cohort of females. What about the risk factors? So it's that classic triad. So there's stasis of blood, changes to vessel walls, and blood composition. Or there can be acquired risk factors such as infection, surgery, pregnancy, trauma, cancer, hormone use. And then we've got some genetic risk factors such as thrombophilias. 90% of people have at least one of these risk factors. In terms of presentation, most people, in fact 90%, present with a severe headache, 35 to 50% present with seizures, and 25 to 71%, so quite a varied variation there of focal neurological deficits. So what about our patients? What did she have? So one of her risk factors was she was pregnant, and she also had COVID in July. Is that a risk factor? Well, we'll speak about that in another wee minute. Another question is, was the spinal or the dural puncture during the epidural blood patch a potential cause, or did it reveal something that's already there? There's been multiple case reports, and a causal relationship is difficult to establish, but the proposed mechanism is venous dilation and stasis leading to the thrombus formation. Some other cases with CVTs. So there was a male who was 30, ASA1, went for spinal for knee arthroscopy. He presented with a severe headache. A&E said it was just sinusitis. He then developed hemiplegia with clonic seizures, and he had a CVT. He was also found to have lupus anticoagulant antibody. There was a female, 43, who had a spinal for vaginal hysterectomy. She was found to have a cortical vein thrombosis and was having focal seizures of her arm. However, blood tests were not performed. And I've read up on 3 other obstetric cases. There's many more, but this was just one case report that reported 3. So 6, 7, and 9 days postpartum, and only one of those had a spinal. So it does show that the pregnant population, if they don't have a spinal or an epidural, can still have a CVT. Like I said before, a causal relationship is difficult to establish. So, like I said, there's multiple case reports. Oh, sorry, we're on to COVID and venous sinus thrombosis. So there are actually multiple case reports varying from young patients to elderly patients, but they're usually symptomatic or diagnosed during the acute infection. Our patient had COVID in July and she had her section in September, but interestingly, she was still COVID positive 56 days after diagnosis. So when she came in for elective section, she was still COVID positive, and there was a concern about PPE, etc. But then when we found out that she had her COVID in July, we didn't use PPE during the procedure. A Chinese study has demonstrated that 9.5% of their patients remained positive after 30 days, with a maximum duration of 83 days. COVID is thought to predispose patients to thrombosis, secondary to inflammation, platelet aggregation, endothelial dysfunction, and stasis. However, more information regarding its effects on the already hypercoagulable state of pregnancy is required. So in conclusion, CVT is a rare diagnosis that can present with a variety of signs and symptoms. This case report has highlighted the importance of prompt investigation with MRI venogram for headaches post-neuroaxial anaesthesia that are no longer postural, change in nature, or become associated with other features such as abnormal neurology or seizures to investigate the possibility of CVT. This case report also questions the significance of previous COVID-19 infection and the predisposition to venous thromboembolism, but more research is required into the subject. In terms of in Lancaster, this is the first CVT that we've certainly had in my period of time, but also in a lot of the consultants' time there as well. And I think it is, because it is so rare, unrecognised. So from our learning, as previously mentioned, she had an outpatient MRI scan. She really should have had an inpatient MRI scan, and there should have been a dedicated person to follow up on that report. So that's learning points that us as a whole have taken as a department. Thanks very much.
Thank you, Deborah. Thank you for an interesting case presentation there. A couple of the questions we had as we were discussing through your presentation, you've actually answered later on. We were discussing some of the issues around COVID, whether that COVID status or her vaccine status may have contributed. I know locally they've had sort of a couple of cases that not necessarily in the pregnant population, but with DVT. The other thing I just, again, I think you started to touch on there. In retrospect, is there anything else that you would have done differently with this patient, obviously knowing what you know now compared to her?
So I think one of the difficulties is that because it was over a period of time, so all this happened over a few weeks, then there's a different anaesthetist on each day. So the documentation could have been better. When she was reviewed, she didn't have any neurology. However, the opinion is of the department that she should have had an inpatient MRI and been admitted, and that MRI should have been reported faster. So in Lancaster, it was recognised that the report was not being reported quick enough, and we did phone our department to say, can you report this? And unfortunately, they said it wasn't their responsibility. So outpatient scans are reported by a different company than inpatient scans, and therefore they didn't report it when they were asked to. So multiple learning points.
Yeah, fantastic. Okay, thank you very much. Thanks for the
Thank
time. We'll just be launching the poll just now. So again, if everybody can complete that poll for the talk, that would be great. I'll hand over to the next speaker.
So next we have Dr. Aashish Koirala, who will be talking to us about an interesting case of preeclampsia. Aashish is currently working as an MTI, a medical trainee initiative in anaesthetics and critical care in the Royal Bolton Hospital. He did his MD in anaesthetics and critical care in Nepal and had worked there for 3 years before coming to the UK, and has been working in the Royal Bolton Hospital since January of 2020. Aashish, we can see you and can see your slides, so over to you. Thank you.
Hi, thank you for the introduction, and I would like to thank the team for this wonderful opportunity and this wonderful program. So today I'm going to present a case that I did.
Make your slides full screen for us, please. Thank you.
I'm sorry?
Is your slides on full screen there?
Yeah.
Slideshow, is it?
Yeah, it's on the slideshow.
Is it on the full screen? Can you put it on the slideshow option? It looks like we've got a smaller view. Start slideshow, maybe bottom right.
Yeah.
No, it's not quite, but we'll make do with it, I suppose. If you can't make it, come on, carry on.
Shall I continue then?
Yeah, go on, continue. Thanks.
All right, thank you. So today I'm going to present a case where a lady who was term pregnant presented to maternal trials of Royal Bolton Hospital with main complaint of a sudden loss of vision since the morning. So basically, the lady was 27 years old, female, otherwise fit and well. She had uncomplicated pregnancy, was not on any medication. So on the afternoon at about 12 p.m. Of 27th August, she presented to the maternal trials with loss of vision, and on examination, her blood pressure was severely elevated. So she was rushed into the high care, and IV access was obtained, and PET bloods were taken. So on examination, her GCS was fine. She was oriented. She knew where she was. but she was understandably very distressed and very anxious. She was really worried about her loss of vision. Other than that, her chest was clear. She was saturating 98% on the room air. She was a bit tachypneic, and cardiovascularly, she was a bit tachycardic, but it was a sinus rhythm. And of other interesting thing that we noted on this lady was she had a bruise on the tip of her tongue, but she and her partner, they denied her having any seizures before they came to the hospital, and she did not had any seizures after coming to the hospital. So the urinary dipstick test revealed proteinuria of 2+. So she was diagnosed as severe PET. About her past medical history, like I said, she was fit and well. However, she had COVID 3 months before she came to the hospital. So she had COVID on June of 2021. So at that time, she had came into the hospital with complaint of chest pain and shortness of breath. So initially she was suspected of pulmonary embolism and pneumonia. So she was started on treatment dose of enoxaparin and started on comoxiclav. CTPA was done later, which showed bilateral pneumonitis. So she was discharged after 5 days. And during her stay in the hospital, she did not require any oxygen supplementation. And after that, she was fine. So immediate management. Basically, after obtaining the IV lines, she was started on magnesium loading dose, and maintenance dose was started. Invasive monitoring of the blood pressure was done. And for the blood pressure, initially labetalol was given twice through IV route, which did not manage to lower her blood pressure, after which she received nifedipine tablet, 20 milligram, and it had a very minimal response on her mean arterial pressure. And after nifedipine, we gave her hydralazine bolus, 5+5 milligram, which did manage to bring her blood pressure down to about 100 to 110 millimeter of mercury. And while we were doing that, we got our bloods back. Our bloods were basically they were not severely deranged. Her ALP was a bit elevated, along with white cell count and CRP. But other than that, her bloods were fine. Her platelets were normal. Her other electrolytes, sodium, potassium, UNEs, everything was normal. And we had sent a blood gas as well after obtaining the arterial line, which showed mild respiratory alkalosis, which was consistent with the clinical picture because she was hyperventilating because of the anxiety when she came in. So given the severity of the symptoms, Cat 1 cesarean section was done under rapid sequence, rapid sequence induction with thiopentone and succinylcholine. She delivered a healthy baby. The baby started crying as soon as it came out of the womb. So that was a good thing. And other than that, intraoperatively, her blood pressure settled down after the delivery of the baby, and the EBL was about 0.5 liters. So intraoperative period was uneventful. And after the section, she was maintained on infusion of the anesthetic and was taken to radiology for CT scan of her head. So after the CT scan was done, we had, so basically when this lady came in, came in, we had informed the ICU team as well, because we suspected there might be something going on inside her head, like ischemia or hemorrhage. So the ICU team were aware about her. So after doing the CT head, we took her to the ICU, and the handover was given to the ICU team. So basically, throughout the transfer, she was stable. Her saturation and blood pressure, everything was within normal limits. And the obstetric team had started her on labetalol and nifedipine for control of her blood pressure, and she was continued on infusion of the magnesium. And her CT head came back as normal, after which we had a discussion with the neurosurgeons in Salford Royal about her case. And based on the normal CT, they advised us to wake her up and do neurological and ophthalmologic examination afterwards. So basically she had uneventful course throughout the afternoon, and she was extubated in the evening of the same day. So when she waked up, her map was about 80. She had a GCS of 15/15, and she was alert and oriented. She was complaining of a bit of a generalized headache, but other than that, there was no focal motor or sensory or motor deficit. So on her neurological examination, her pupils were normal and reacting. Her vision had improved. So when she came in, she told us that she couldn't see anything. So from her description of her symptoms, it looked like she was totally blind when she came in. But when she waked up after 5 to 6 hours, she told us that she could count fingers up to a distance of a meter. So there was a visual deficit, but her vision was improving as well. So that was a good sign. And she had a reduced peripheral vision on the temporal side on her both eyes. Other than that, her eyes movement were normal. The cranial nerve examination was normal. She had no motor or sensory deficits, and her reflexes were also normal. Overnight, her stay in the ICU was uneventful, except for an episode where she had a headache, which was managed with paracetamol. And since she was stable and she was alert, conscious, and had no neurological deficit, she was shifted to the ward next day. And while she was shifted to the ward, she was still having blurring of vision and a mild occipital headache. So the ophthalmic review was done on 31st of August, which was 5 days after she presented with the blindness. Her visual acuity on both eyes was decreased, and it was 6/60, both unaided and on pinhole. But other than that, her intraocular pressure was normal, pupillary reaction and fundus were also normal, and they couldn't find any obvious ocular pathology. And because since he was having residual visual deficit, MRI head was also done, which was normal. Visual field Goldman test was planned for a future date, and she was discharged to home under ophthalmologic outpatient review. So from her records, her last ophthalmic review was done on 7th of September, which was about 2 weeks after she presented with blindness. And at that point, her pinhole vision had returned to normal. It was 6/6. However, her visual acuity unaided was 6/18 on both eyes. So she still had some residual visual defect. Goldman field test was done, which was normal, and macula and the disc oscillotonometry was also done, which was also normal. So she was discharged to optician for possible need of glasses. So about discussion about this case, in our clinical practice, especially in obstetrics unit, preeclampsia and eclampsia are very common clinical condition that we as an anesthetist deal with most of the time. Visual disturbances are relatively common in patients with preeclampsia and eclampsia, and the visual disturbance can range from blurring of vision to diplopia. However, blindness is rare and has an incidence of 1 to 3% with eclampsia. And blindness can be due to involvement of the optic pathway anywhere from the retina to the occipital cortex. So factors for visual disturbances during eclampsia and preeclampsia include cerebral vasospasm, hemorrhage, ischemia, edema, and as well as hypertensive and metabolic encephalopathy. Recently, loss of autoregulation of posterior cerebral circulation as a cause of visual deficit also has been postulated. In past, blindness associated with preeclampsia was mainly attributed to retinal pathologies like edema, vascular changes, or detachment. However, nowadays, more emphasis is being placed on the cortical blindness. So a cortical blindness is a condition in which is characterized by the intact pupillary response and normal colonoscopy findings on a background of a blindness, recent onset blindness in a patient with severe preeclampsia or eclampsia. The exact mechanism of cortical blindness is unclear, but it has been thought that it might occur from cerebral vasospasm or ischemic injury or from vasogenic edema. Previously, it was thought to be associated with the petechial hemorrhage and focal edema in the occipital cortex. However, recent scan, they have showed that elevated capillary permeability and vasogenic edema might play a role, might be a major role in patient with cortical blindness. So normally these lesions are usually bilateral and are often on the posterior cortical areas on the occipital lobe. And the neuroimaging such as CT or MRI, it can range from normal finding to typical finding, which we can see here. And the typical finding would include hypodense lesion on the bilateral occipital area. And the blindness, along with the lesions of the cortical posterior cortical areas, are reversible, and usually in case of cortical blindness, vision is regained within 4 hours to 8 days. So in our lady, the blindness was sudden, and although she did recover her vision, she still had some residual visual deficit even after 2 weeks. She had no ocular pathology on repeated ophthalmic examination. Hence, she might have had a cortical blindness due to severe preeclampsia. And also, of note is also that when she came to us, she was hyperventilating, and her PCO2 was low. It was 2.9 on her blood gas. So this might have exacerbated her pre-existing vasospasm, which was present due to preeclampsia. But this is just this might be the cause, but the chances are very low. And also she was examined by the ophthalmology 5 days after the onset of her symptoms. So if the ocular changes like a papillary edema or anything like that, if they were present when she came in, then the chances are that they might have subsided after 5 days. So I think I'm
just going to give you a minute warning there. Thank you.
All right. So basically, I think it looks like the cortical edema, but we will never know what it was exactly, because the scan was normal and ophthalmologic examination was done after 5 days. But this was an interesting case, which I thought would be worth sharing to all of you. Anyways, thank you very much. Thank you, everyone. Any questions?
Yeah, thank you for that. That's a very interesting case. It sounds quite terrifying for you and the woman involved, but I'm pleased to hear it sounds like quite a good outcome. I have to say, I'm really sorry, but we couldn't see your slides moving on there. So this was that was the message I was trying to announce at the beginning. Your slides looked very nice, they looked very pretty, but we couldn't see them moving on. So I apologize, but thank you for giving your presentation as it was.
So you couldn't see my slides then?
The slides weren't moving on for us. I don't know if I presume they weren't for us or for people at home. Sorry.
Oh.
But thank you very much for that. We really appreciate it.
All right, no worries.
Okay, no worries. Thank you.
Thank you.
So thanks to all our presenters there this afternoon session for another excellent set of talks. Please remember to use the scoring polls at the end of each presentation to allow us to allocate the prizes at the end of the day. And we're going to take another short break now and then return for the final session at 3 o'clock. Thanks a lot.
Thank you.
welcome back. Thank you for joining us for our last, but of course definitely not least session of the meeting today. Our final invited speaker is Dr. Kailash Bhatia, who is a consultant anaesthetist at Manchester University NHS Hospitals and has been there since 2012. He's the research leader at MRI and has contributed to publications on rare neurological complications following obstetric neuraxial blockade, COVID-19 in pregnancy, and heart disease in pregnancy. He's a council member of the UK Maternal Cardiology Society. Outside medicine, he loves to play cricket, chess, travel, and spend time with his family. We are happy to welcome Kailash to the meeting today and to give us a Northwest perspective on COVID-19 and anaesthesia during pregnancy. Kailash, we can see you and your slides, so over to you. Thank you.
Thank you for the kind invite. I hope you can see my slides.
Yeah.
It's great to be talking at the Northeast Obstetric Anesthesia meeting. I actually am currently sitting in the Northwest, and this is the entrance of our hospital, St. Mary's, which is a tertiary center. This photograph clearly is taken pre-COVID times because you can see none of the people there are wearing any masks. The tertiary center does about 8,500 to 9,000 deliveries a year and performs about 2,700 sections a year. Now, over the next 30 minutes, I'm going to talk about COVID-19 in pregnancy. So my talk is divided into two halves. The first half talks about pregnancy outcomes from COVID-19, and I'm mainly focusing on studies published from the United Kingdom. The second half of the talk mainly deals with the anesthesia outcomes, and I'm going to talk about some of the publications which have come from the Northwest. Now, the publications here are from a limited number of hospitals from the Northwest. I do have a conflict of interest for this meeting that I've contributed to some of these publications on anesthesia outcomes from COVID-19. Now, we are 2 years down into the pandemic. So let's recap and refresh our memory a bit of this virus which has changed our lives. Now, we knew that the virus originated in Wuhan, apparently quite close to my birthday. And then cases started to steadily move over across the globe, with cases reported in Spain, Japan, France, and USA in January 2020. I think UK had the first case around the third week of January around York. The virus was named SARS-CoV-2 in February, and WHO declared pandemic in March 2020. Now, the credit for publishing valuable data on COVID-19 in pregnancy should go to UCOS and Professor Marian Knight and her team, along with all the collaborators and midwives who actually contribute to this surveillance system for this study. For people don't know that this study now has been extended up to 31st March 2022. The first study published by UCOS looked at the first 6 weeks of the pandemic from 1st March 2020 to 14th April 2020, and it included 427 women which were admitted with this virus, giving us an incidence of 4.9 per 1,000 maternities. The findings are still currently relevant, even in this probably almost 2 years down the line, with a majority of the parturients reporting symptoms in the third trimester, with fever, cough, and breathlessness being the most common symptoms. We know that it affects ethnic minorities, and this paper was one of the first to highlight that. What surprised me was a 19% general anesthesia rate was reported in this study. But if you read the paper, a significant number of women were on oxygen when the study was reported its findings. And some eye-watering numbers here, about 10% being parturients being admitted to critical care, with 1 person needing ECMO, and a mortality of 1% was reported in the study. We had less than 2% neonates testing positive, suggesting that vertical transmission was uncommon in the study. Moving on from the first 6 weeks to nearly the first 6 months, and this time they looked at symptomatic and asymptomatic pregnant patients affected by this virus. So what they found was the symptomatic group outnumbered the asymptomatic group, which came as a bit of surprise. And when you read the paper, and there's a bar chart in there, there were more symptomatic parturients reported during the initial first wave of the pandemic. So that's why the symptomatic numbers here outnumber the asymptomatic ones. What did it find? Well, it found that the cesarean section rate in the C-section rate in symptomatic patients, if you look here, you've got almost a 50% C-section rate here in symptomatic. And you compare with that with the asymptomatic group, which is around 40%. So you know that there's a significant increase in C-section rate if you are symptomatic. What also the information this paper highlighted was looking at NICU admissions rate. So you look here, 19% of neonates born to symptomatic mothers needed NICU admission. And when you go into the details of the paper, you'll notice that it's the preterm, it's mainly then increase in preterm birth seen in symptomatic pregnant women with SARS-CoV-2 that is responsible for this finding. Now, I've presented 2 papers on UCOS. I thought I should highlight this paper and this group as well. This paper comes from Professor Asma Khalil's group. She is the lead obstetrician of NMPA, which is the National Maternal Perinatal Audit currently going on. She works at St. George's, and they have a brilliant team which regularly publishes findings on SARS-CoV-2. This study has recently been published in American Journal of Obstetrics and Gynecology. And what it looked, it's a population-based study. They looked at almost 3,000 pregnant patients affected by the virus, and compared with controls were pregnant patients unaffected by the virus. So you've got almost a 1% incidence of women affected by SARS-CoV-2. What it also looked at was neonatal outcomes. So it looked at neonates born to SARS mothers, which included almost 2,500 neonates, and compared them with neonates born to mothers without SARS-CoV-2. And you can see there are almost 300,000 neonates in this cohort. What the study found was that women above the age of 30 are at a significant risk of acquiring SARS-CoV-2. Also, it found ethnicity, which was highlighted in previous papers as well. You've got multiparous women reported here, almost 46%. And what interesting finding in this paper is on how when pregnant patients are deprived, and looking at index of multiple deprivation, you have 50% of women from deprived backgrounds having a higher incidence of SARS-CoV-2. Going on to fetal and maternal outcomes, you can see that the fetal death, the adjusted odds ratio is 2.2, suggested that the risk of fetal death is twice higher in SARS-affected patients, and risk of preterm birth is twice higher as well. You've got a higher incidence of preeclampsia in this cohort. You've also got a higher incidence of cesarean deliveries, which was highlighted in previous studies as well. Both elective as well as emergency cesarean deliveries, it's fairly significant. You've also got a higher maternal length of stay and a higher maternal readmission rate in the COVID group. It also looked at adverse neonatal outcomes index actually, and it's mainly looking at a composite of these 4 outcomes, and you'll find that the neonatal specialist care or NICU admission rate is higher, as well as neonatal length of stay, and neonatal readmission is higher. Now we know that we have had multiple variants, and one variant which is not listed here is the wild type variant, which was going on before September 2020. We've had the alpha variant, we've clearly had the delta variant, and currently we are in the Omicron. We've got the Omicron variant being reported. Now, UCOS highlighted interesting findings from this study, which is still in the preprint stage. And what it did was it compared the three waves, looking at wild type variant till November 2020, and you got the alpha variant from December 2020 to May 2021, and comparing both with the Delta variant, which was going on till July 2021. And the findings are interesting. I've got a busy slide here, but I will go through it. We find that 2/3 of the patient here are either overweight or with a BMI greater than 30 kg/meter square. And you can see here with age, as you compare the variants, you'll see that the Delta variant started to infect more younger parturients, suggestive of its virulent nature. You've got the data on ethnicity again coming up here. And you've also got the big three: women with respiratory conditions, women with gestational diabetes or diabetes, and women with hypertensive disorders in pregnancy. They were clearly more susceptible to the virus. Multiparous women were were reported almost in 2/3 of the cases, especially within the Delta variant. What other interesting finding here was, as you go along, you'll see that the indicators of moderate to severe infection kept going up. So you can see here, when it comes to Delta, you have an indicator seen of moderate to severe infection seen in almost 45% of the women. And when they compare alpha versus wild type, you can see alpha is quite more potent actually. And when you look at Delta versus alpha, you can see Delta is more potent. What it also reported was evidence of imaging of pneumonia. And you can see here that 36% in the Delta group had more evidence of pneumonia on imaging. Startling figures on respiratory support also came to light, with almost 1/3 of the women needing respiratory support when the Delta variant was active. And this is reported with higher number of women on oxygen, higher number of women needing high flow oxygen or CPAP. Some more eye-watering numbers is critical care received. Critical care admission rates reached almost 15% with the Delta variant, suggesting significant virulence of this strain. UCOS also produced some fantastic infographics actually, and they continued from where they left with this paper, and they looked at this data comes from COVID women affected between 1st February to 30th September 2021. And you can see here from the left side of your graph, the number of deaths have serially gone up, as well as the number of women infected with this virus. What also startling figure was almost 14% of patients admitted to intensive care, with none of them receiving 2 doses of the vaccine. So you have 98% of patients there unvaccinated. Some simple but useful infographic again on your extreme right. You can see that a C-section rate of 43%, with 1 in 5 needing respiratory support and 1 in 10 needing intensive care, with a 0.4% mortality being reported. With newborn, the theme of stillbirth and prematurity continues in this data as well. What it also did was it produced some interesting rapid reports, and I've chosen this one because it does highlight the need of having a multidisciplinary team, maternal medicine team, for any pregnant or postpartum women admitted with C19. It also highlights that all hospitals need appropriate triage tools, escalation pathways, which hopefully should be there in your hospital too. And an emphasis was placed on ECMO if there was worsening respiratory failure. It also talked about following RCOG guidance, and I'm coming to that next. So this is the recent infographic released in December 2021 on COVID-19 in pregnancy. And you can see here that it talks about giving oxygen when the SATs are less than 94. It talks about thromboprophylaxis according to the weight, which should be continued for a minimum of 10 days. It also talks about giving corticosteroids, especially when they go on oxygen. And then it talks about the role of MDT and how they should serially evaluate the patient on a day-to-day basis, especially if needing escalation of care. The guide also talks about giving the tocilizumab or monoclonal antibodies, which are usually given for patients affected with Delta. It also talks about encouraging COVID vaccination, actually, something which the government missed telling pregnant women, and they have paid a price, unfortunately. Talking about vaccination, you can see here, I've got some reports from the vaccine surveillance, which are published on the government website. You can see by Jan 2021, hardly any woman who was giving birth was vaccinated. And come August 21, this figure increased to about 22%. If you look at ethnicity wise, you can see that BME group lagged behind white group in receiving intake in the uptake of the vaccine. And again, this message needs to go to the BME group as well about increasing uptake for the vaccine. UCOS also highlights this good infographic of making every contact count. So I feel even an anesthetist has a role here, an anesthetist which is looking at high-risk patients in their clinic, and an anesthetist which is doing ward rounds in their delivery unit to emphasize the importance of vaccine. It clearly gives you some numbers for the baby, a higher risk of stillbirth and higher risk of preterm birth, and it highlights about the information that majority of women in ICU are unvaccinated. I've shared some papers from UCOS, but these are some other papers which I will share here. So you've got the inter-COVID multinational cohort study, which was looking at data from 15 countries, which highlighted that neonatal morbidity is significantly high in symptomatic patients, especially those with respiratory symptoms. And these two papers also come from Professor Khalil's group, and they highlight the changes going on within the pandemic. Now, looking at deaths by region, I thought this is an important slide as I'm presenting from the Northwest to the Northeast group. And you can look here, Northwest leads in the number of deaths, whereas you might suggest that the Northeast lags far behind, which is actually not true, because the true figure is reflected on your right-hand side. So if you look, the rate of death per 100,000 population is 292 for the Northwest, and Northeast doesn't lag behind, probably suggesting the influence of deprived areas on deaths. Moving on to admission, critical care admission as per by region, and this data is just being published by ICNAC. I thought it gives you a useful data on timelines of the percentage of women who were admitted, who are currently pregnant or recently pregnant and admitted to critical care. It's got 3 bar charts in each region, and the gray ones represent the ones in August, whereas the blue ones represent early 2021, and you've got the latest one represented in orange. And you can see during the first wave, actually it's Northern Ireland which has borne the brunt of the virus highest. Whereas in the second wave, it's London which has borne the most burden of the virus. Whereas the third wave, it's the Midlands which is which has borne the burden of the virus. But if you look at the solid lines, you can see that the Northwest actually leads in the number of patients who are actually currently pregnant and admitted to ICU. Now let's move to anesthesia. Now, when the pandemic hit us, we were provided with some fantastic articles, and this one from Prof. Lucas was one of the picks actually published in IJOA, and again highlighting to us what precautions we should use, and the guidelines suggesting encouraging use of regional anesthesia. And the same one came from ASRA group as well, and you got Ruth Hilandu here, who's one of the popular an obstetric anesthetist from New York and Colombia, and you've got Vishal Uppal here, who is quite active on the ASRA side. And this led us to publish the first audit actually from St. Mary's Hospital. And what we looked at GA rates as per Royal College of Anesthesia standards from 1st April 2020 to 31st May. So over 2 months of data, and we compared data during the pandemic, which is 2020, with the previous 2 years. The two notable findings which come across, you'll see here, is an serial increase in section rate. You can see there's a 33% here, and a serial decrease in the GA rate, which is much more pronounced during the pandemic. And the most of the drop in GAs come from a decrease in the GA rates of CAT 2 and CAT 3 sections, with emergency sections and elective section GA rate not really being affected. This first bit of data provided us some impetus to collaborate. And what has worked here in the Northwest is this collaboration. So we looked at a bigger study now, looking at 6 hospitals in the Northwest of England, and you've got not only St. Mary's represented here, you've got Liverpool, which are the 2 big tertiary centers, and you've got a lot of district general hospitals being represented. And what you'll find is this study, which looked at almost 2,500 sections in each group 3 months into the pandemic versus a similar time in the pre-pandemic period, the GA rate pre-pandemic was 7.7%. And it dropped nearly to half. The odds ratio is half there actually. So clearly the GA rate had half during this time. What was interesting was the 76 COVID patients were in the study, and the GA rate was fairly similar. Now you'd argue what is the reason for the drop in GA rates, and I've highlighted a list here with most of the guidelines recommending regional anesthesia, and we know that a lot of consultants stepped up actually to join the rota, and that could be a factor. We clearly had a decrease in RA to GA conversion, which was a factor in drop in GA rates. But the other factors which came to light were there was limited testing for the virus. You had risk to the healthcare workers, and there were clearly deficiencies in the PPE provision. Now, the papers actually caught the attention of the 2 fantastic members of OA, who correctly pointed out that any reduction in GA rates can only be viewed successful if they do not come at the cost of increased neonatal morbidity and mortality. I couldn't agree more with them, but what we replied to them was important as well, that factors other than anesthesia could possibly impact DDI especially for category 1 cesarean section. And I've included factors here actually, which include comorbidities. We knew that mothers were taking longer to come to theatre because everyone had to be in their PPE. And clearly the outcomes would also depend on what staff were in theatre. Now, by the time they had written to us this letter, we were halfway through our other study. So this study was published about 4 months later. And what it looked at, we looked at DDIs and neonatal outcomes mainly for CAT 1 sections, because we know that CAT 1 sections, often the neonatal outcomes can be quite poor. So what we did again during the same periods, which we had highlighted a lower GA rate, we looked at 562 CAT 1 sections pre-pandemic and compared with almost similar numbers during the post-pandemic. And we found that the DDI had actually increased from 26 to 27 minutes. General anesthesia still was the quickest which is what was highlighted by Robin Russell and Prof. Lucas. And you can see here, spinal anesthesia takes the most time to act for the Cat1 section, with 2/3 of the unit achieving a DDI under 30 minutes pre-pandemic, with less than 2/3 now achieving post-pandemic, something which was significant. The good thing about was that the neonatal outcomes were not being affected by this change in increase in RA rate, which had dropped from 7.7 to 3.7%. And you can see here that all the time intervals had gone up, and especially the decision to theatre time and theatre to incision time going up. Now, whatever we've highlighted in there, we actually sounded a warning that though GA contributes to poor neonatal outcomes along with prematurity and lower gestational age, anesthetists should not be fixated on performing RA actually, as delays can and do lead to worse patient outcomes. And the decision relies on the multidisciplinary team looking after a woman needing a category 1 cesarean delivery. Now, the data which we've published now is being corroborated by other centers, and this study from Glasgow by Malcolm Broom here, it provided us similar data actually comparing a COVID cohort with a control cohort, and it found out the similar thing, that the GA rate had dropped significantly with none of the COVID cohort receiving GAs, and the DDIs were fairly similar, with neonates not being affected by this change in anesthesia technique. Now, we here actually thought that very few studies have been reported from UK about what is happening in COVID positive patients. And this study I'm sharing with you, which has just been accepted in anesthesia, which looked at almost 836 patients and what happens across 10 maternity units in the northwest of England. What we've divided is we've divided them into symptomatic and asymptomatic, and what women were using for analgesia and what did they have anesthesia for cesarean delivery. And you can see here that the epidural rate, which was recommended by most guidelines, is fairly similar, with only 1 in 5 women actually having an epidural. We've got REMI here. I think it's the first study which actually highlights that REMI can be used in this cohort, but majority are using non-neuroaxial anesthesia technique. We've also got a GA rate of just about 5.8 or under 6% reported in this study, with spinal being the most commonly utilized anesthetic technique. Another interesting finding I'm sharing with you guys is we also looked at the total number of deliveries happening in these 10 hospitals, and these included about 57,000 deliveries in total, of which 18,561 women were COVID negative, and these women had a C-section, so giving us a C-section rate of 32% in COVID negative women. When you compare this with asymptomatic women, you have 193 asymptomatic women here, and the C-section rate is about 33.7%. And you compare this with symptomatic women, and you can see that there's been a significant increase in symptomatic women having a C-section rate, which equates to about 44% in this study. We also looked at some other interesting outcomes. So PPH, there was no difference. Oxygen supplementation mainly was seen in symptomatic patients, and you can see 1 in 5 having oxygen supplementation. You got an ICU admission rate pre-delivery of about 8%, and this increases post-delivery to about 11%, with 3% of women having mechanical ventilation. And clearly this data is going to be significant. Now, how does this data compare to data from other studies? So you got a big study from US, which is a case control study. And this again is from New York Columbia Group. And you can see here that in US, almost 80% of women were having labor analgesia, but 88% were also having those who were not having COVID. So clearly in US, epidural is used as the predominant form of pain relief. Their GA rate was nearly 9%, 8.5%. But when you look at the data carefully, you'll find majority of the women who had a GA were having respiratory failure. This study from France, looking at 126 women with COVID-19, gives us some more useful data of what's happening with COVID women actually during pregnancy. And you look here, the C-section rate here is 52% in France. You've got renal failure being reported, which is 7% down there. You've got a GA rate of almost 17%, and you've also got difficult intubation being reported in 18% of women, something which we didn't have actually. Now, if I have to highlight whatever I've said in one slide, this is the slide you'd want to know and you'd want to share about what is actually happening in COVID women from the obstetric point of view, as well as from the anesthesia point of view. So I've included here the risk factors, the morbidity, the mortality, you've got neonatal morbidity, and the gist of what's happening from the anesthetic side is highlighted here. There were other things going on as well, which include an increase in virtual consultations and decrease in antenatal attendances. So what 5 messages do I have for you? First of all, COVID-19 is associated with poor maternal and fetal outcomes. And when you compare them with pregnant women without COVID-19, or you compare with non-pregnant women, the outcomes are really poor. Secondly, you have non-neuroaxial analgesia regimes being utilized for labor. That is the most commonly analgesics being used here. You've got spinal anesthesia as the most common technique. I think the key message which anesthetists also need to drill along with the obstetricians is pregnant patients need to be encouraged to take up the vaccine and make each contact count. Lastly, but not the leastly, we've seen the power of collaboration actually in the Northwest, and we need more studies to inspect detailed anesthesia outcomes in this cohort actually. And I'll end my presentation here.
Thank you very much, Kailash. That was a very interesting talk through through a lot of detail into your studies into the outcomes of COVID-19 in the Northwest. Do we have any questions from the floor? I didn't quite see it. There was just the thought that crossed my mind was to ask you what you thought was the most, or maybe the top 3 most important kind of takeaway points that have been that way, changes that have been made going forward, and maybe the post-pandemic days from the most important lessons that have changed our practice that you think can continue.
Probably first is clearly we know that GA rates have gone down. I think I'm sure if they've gone down in Northwest, they have gone down in other places as well. What our study lacks is, has the drop in GA rate produced the substantial benefit to women? So that needs to be looked into, that needs to be researched into. I think the second one still is about vaccination. The third one is, why is the epidural rate low? I think in the paper which we published, our paper was not investigated to highlight the low epidural rates and why they were low, but that needs some investigation, isn't it, about why is it low? Is it because anesthetists were scared to actually provide epidurals to women, or is it just following a pre-pandemic trend, which seems likely, because when we compared some data with before the pandemic, we thought that the epidural rates were fairly similar to what was being reported before the pandemic started. So, okay. And the easy availability of non-neuroaxial regimes like midwives and, easy to give Entonox and easy to give IM injections. And that could be a contributory factor. I think the presence of, we saw the benefit of consultants being on the shop floor. I'm sure it was difficult. I'm sure it was difficult actually for everyone. Yes, so that was an interesting one, and it probably needs to be seen whether that will happen in the future.
Yeah, well, we can, we'll see. Thanks again for that. I really appreciate that.
Thank you. So our next speaker this afternoon is Dr. Justin James. He's going to be talking to us about high BMI referrals. Justin completed his MD and anaesthetic training in India in 2011 before moving to the UK, and has since worked in Bedford Hospital since 2017, working as a senior clinical fellow. Justin, I can see you, I can see your slides, so we'll hand over now. Oh, Justin, I think he's just gone down for the moment. He was back with us. I think one of the things we were discussing earlier, wasn't it, is at what stage we'd see patients with a higher BMI in our high-risk clinics, and whether there might be some variation between that as it's the first baby or a subsequent delivery. Yeah. And perhaps the added challenge we're starting to face with the increasing BMI among pregnant women, indeed the general population, and how much that might be impacting on our anaesthetic work. So perhaps the high BMI patient will become something more of the normality rather than the extreme as we move through that.
Okay, so I think what we'll probably do is just move on to the next speaker, and we'll give us a bit of time to sort out the tech on Justin's presentation there. So the next speaker is Dr. Omnia Raska, who will be giving us a case presentation on Horner syndrome. Omnia has 20 years experience in anaesthesia, having graduated and finished her training in Egypt, where she worked as a consultant for 3 years. She then moved abroad and worked in 3 different countries, including Saudi Arabia, Ireland, and the UK. Her main interest is obstetric anaesthesia, and she now works as a specialty doctor in anaesthesia and intensive care at the Chelsea Westminster Trust in London. Omnia, we can see you and we can see your slides, so over to you. Thank you.
Hi, everybody. It's nice to be here with you today. Today, I just like to talk about a case that I've had a few months back. It was a Horner syndrome following neuroaxial block. Horner syndrome actually is a rarely reported complications following neuroaxial block. That's why its exact incidence is probably unknown, but it is probably higher in pregnant women in comparison with the general population. And as we all know that it is caused by sympathetic block at probably the level from C8 till T2. But whenever it happened, it caused lots of anxiety for the patients, for the midwives, and even for the anesthetic doctor, because probably we're not seeing it very often. But the good thing is that it is usually a benign phenomenon that it will resolve spontaneously within just a few hours. And I think the take-home message for today, that if we have had a Horner syndrome complication followed when our neuroaxial block, we shouldn't discontinue the neuroaxial block, unfortunately, not as I did in my case. So I was just on call. I was called for epidural as usual in a busy labor ward. It was very straightforward epidural. I did it about 10:30 nighttime, and it was very straightforward. Just I've got the space at 4 centimeters. As my usual practice, I left 5 centimeters inside, and I topped it up with, loaded with just 10 mils of bupivacaine from our low mix solution that we use in our labor ward. And I have no issue at all. I didn't expect anything from that patient, but unfortunately, about 2 hours later on, the midwife called me because she noticed some ptosis in the right eye. So I went there, examined the patient. Definitely there was a ptosis in her right eye. The right pupil was about 3 millimeters, and it was reactive to light. So I started by checking the level of the block, because I thought that probably the level is too high. But when I checked the level, it was just T10 bilateral. The right leg was probably heavier than the left leg, because the left leg has no motor block at all. It was full motor power. checked the blood pressure, no hypertension, no desaturation. She was definitely spontaneously breathing in room air. And I've started to check any other cranial nerve affections. There was no other manifestations of trigeminal or hypoglossal or any other kinds of very high level of block. And there was no blurring of vision or any arm weakness or anything that can suggest that the block has gone very high. I was lucky that the patient was so comfortable at that time. And because of all the panic around, I've decided just to stop the epidural and just to see, check what's going on. So I've stopped the epidural. And as we usually do in this kind of cases, I've asked for medical consultation. And the medical registrar, when he came in, his impression was it's just post epidural Horner syndrome, as I thought also. And he suggested that if the symptoms persist more than 24 or 48 hours, then at that time we should do some brain scanning. Luckily, after 2 hours, no symptoms at all of the Horner syndrome. So I decided, okay, I'll just resume the epidural because that woman was really progressive in labor. I was lucky enough that I didn't have to take that woman to theater. She delivered nearly by the end of my shift, around 7 o'clock in the morning, Kiwi delivery at room, and she was very satisfied and happy, and she had good epidural block throughout. When my colleagues checked her the following day, there was no signs at all of Horner syndrome. This is what happened with my case. So I've decided just, okay, I'll just go back to the literature to see what's going on with this case, because to be honest with you, this was my first case to see such complication with epidural. When I looked back to the literature, I found a very nice systemic review article published about Horner syndrome cases following the neuroaxial block in obstetrics. So it was very specific, whatever I was looking for. They've looked into the whole literatures published from 1972 till 2017. They found only 78 cases reported from Horner syndrome. 3/4 of these cases, the symptoms and signs noted within an hour of the start of the block. And it didn't last long in many of these cases, just for about 2 hours. Even in some cases, the symptoms disappeared in spite of continuation of the local anesthetic, the epidural local anesthetics. But there was some serious thing that they noticed hypotension in 13% of these cases. They found that this kind of complication happened mostly with the epidural blocks, and most of these epidural was for labor analgesia, not cesarean sections or post cesarean section or whatever. But they found it also with some caudal blocks. They found it with CSEs. They found it also with just single shot spinal anesthetics. Checking the patient demographic, most of these cases was unilateral, but it happened in multiples and primary gravida, all types of deliveries, normal, instrumental, cesarean section. They found there was not only Horner syndrome, but there was also some trigeminal nerve palsy in 8 from these cases. And in one case also, they found trigeminal and hypoglossal nerve palsy. As I mentioned before, that they found hypotension in 13% of these cases. Also, some other signs also was notes like blurring of vision, some arm weakness, some sensory disturbance in the arm, some neck pain, and most of these cases, they found that the sensory block was above T4. It happened with all types of local anesthetics. So it's lidocaine, bupivacaine, levobupivacaine, chloroprocaine, and they found it with different types also of administrations, either boluses or infusions, with all concentration also, either higher concentration or low concentration, with different volumes also, ranged from 8 mils to nearly 300 mils, but the average was about, the median was 18 mils. Timing wise, most of these cases just within 1 hour resolved within 2 hours, and I don't want to repeat myself for this. This is again for the laterality, most of it unilateral. Level usually it's T4, but systemic hypotension is not very low. It's about 13% of these cases. That's why we should always check the blood pressure for these patients. So as I mentioned before, that Horner syndrome is higher in, the percentage is higher in pregnant patients. So we'll just go back to check what is the sympathetic innervation for the eye. It is a 3-order neuron. So the first order neuron is the central sympathetic fiber, second order neuron is the preganglionic fiber, and the third order neuron is the post ganglionic fiber. Neuroanatomy is a bit tough, but the first order neuron is from the posterolateral of the hypothalamus, descend uncrossed to the midbrain and bones, so in the same side, and then it terminates in the spinal cord at the level of C8 till T2. Second order neuron, after they exit the spinal cord at the level of T2, they enter the cervical sympathetic ganglia with the close proximity to the pulmonary apex and to the subclavian artery, and then they synapse with the superior cervical cervical ganglion at the level of the bifurcation of the common carotid artery. And then the third order neuron, this postganglionic fiber, they exit the superior cervical ganglion, go with the ascend with the internal carotid artery. And this is actually important because in one of the cases, it was due to dissection of the, not my case, but in one of the reported cases, it was the Horner syndrome. It was prolonged after 48 hours, and it was discovered due to dissection of the internal carotid artery. That's why this neuroanatomy is properly important. And shortly after the postganglionic fiber, they leave the superior cervical ganglion, and then with the external carotid artery, they innervate the blood vessels and sweat glands of the face. So the interruption of the sympathetic fiber can happen either centrally or peripherally. If it's centrally, so it will between the hypothalamus and the exit from the spinal cord from C8 till T2, or it can happen peripherally after the superior cervical ganglion all along the carotid artery. So we'll go back to the question, why the percentage is higher in pregnant women. First of all, because there are some factors that will promote the cephalic spread of the local anesthetics in pregnant women. We all know about the difference in the anatomy between pregnant and non-pregnant women. So there is narrowing of the epidural space with the venous engorgement and increase the volume of connective tissue. And there's further even increase in the epidural pressure with the uterine contraction and with the effect of drugs and with obesity as well. Also, there is increased sensitivity to the local anesthetics due to the progesterone effect during pregnancy. And in some women also, there's some anatomical variations that can lead to higher incidence of Horner syndrome as presence of septa, or if the sympathetic fiber originated from the level lower than the T2 as low as even T4. And sometimes the difference also in the anatomy between the right and left side, that's why usually it is unilateral. So anyway, we'll go back to our anesthetic management. So whenever we will have this case, definitely the anesthetist should be notified, and then we'll go systematically through assessment for airway, breathing, and circulation. Specifically, we should look for any higher levels of block, any presence of hypotension, especially that it can affect the fetal well-being also. And
apologies, I'm just going to give you a 1 minute warning there. Thank you.
Yeah, thank you. We should rule out any intrathecal or subdural block. We should discontinue, check also the sensory level. Should we stop it or not? Actually, we shouldn't, but this is on individual basis. We'll see if it's just Horner syndrome alone, we shouldn't discontinue, and we should also follow up after delivery. And if it persists, we should do full neurological referral and some assessment, further scanning. The other question is that what if we have to take this patient to theater? The conclusion is that if it's just Horner syndrome, again, without any other cranial involvement or hypotension, we can still use this epidural catheter. If it is happened with epidural catheter in situ, we can still use this epidural catheter for top-up and for cesarean section. And thank you, everybody.
Great, thanks for that. We've heard a couple of reports of Horner syndrome recently, actually. I think there was one in this meeting last year, which is unusual, but reported. And you, Jen and I were just discussing that. What would you do with the epidural? What would you do for the anaesthetic if you had to take the woman to theatre? And I think you've answered that. You can use it if it's just a Horner syndrome.
Yeah, if it's just a Horner syndrome without any, so we are 100% sure that it is not intrathecal or subdural or very high block, then still we can use it as our anesthetic supplement. Yeah.
I would still feel a bit scared, but I believe you. Thank you. We'll open the poll for that presentation. Thank you very much, Ahmed.
Thank you.
Okay, thank you. And I think we have Justin James back again for his presentation on high BMIs. So we'll just give a moment for your slides to appear on the screen again, Justin. And I think you're still with us. So we'll just give them a moment to appear on screen, Justin. And then we'll hopefully be able to start the talk on high BMIs. Have we lost Justin again?
You can see the slides.
The slides have now appeared, and I think hopefully Justin will be around. He's been on screen with us. I know he's there to do the talk for us. We'll see if we can manage to get everything to marry up. Okay.
So, one of the questions I had earlier on was mentioned. One of our speakers earlier was mentioned remifentanil PCAs, which is a constant a source of conversation in my institution. I don't know what you have. You got any thoughts about them? Have you?
So I think sometimes as trainees we've sort of discussed these, that there seems to be a bit of variation between different trusts as to how much they do them, from the sort of don't get mentioned, aren't part of your anaesthetic programme at all, to those that are sort of much more keen and will sort of have them. And I think certainly outside of this region, perhaps there's some sort of centres that actually run it an awful lot more. I know you're saying within the RVI it's not sort of particularly an anaesthetic choice or an analgesia choice.
No, it's there. So we use, I think we use the Ulster protocol, which is probably the most widely published. What I suspect is the case is that places who do it all the time will get very good at it, get used to managing the routine of it, get used to managing the complications of it. Places who don't do it very often don't do it very well. So we can offer it just about, but I wouldn't be confident we can offer it at high quality.
I guess same with a lot of things, that once you're happy doing it in the hands of the people that use it a lot, it's there, it's a skill that you're all keen to be getting on with. Okay, we've unfortunately seemed to have lost Justin again, so we'll move on to our next speaker and then see where we can go with that. So I'm pleased to introduce our next speaker to you then. We have Dr. Cassandra Ferguson joining us. So final talk of the day, it may or may not be, we'll see where we're at. Cassandra graduated from Leicester Medical School in 2010, has moved around the country a bit, working in Cambridge, Manchester, the west of Scotland, and is now a senior anaesthetic trainee working in Edinburgh. Before medicine, she studied psychology in Glasgow, and growing up, she's lived in Italy, the US, and Germany, so very well travelled. Her main interests are obstetric anaesthesia, maternal medicine and perioperative medicine, but she would consider herself something of a generalist. Outside of work, she enjoys spending time with her family, running and outdoor swimming. Hats off to you at this time of year. Cassandra, we'll wait for your slides to appear on screen. I can certainly see you. Just give a moment for your slides to appear and we can hand over. They're coming through. Just a little bit of an order change. Sorry, it takes a moment or two just for everything to catch up, moving the slides around.
Still can't see your slides there, Cassandra.
I'm just attempting to, I've clicked to share them. Just one minute, please.
No worries.
I think we're starting to get a little.
I think this should be there.
Yeah, the computer is saying that they're about to start showing. There we go. If I can get you to pop those to full screen view.
Absolutely. Is that good?
Lovely. Great. Perfect. Thanks very much. We'll hand over to you.
Fantastic. Sorry for the slight delay. Yes, good afternoon. Thank you very much for welcoming me to the conference today. I'm going to be presenting an audit looking at the post-operative cesarean section analgesic protocol that has been used at the Victoria Hospital in Kirkcaldy, which is a large district general hospital in the southeast of Scotland. And in the last wee while, we've changed this protocol to try and improve patient experience. And that's what our survey was looking into. So the background to this work is emphasized by the fact that the global cesarean section rate is rising and has more than doubled since 2000. Worldwide, more than 30 million cesarean sections are performed annually. And this means that, that a similar number of women are affected by moderate to severe postoperative pain each year. So adequate pain relief is really important for these patients, and it should be provided not only to improve patient well-being, but also to reduce morbidity, such as reducing the incidence of venous thromboembolism by improving mobility, and to facilitate neonatal care and the mother-child bonding experience. Studies have shown that when post-cesarean section analgesia is suboptimal, that this can have serious implications, both in terms of morbidity, but also on things like the development of chronic pain, the use of chronic opioid consumption, and difficulties establishing bonding with the infant and the establishment of breastfeeding. So previous work at RDGH looked into patient satisfaction, which showed 32% of patients were unable to tolerate the postoperative analgesic regime that was prescribed at the time due to side effects. So this indicated that there was significant need for improvement. So following a change to our postoperative cesarean section analgesia protocol from the use of regular tramadol to regular dihydrocodone, we decided to reassess patient care and satisfaction. So the way that we did this was to carry out a prospective face-to-face and telephone survey of all patients undergoing cesarean section in our hospital over an 8-week period. And that included all the elective cesarean sections, but also the emergency cesarean sections. So patients were interviewed within 48 hours post-operatively on the ward. And then thereafter, they were telephoned at home within the first 2 post-operative weeks. And the data that we collected was looking at the inpatient post-discharge analgesia, and also looking at pain relief satisfaction, both in hospital and following discharge, the duration that patients were taking their analgesic medications, any side effects they experienced, and also any delays to discharge. So we were able to capture data from 43 patients in hospital following their cesarean section. And of these, 29 were successfully followed up post-discharge. As you can see, the majority of patients received neuraxial anaesthesia. That was 41 out of 43. And all of these were given intrathecal epidural diamorphine. 2 patients had a general anaesthetic, and both of these were given a morphine patient-controlled analgesia pump for the first 24 hours. All of our patients were prescribed and took regular paracetamol, and they were all but 2 were also prescribed and took regular ibuprofen. And of these 2 patients that were the exception, this was because of patient factors that meant they avoided non-steroidals. And we were pleased to see that our patient satisfaction scores improved with our new protocol. So 79% of our patients were very satisfied with inpatient analgesia compared to 58% with the previous regime. And as you can see here, we also had reasonably good rates of satisfaction with analgesia after discharge, with 86% of our patients reporting to be very satisfied with their postoperative excuse me, analgesia at home following discharge. So one of the things that we were really interested in was whether or not there are any factors that meant patients were unable to tolerate the analgesic medicine, given that had been a significant problem with our previous experience of tramadol. So only 3 patients reported being unable to tolerate postoperative dihydrocodeine. One of these had tramadol from the start because she was allergic to dihydrocodeine. One found dihydrocodeine to be ineffective, and so was prescribed tramadol instead after the first day, and one suffered significant nausea with dihydrocodeine and therefore sought an alternative from her GP following leaving hospital and was given tramadol. And the main side effects that were reported in hospital by our patients were pruritus, experienced by 16% of patients, and also nausea, which was only reported by 2% of patients, but we noted that at least 16% had at least one antiemetic in the first 48 hours. Following discharge from hospital, the main side effect reported was constipation in 14% of patients, nausea, and a small minority reported feeling shaky following taking dihydrocodeine. Our definition of sort of delayed discharge was of being discharged more than 48 hours following the cesarean section, and all but 6 of our patients were discharged within this time frame. And for the 6 who stayed longer, 4 of these were due to complications with the baby, and 2 due to obstetric reasons. So none of our patients were kept in because of anaesthetic or pain-related reasons. So we also asked our patients if they were still taking their analgesia at the time of their telephone follow-up, and if they were taking this regularly or as required. And we found that a majority of patients, 79%, were still taking analgesia 7 days down the line from their cesarean section. And quite a sizable amount, 34%, so more than a third, were taking this regularly, 45% as required. So we were pleased to see that our new local analgesia protocol showed improvement in patient satisfaction and also tolerance of pain medication, both in terms of patients being able to continue taking their analgesia medication and the reporting of side effects. We decided not to carry out patient pain scoring in our survey, as this has been found to not always correlate particularly well with patient satisfaction scores. And in fact, it's been shown that imperfect analgesia is not necessarily related to the subjective perception of satisfaction. We do note that there is still considerable variation in analgesia requirements between our patients, and that most women are still requiring analgesia a week down the line after cesarean section. And therefore, we've had conversations with our pharmacy department to instruct them to provide at least a minimum week's supply of analgesia when patients are discharged on postoperative day 1 or 2. We were also interested to know whether or not our local practice was adhering to recommendations by national bodies such as NICE. So we're looking at the NICE guidelines in 2021 for caesarean section care. So we were pleased to see that all of our patients receiving neuraxial anaesthesia received intrathecal or epidural diamorphine. They all got regular paracetamol, and they were all prescribed regular non-steroidal unless contraindicated. And all of our patients were given regular prescriptions for simple analgesia and not just as required. Our main side effect reported, as I mentioned, was constipation, and we note that NICE recommends that all patients should be considered for laxatives when taking opioids, and that this should be taken into account. And laxatives should be made available for the duration of dihydrocodone treatment, and this is something that we're intending to sort of look at in terms of patients to take home prescriptions as well. Thank you very much.
Thank you very much, Sandra, for another very interesting talk for us. Thank you. Just to change the order ever so slightly, we're going to open the poll for Cassandra's talk just now, and then do the questions, just to give you all a fair chance to get that poll in for Cassandra. So if you could all do that just now, and then we've just got a couple of questions to go through there. So your survey had a number of general anaesthetic caesarean sections there. Within your institution, what do you do in terms of local anaesthetic? So plain blocks, wound catheters, that sort of thing for general anaesthetic patients?
That's a very good question. Unfortunately, at this time, we don't have a standardized approach. The two patients in the survey received local anaesthetic wound infiltration from the surgeon. However, there was a study that came out in anaesthesia, a review that came out in anaesthesia last year, the prospect review of caesarean section analgesia, which indicates that there is a role for either local anaesthetic infiltration in the form of wound catheters or fascial plain blocks, such as tap blocks, in patients who are, for whatever reason, are unable to receive neuraxial opioid. And this is something that quite a lot of my colleagues are interested in trying to roll out as a more standardized approach, because I think particularly when it comes to things like tap blocks, the incidence of complications is quite low, but there's definitely an improvement both in patient satisfaction scores and also in the use of rescue analgesia.
Okay, thank you very much. We also wondered, did you consider sort of evaluating your patients' expectations of pain post-caesarean section to see how well they were prepared, what they might expect to feel after they've had a caesarean?
Yes, we did. We thought about that at the time after having sort of started the survey. I think that would be something that would be really interesting to look into. In NHS Fife, we instituted what we call sort of caesarean section school for the elective caesarean sections, which takes the form of providing patients with a video of the patient journey, but also certainly pre-COVID times and sort of trying to bring it back in now, attending hospital beforehand to speak to a range of multidisciplinary health professionals. And one of these would have been one of our anaesthetic colleagues to discuss things like expectations of pain and what to expect in terms of pain management, both intraoperatively and postoperatively. And I think that certainly when it comes to the vast majority of hospitals now, there's been a significant move to the enhanced recovery model for postoperative care for caesarean section patients, and managing expectations is a really key feature for this in terms of being able to get patients returning to their normal function, bonding with baby, and being able to leave hospital in a timely fashion.
Thank you very much.
Thank you.
So thank you for stepping in. We've changed the order there ever so slightly. Thank you very much.
Thank you. Thanks.
So yeah, I'd like to apologise. We're not going to be able to bring you that final presentation, which due to technical issues we were unable to retrieve. So that is going to bring us to the end of our programme today. I'd like to thank you again to all of our fantastic speakers for taking the time to educate us and share the project and cases with us here today. It is really fantastic to see the work that's going on regionally and nationally to share and collaborate. Thank you especially to the keynote speakers for their incredibly educational talks and views on what's happening on a national level. We really do appreciate it. Also, in addition to the speakers, we'd like to say thank you to all of those behind the scenes, including our tech team here today, who've made this second annual Northeast Obstetric Anaesthesia meeting possible. We'd like to especially thank the Anaesthesia Learning in the Northeast, or A-Line, for facilitating and hosting this event, as well as Peri-partum for their kind sponsorship. I would just also like to take the opportunity to publicise another A-Line meeting that is coming up soon. So that is the annual education meeting that will be taking place on the afternoon of 26th of April. It's Tuesday, the 26th of April. Booking is free of charge. You can find that at a_line.org. We will be covering some key topics, including training, improving portfolios, and top tips on expert presenting from an international expert, no less.
Booking's open now, so get on the website and get your place sorted.
And we have the results in on the presentations, and so that's our last job before we go to present the prizes. So we've totted up the scores, and Jen, do you want to take?
Yes, I feel I should do a little drum roll here. There we go. That's our technical drum roll in the background. So we'll go in reverse order. We're actually going to do a fourth place because we've got joint second. So in fourth place, congratulations to Sarah Todd for the talk on postnatal analgesia.
Joint second place, we have Nathan Griffiths on maternal transfer and Deborah Moore on cerebral venous thrombosis. Congratulations.
And in first place today, congratulations to Steve Manning for his talk on maternal cardiac arrest management.
Congratulations to all of those receiving prizes. Well done.
Well done. Excellent. So finally, just on behalf of the organisers, thank you very much to everybody who's joined us online today. It's been a real pleasure to host a national online meeting from here in the beautiful Northeast. After the meeting today, you should receive an email which will have a link for feedback to this event. We're obviously Neoam is very early in its development. Your feedback is invaluable for our future meetings to ensure we're able to continue this event in a valuable and educational meeting for anybody with enthusiasm for obstetric anaesthesia. You should also receive an attendance certificate via email. So we hope you've enjoyed today. I certainly have. It's been a really, really interesting and enjoyable day. We wish you a pleasant evening. Bye for now.
Goodbye. See you next year.